Good morning. Sorry for my voice. Just recovering from viral. Thank you, Ashish. Again, it's good to back to Jabalpur. I think my third or fourth visit to Jabalpur, and your academic program has been really good always. So, what I discussed yesterday about monoportal discectomy, uh, this talk is basically evolution. It's basically for the youngsters to evolve into endoscopic discectomy. I have taken some literature also in that, and how I learned it and how I proceeded. Uh, in the absence during our time of any major workshops and anything to teach you, so everything was a self-learning process to how to evolve. So lumbar disc disorders, everyone know different type of things. But the last point I wanted to tell about is chemical irritation and inflammation. So many a time you find neurologists giving steroids in cases of acute lumbar disc prolapse. So is there a role of that? Though there's no evidence which suggests that, but we know that in these cases temporarily if you give a transforaminal where the protrusion is not significant but there is an acute pain, a transforaminal injection sometimes or epidural injection sometimes helps for the next 3 months by the time the healing process comes in. So that role is still there and we cannot dismiss it out. When you talk of disc protrusion, should you remove the whole disc or only the extruded portion? Again, many people try to do a complete discectomy just to prevent a recurrence. But for minimal access surgeries, endoscopic surgeries, we have seen that a good removing the sequestered and not opening the annulus too much is also sufficient in these patients. Important is not what you do in discectomy. Important is what to treat, when to treat, indication, and which procedure to adopt. All the procedures available are complementary. They don't supplement each other actually. And the cost benefit of all of these procedures. When we select a patient, all these things have to be taken into consideration. Is it a recurrent? Is there any evidence of epidural fibrosis? Is there a incomplete decompression which has been done? And poor patient selection for surgery is the most important cause for failed back syndromes. And too much of discectomy leading to osteomyelitis infection. And important thing we cannot deny is smoking. Smoking is a very big risk factors for all these acute disc prolapse which has to be taken in consideration. When we go with a poor patient selection, we may land up something like this. You go out for a good cosmetic surgery, but you land up in a poorer outcomes in these cases. Different surgical options are there, and as I mentioned yesterday also, the two differentiating between two types of procedure, one is a dry field technique and another most of things are wet field. The vision in a dry field, the vision what we get is always superior to a wet field. Wet field may help in clearing the blood and keeping the field clear and for your surgery, and these coagulation things many times you avoid. But if you look at the vision which we get in a dry field is much superior to wet field techniques. So these are some of these things, uh, literature where they have done comparison MED versus endoscopic disc surgery. Uh, though long-term outcomes in both the things were same, the hospital stay was slightly longer in microdiscectomy compared to percutaneous discectomies. Similarly, this pain score was slightly different between microdiscectomy versus an endoscopic discectomy. When we talk of the learning curve, they compared transforaminal to endoscopic, full endoscopic discectomy. The learning curve for transforaminal approach was steep and easy to learn. It was steep, but you can learn it. While the learning curve of interlaminar approach was flat and it's very hard to master. So it's not that the interlaminar discectomy is an easy thing. It is also difficult, but you have to master it. This was between a learning curve for interlaminar endoscopic discectomy. It was a systemic review which was seen. So as the volume increases in your place of the discectomy, your duration of surgery and the outcome slowly becomes better. They compared the initial experiences with the late experiences. They found that the volume increases, the outcomes becomes better actually. Surgeon learning curve for transforaminal, when we talk of these things, it is safe and initial good amount of supervision is required compared to an endoscopic interlaminar discectomy. And, uh, and the need for experienced mentors in the initial phase of your career is mandatory. This is the learning curve you can see. For a percutaneous endoscopic discectomy, you reach a mastery by at least doing 50 to 60 cases. That's a time when you achieve a very optimum result in endoscopic discectomy. Why conventional surgeries or laminectomy was familiar? Because during our training time, this was the basic teaching for any neurosurgeon, that they are taught about laminectomy and discectomy and these things. So when we come into practice, it was easier for us to adapt to these things, and we continue with that. But staying in that, it was not the option. We have to always evolve in understanding of these things. Extensive dissection leads to a relative violation of the stability of the spine, especially when you add, I know some of the older teachers used to talk about wide laminectomy for any lumbar canal stenosis. So when you talk of wide laminectomy, means it includes both the facets also. So they can cause, and we have seen long-term results where they'll end up in spondylolisthesis and these cases. So why minimally invasive surgery? Smaller incision, less tissue disruption is two main aims actually. And surgery, less tissue damage, less pain and function. So MIS has bought into less pain and better functional outcomes. So comparing surgically invasive between microdiscectomy and three different endoscopic discectomy techniques of lumbar disc herniation. The percutaneous endoscopic lumbar discectomy, that is the transforaminal, cause the least muscle injury and reduce the postoperative back pain and hospital stay duration. How did they evaluate it? They took the CPK and the CRP levels in all these patients who underwent microdiscectomy, interlaminar endoscopic discectomy, and the percutaneous endoscopic discectomy. And microdiscectomy has the highest CPK and the CRP levels compared to all other procedures. Here the comparison of percutaneous discectomy versus lumbar microdiscectomy. No superiority exists between the two surgical approaches when it comes in terms of long-term outcome. So all are good, but we have to consider all other factors in these things. When you talk of microdiscectomy, that's how I started my journey with microdiscectomy. Because we had the microscope, we were used to trained under microscope, we were never trained under endoscopes. And a neurosurgeon's comfort zone is always a microscope with both hand techniques and you see it. This was again CPK levels compared to lumbar disc surgery. So for me, the evolution of started from 2002 when I finished my MCH. Started with laminectomy, hemilaminectomy, interlaminar microdiscectomy. Then in 2008, I started doing the Destandu's technique actually. Started with extruded and contained disc herniation, then migrated disc, interlaminar bilateral decompression, then two-level discectomies and redo cases. That is from 2008 to 2025. Good 17 years I spent with Destandu's technique. Then thought that let me move to the pure endoscopic interlaminar discectomy. So step by step, discectomy, decompression, cervical is slightly difficult. Cervical, we take it in the later part. And then comes multiple level discectomies and fusion. So your incision basically has become smaller to smaller as you have learned it actually. And you realize that these things, these big openings and big things are not required really during your surgery. The Destandu's technique, the indications are same as a microdiscectomy. And proper patient selection and all other advantages of this thing is there. And it's a workhorse still for many surgeons in the country and worldwide, the Destandu's technique. The steps, I will not go into this. Is a stepwise how you mark it and do it. Docking of the scope and sheath. A simple case of this is done way back in This is one of my initial cases, 2008, of a descendo endoscopic discectomy. With that scope and these things, the vision is quite clear, and you remove a big fragment of the extruded disc. I, and usually to prevent post-operative epidural fibrosis, I used to place a piece of epidural fat which I had removed during discectomy back there actually. Similar cases of endoscopic. Again, these are old videos. So you can get a big chunk of disc which comes out. Average duration came down from 1.5 hours down to 45 minutes. I found out that the sheath helped in obese patients. Compared to a retractor, the sheath was very helpful. A tubular retractor or a sheath helps you very much, especially in obese patients. Similar cases, endoscopic discectomy. By the time the optics have improved over a period of time, same way, removing the extruded disc. So what happened when there is a bleeding in destandos? As neurosurgeons, we already had the microscope in our back. So whenever there is an excessive initial phases, excessive epidural bleeding, keeping the same sheath in place, like a tubular retractor, I used to just remove the scope and the inner trocar and then proceed with the sheath is the same, through which we are doing the microdiscectomy. Those epidural bleedings and these things which used to happen, we wanted always, because your scope used to get soiled by that excessive venous bleeding. The sheath is there, you can see that. This is the descendus sheath through which we are doing a microdiscectomy. And you can comfortably continue with the same surgery. We had an experience, this was the data I annotated in 2018, but we have more than 350 cases of descendus technique. We compared it with microdiscectomy and descendus technique. And we had our issues with dural tears, CSF leak, infection, conversion to microdiscectomy in 20 cases through the same sheath, and fresh deficit and redo surgeries for these things. Outcome was fairly excellent and good in majority of the cases, both ways, whether endoscopic or microdiscectomy. So there's another school of people who used to use the tubular retractor in the matrix system. Many people must have been familiar with. It's almost the same thing, except that instead of an endoscope, we are using a tubular and a microscope. The docking and everything, the principles of microdiscectomy is almost same there. Each had its limitations, sometimes two-level prolapses, bilateral, and multi-segment stenosis had its own limitations. The then disadvantage, what was taught to us, the steep learning curve, hand-eye coordination, and lack of tactile feedback, what we get in these things. So doing it over 17 years of endoscopic discectomy, so I felt slight that there was some setting of monotony in the practice of doing a discectomy. That's how we moved to the monoportal endoscopic discectomy, because that was the next migration which you could look for an interlaminar procedure. And it was very, very easy to adapt to that actually. That's the time when I moved on to the monoportal discectomy as late as 2025 actually. So I don't think age is a criteria for learning anything. And same cases, discectomy, and so if you know there is fluid, your field is clear, but the clarity of vision in a dry field technique is different. It is always better. This is a fluid filled thing. The initial step, but the advantage is the amount of tissue in a monoportal dissection is very, very, very minimal. It's only the tube vertical thing which you see. That's the amount of tissue dissection you do, that's all. This is a ligamentum flavum which we find, and you cut the ligamentum flavum. Advantage is that the moment you cut it and there's a small rent, the fluid gashes in, the dura automatically separates. So absolutely there is no risk of any dural injury in these cases actually. And so retract the root. by rotating the sheath. That was one technique everyone has to, who want to go to the monoportal. This rotation of the sheath gradually, retracting the root, is the mainstay of your endoscopic discectomy. Then you remove the disc, how much ever you want, and rest of the disc you can just do an RF. This is into the disc, you can go into the disc base here. Other cases you cannot go into the disc base. But in these endoscopic percutaneous, either a transforaminal or monoportal discectomy, you can go into the disc base and remove. If any osteophyte is there also, you can remove it actually. And rest of all this fine. This is the end point. You can see the root is free. This is the axilla. And the root can easily be retracted now, you can see here. That's the end of the procedure of this discectomy. And post-op, if you require discectomy infusion, if there is instability, we can do. I have just done 25 cases over past 8 months, and step by step, as I learned more and more, I did more and more cases. One case of dural tear, that was of no significance, so that was managed conservatively. There was no CSF because the muscle automatically, because your pathway is so narrow. So even if when I get a post-op MRI, it's difficult to find the tract exactly through which you went to do the surgery also. And so concluding, proper selection is very important. Selection of surgical procedure which does not cause additional instability, and avoid ego. Ego means I have to do this case endoscopically only. It is not good. Do what is best for the patient, and learning the proper interlaminar microdiscectomy is a teacher for all endoscopic discectomy procedures. And the best procedure is one where you can deliver the best results for the patient. All procedures are great. Thank you very much.
Any comments or anything? No. Yeah. So any comments or questions, please? Yeah. We welcome.
Dr. Sud, wonderful presentation. But only one confusion in my mind: if there is a dural tear and you are doing underwater and water is under pressure, it will go into the dural sac and produce the raised ICP?
Absolutely, absolutely. That you have to be very care of. So that one dural tear which I had an arachnoid intact actually. So whenever you see a dural tear, your amount of irrigation should come down. You should not do, as such we use gravity associated irrigation only. We don't use pumps at all. So dural tear, having it early in the surgery is, I think we should convert it into a microdiscectomy. Early in surgery.
Early in surgery.
If it's in the late part of the surgery, you can continue to do that.
And another one, is this water can be absorbed by the venous plexus over there through the veins if there is a venous tear or venous injury?
So when you know about venous bleedings when happening, it's not a continuous thing. Whenever your fluid is coming down, if there's a bleeding, you just coagulate it. Your RF is very effective than bipolar in coagulating. It will hardly cause any nerve damage on dural injury actually. So you can just coagulate it actually.
Have you ever faced the patient going into the volume overload or anything?
No,
not in fact.
Not yet.
Thank you.
I think my experience is too low on that.
Thank you very much.
Thank you.
Thank you.
What did you ask? Sushi?
I don't think we've got time.
He wants to ask.
We've run out of time.
Yeah, okay. Thank you.
I'm sorry, we've run out of time. Look, my apologies for being late today. My schedule said it started at 9, but I didn't realise it had changed. So welcome everyone, and I look forward to a very stimulating session. That was a great talk. Thank you very much. The next speaker is Dr. Dwakaneth, and he's going to talk about the tracking the cavernous sinus invasion during endoscopic surgery. Now, you know that I'm very strict when it comes to time, so I'll give you a 2-minute warning when you have 2 minutes to go, and then a 1-minute warning, and then we'll expect you to finish on time. Thank you.
Thank you. Thank you, Dr. Ashish. First visit to Jabalpur, it's been great. So yesterday we had a very nice workshop. So today I will just be speaking on the extended approaches to the cavernous sinus, mainly in pituitary adenomas. So pituitary adenomas, of course, come in various sizes and shapes. Giant pituitaries generally constitute around 5 to 15%, but at Nimans, almost half our tumors are giant pituitary adenomas. And apart from generally giant prolactinomas, all of them require surgical decompression. But the problems are they go into various compartments, they encase neurovascular structures, they exhibit high rate of invasiveness, and of course the morbidity because of hypothalamic invasion. So like I said, we have evolved a lot. First transcranial, then microscopic transnasal, and then over the last 15 to 20 years, we have completely shifted over to endoscopic approaches. So this data is based on our unit experience of almost 886 pituitary adenomas for the last 10 years. Microscopic was 250. That was we started the transition around 10 to 12 years back. Transcranial was 125, mainly invasives, and then endonasal 481. So now it's almost 99% is endonasal. So what are the goals of surgery? One is, apart from hormonal control for functioning adenomas, you need optic nerve decompression, maximum possible tumor shaped resection, and arachnoid preservations. So we are all familiar with the Hardy's grade and then the Knopf's grade and the Goel's grade. So the question is, what will you use for? So the Knopf 0 and 1, where there is minimal invasion of the cavernous sinus, these are the tumors in which you should have complete excisions like these. You get very good excisions. You just have to take your time, do good hemostasis, and put the endoscope, use the angle scopes to all parts of the tumor, and you usually get almost total excision in most of these places, most of these tumors. The problem arises with these type of tumors, which are basically invading the cavernous sinus. They are NOS4, and they are encasing the carotid artery. Some of them may be functional, some of them may be non-functional, some of them may have cranial nerve deficits, some of them may not have cranial nerve deficits. So what do you do with them? And for this, a thorough understanding of anatomy is necessary. This, of course, is the classic anatomy, which all of us know. This is a cellar floor. This is the paracellar carotid. This is the paraclival carotid. This is the optic, planum sphenoidal. I'll not go through this. But what is important is for cavernous sinus invasion is to go lateral to the paracavernous carotid. So if you see the paraclival carotid comes here, then takes a turn, goes like this, and then goes near the optic, and then takes a turn away. So what you get is here you have the cavernous sinus. This is the anterior intercavernous sinus. This is the posterior intercavernous sinus. Then the ICA, and lateral to the ICA, you have the anterior-inferior compartment of the cavernous sinus where the tumor is going to be. So your target is going to be this part if you have to access the cavernous sinus for these tumors. So of course, this is a close-up view. So this is the paraclival carotid. This is the carotid rings. This is the suprasellar segment. So this is the anatomy which you should be aware of, and this is the part of the cavernous sinus which is lateral to the carotid, which is of importance when you are doing a cavernous sinus removal. So I'll show you this case of a NOS4 pituitary adenoma where we did an extended endoscopic approaches. So if you can see over here, you can see the tumor is completely lateral. A huge chunk is lateral to the huge chunk is lateral to the carotid. So this entire part is lateral to the carotid. So the anatomy which I already mentioned. So we have to go lateral. So we need to do a complete excellent bone removal. So here what we are doing is, if you can identify the structure, this is the sella. Now we are trying to drill lateral to the sella and the lateral to the carotid. So this involves a little extensive resection of the bone. This is the cellular component which has been opened. We are decompressing the tumor. And the tumor, of course, like what is classically taught, has to progress in a particular direction. You always remove the inferior component first and leave the superior component for the end. And if you can identify, if you can make the orientation, this is where your ICA is going to be. And this is the paracavernous carotid. Sorry, the paracavernous, the cavernous sinus lateral to the ICA. So we have opened the dura lateral to the ICA, and now we are removing the tumor from the cavernous sinus itself. So this is a place which is going to bleed, so you have to be very careful, and you have to take your time with hemostasis and keep on irrigating the field. And this is the lateral wall of the carotid, lateral wall of the cavernous sinus, which is abutting the temporal lobe. So, so now basically what you have done is you started working medial to the carotid, and then you are working lateral to the carotid, and then you are trying to join around the carotid. So this is, here you can see the cavernous ICA over here. So we have almost communicated both the segments. There is a thin dura between the cavernous sinus and the cella. So that entire thing is opened up, and now the entire cavernous sinus is seen posterior to the internal carotid artery. So now the hemostasis is done, and you can see here that, so you can see the lateral, medial, and this is the ICA. Of course, the standard closure, and this is the postoperative images which show significant removal of the pituitary adenoma in the cavernous sinus. So this is the preoperative scans. This was the immediate postoperative scan. It looks like there is a tumor, significant tumor residue, but at 5 months there is a very minimal residue in the cavernous sinus. So so similarly, these tumor, giant invasive NOS4, this is at surgery at 1 year and at 3 years. So many of these cases after the initial MRI post-operative generally tend to shrink. So these are some examples of giant invasive NOS4's pituitary adenoma, where we have got very good excision, removal of the tumor from the cavernous sinus and the supracavernous part. So again, some of our many cases which we have operated over the last 10 years, and most of them you see the thing to remember is that the immediate post-op scan is not a true indicator of the extent of removal. You have to wait for at least 3 to 4 months because the tumor actually starts descending, and some of this is because even if you leave a thin residue, that actually bleeds and appears as a residual tumor in the immediate post-op scan, but around 2 to 3 months it disappears, and actually the real extent of the residue is seen. Again, some of the NOS4 tumors. So if for example in these recurrent invasive pituitary adenomas, if there is a residue like this, I mean, which is quite much lesser than what used to be, we give gamma knife or SRT, and this is the residue after 3 years. So the question is, which approach would you choose? Transsphenoidal, of course, is the first choice of approach, and that should be the choice in almost all the cases. But there are indications of transcranial approaches where it's extremely paramedian or frontal location, or encases the arteries and extends into the multiple compartments. For example, these tumors, these are going to be a little difficult because of the angle of approach in the endoscopic, which precludes you from reaching these tumors right laterally and superiorly. So these sometimes I prefer transcranial approaches. For example, this tumor, which has a significant lateral extension, which I felt probably could be blind to the endoscopic approaches, we went transcranial. So in this transcranial, we do a transcav, we do a FTO, then we do a transcav and open up the cavernous sinus from the outside. So this is a single piece FTOZ. This is the clinoid drilling. This is the peeling of the dural duplicature from the cavernous sinus. Here we are mobilizing the sylvian vein to preserve it. We open the dura here. This is the part of the tumor which is surrounding the carotid. So this tumor is decompressed. this is the tumor in the retrochiasmatic. So the advantage of a basal approach is that you can go posterior to the carotid, you can posterior to the ICA in the space between the between the P1, P2 and the ICA. Use that corridor, and this is the basilar system, the basilar bifurcation, and the PCAs and the superior cerebellar arteries. So the entire posterior fossa component, the temporal fossa component is removed. Then we enter the cavernous sinus through the Parkinson's triangle, which is the infratrochlear triangle. And also open the supratrochlear triangle, identify the cavernous ICA from outside, decompress the tumor. And this is the cavernous ICA here. This is part of the tumor which is completely inside the cavernous sinus. And then hemostasis. So you can actually see the nerves, the fourth nerve, the V1, V2 and the third nerve on the lateral wall of the cavernous sinus. This is the immediate post-op scan. These patients do have a stormy, these patients do have a stormy post-op course, but they do eventually recover over the next 2 to 3 months. So, these huge tumors, I did a basal interhemispheric approach and excision of these tumors. Some of these tumors we have to do both an approaches. So either we do the endoscopic approach first and then do the residual tumor through a microsurgical approach, or vice versa, depending on which component is more symptomatic. For example, this is a very interesting case. Prolactinoma was started on cabergoline, for almost 1.5 years. There was no response at all. In fact, the prolactin kept on increasing. So this patient came to us with this giant functioning pituitary adenoma with bilateral cavernous sinus invasion, and he underwent an extended transsphenoidal surgery and extended endoscopic approaches, and this was the post-op scan. You can see a significant bit of the tumor is excised. We left a bit of the cavernous component was left behind, so we thought probably we'll wait or we'll call him back for a transcavernous approach because it was a functioning tumor. He of course was lost to follow-up, and he came, but he was on he continued to be on cabergoline. But if you see, after almost 1.5 years, the tumor was not regressing. In fact, it had worsened. It had gone completely laterally over here. And these tumors are basically almost like malignant prolactinomas. So again, a bilateral cavernous sinus invasion. His right PL was negative. His left eye was 6/18. So we thought, okay, fine, we will do a transcranial. His prolactin had gone up to 14,000.
2 minutes?
Yeah, almost done. So we did a FTOZ and transcavernous decompression. This is the postoperative scans which show significant decompression. The patient is gone for SRT. Is coming to SRT, of course, SRT and IMRT is a very good modality for residual tumors, especially non-functioning tumors. So these are some examples in which a small cavernous sinus residue we have given gamma knife. This is a giant pituitary, again gamma knife given. You see the almost complete disappearance of the tumor with good quality of life. GH secreting are a completely different beast. You have to remove the entire tumor. If you have to excise the medial cavernous wall, you have to do it. This is a giant, again, NOS4 GH secreting tumor. We did almost a complete tumor excision, but still he had a relatively around 6 to 7 was the GH. So we gave a complete gamma knife to the entire tumor bed. So I would like to conclude by saying these NOS4 tumors are very difficult cases. The most important thing you need to be prepared is for a stormy post-operative course. Many of these patients develop palsies, which generally reverse by 3 months. Vision improves. They have relatively good outcomes, but what is important is the first 7 to 14 days after surgery, you have a very stormy course. You have dyselectrolytemias. You can have infections. It's a real difficult ask managing them post-op, and you need a very dedicated ICU team. Functional versus non-functional. Non-functional, even if you leave a bit of the tumor in the cavernous sinus, you can still give gamma knife. Functional tumors, the idea is to remove the entire tumor, including excise the medial wall of the cavernous sinus, because they can contribute to GH levels, meticulous hemostasis, and SRT and GKRS definitely needs to be considered. So I end my talk here. Thank you.
Thank you very much. That was, again, a brilliant presentation, excellent cases. Sadly, we have no time for discussion, but I'm sure that someone will approach you during the break because I have lots of questions myself. So our next speaker is Alok, my good friend, who's going to speak to us about 3D exoscopic surgery. If this is going to take a bit of time, we could have time for one question of the last speaker. Maybe one question, one comment, until we get this talk up. I'd like to ask one question. How do you decide when to give radiotherapy after you have documented residual tumour versus repeat surgery? Given that you can get access to the cavernous sinus, both transcranial, endoscopic, when do you choose to give radiation?
That's a very interesting question. So for functional tumors, if it's a functioning GH adenoma or a non-responsive prolactinoma, the indication is surgery because you need to remove the entire tumor. I mean, that there is no doubt about it. So if there is no visible tumor like what I showed, so if like what I showed you in that growth hormone secreting, where even though there was no visible tumor, there was still a little bit of GH elevation and the IGF elevation. So in these patients, we give gamma knife to the tumor bed. The problem with gamma knife in pituitaries is that many of the time the optic apparatus is not seen separately. The optic nerve tends to sag into the cella, and sometimes you don't get a very good margin for GKRS. So either we do fractionation now with the new gamma knife machine, or we give SRT. On the other hand, non-functional tumors, if they have cranial nerve palsies, which we feel are reversible with surgery. So even though they have a temporary deterioration or they do not improve immediately, over a period of few months, when the pressure is removed, the cranial nerve palsies actually improve. So these are the cases we feel that, yes, we will go transcranially, or we will do a cavernous sinus exposure and remove the rest of the tumor. And when there is a cavernous sinus residue but no deficits, and the patient is very well preserved, so these are the cases in which we do not do cavernous sinus excision, we give gamma knife.
Given your ability to access the cavernous sinus, in the olden days we were taught that cavernous sinus invasion means that it's inoperable. Clearly it's not anymore. But do you think it's a strong negative prognosticator if there is cavernous sinus invasion, or it really doesn't matter because you can get such good access to the cavernous sinus?
Cavernous sinus per se, as long as it's maintaining the dural limitations, it's not a bad prognostic. The bad prognosis comes when it penetrates the dura and enters the intracranial component, when there's only arachnoid between the tumor and the rest of the brain. Those are the tumors which are very invasive. Cavernous sinus per se can be tackled. We have shown so many cases. They can be tackled. They have very good outcomes. The problem is with tumors which are invading into the brain. Basically, they breach the dura and then gone into the brain. Those are the ones which tend to recur more frequently.
The biggest challenge has been the bleeding.
Sir?
I mean, why do people avoid entering the cavernous sinus? Because of bleeding.
Yes.
In your experience, when did you have a situation which was very horrendous bleeding because of entering into the cavernous sinus? In how many cases the situation had the potential to cause a mortality?
So, sir, I mean, olden days, I mean, of course, 20 years back when there were no good hemostats, I mean, it was a big mess doing the cavernous sinus. Actually, when you have entered the cavernous sinus with the tumor, the initial bleed is less. The bleeding starts after the tumor is removed. So these are times when you pack it with some cotton, then do the removal of the tumor, and then use gel foam, flow seal, and glue, and do the hemostasis. So generally, cavernous sinus hemostasis is not a difficult thing, sir. You need to pack it well. Hemostasis usually occurs because these are all venous bleeds. The problem is the cavernous sinus is the ICA, and the most frequently injured vessel is the inferior hypophyseal trunk. That is the one which bleeds or gets avulsed right at the origin of the ICA. So that is a bit of a problem, but again with packing it usually subsides.
Okay, Alok, we're ready for you. Thank you.
Good morning, everybody. I thank organizing committee to give me this opportunity to introduce exoscopy in brain, spine, and nerve surgery. This is a newer tool and a newer armamentarium which can be used in future. So this is a safe alternative to microscope, adjunct to brain and spine surgery. We can use it in brain tumors, skull base tumors, aneurysms, and in simple to complex spine surgery, and of course in nerve surgeries also. It is a developmental marvel. We can switch from 2D to 3D, high definition to 3D and 4K. We have light filters. We have a pneumatic and electronic holding arms and a longer focal distance and better magnification. This is the 3D setup which we have in our center. And the 3D palette control is with the technician or the assistant, so that your both hands are free and both hands can be used for surgery. You don't have to change the field or focus yourself. So for development, maybe further it will go for better digital imaging, better options and screen technology. And some of the cases which we have been able to do with this exoscope are evacuation of intracerebral hemorrhage. We did a frontal glioblastoma. We did a split cord malformation. This is all through the exoscope. Anterior cervical discectomy was done. A tubular discectomy was done and we used exoscope for our help. For brachial plexus injury in Oberlin's procedure, we used exoscopy and could see the nerves in a magnified way and did not have to switch over to any other assistance. All this is exoscopic view. Position is not limited to microscopic oculars. Less fatigue for longer surgeries. You can move about when you are using exoscope, like we can't move about in microscope or endoscope. This gives lot of leeway to move about. Control of palette is with the assistant, so your both hands are free. Depth and view is with great clarity. Not just restricted to 3D, we can switch to 2D also. It is portable and easy to use. Of course, there are some challenges. We have to learn the maneuverability of the holding arm. Certain related issues are there because if we have only one monitor, then he has to turn and see the screen. However, we are trying to solve it by, we'll be incorporating 2 monitors, so that surgeon faces one monitor and assistant faces the front monitor. Needs some learning, needs some improvement. we are definitely gaining experience and getting used to this. Only 5 to 6% of cases required a switch over from exoscope to a microscope. With passage of time, I think this number will also become less and less. It's a good educational tool, very nice to teach in the OT. And most important is the whole staff is involved. All are wearing 3D glasses and all tell us what to do. All are welcome for this microscopic, endoscopic and pain course, which is being held just now. Thanks. I think I have made up for the other people's time, so I've made it short.
Oh, well, there's
Thank
definitely
you.
time for questions or comments.
Has your neck pain reduced after using the exoscope?
Yeah, there's neck pain has reduced because you don't have to be in same position all the time. You can move about also. It is certainly less taxing to surgeon because the movement improves. Not like endoscopy or microscope where you have to be in same position all the time.
What is the maximum magnification possible with the exoscope?
This is a technical question. Ashish? Maximum magnification.
So there are two types of magnification as in any system. So we have the digital and optical. So optical goes about 6 to 10x and digital another 5x to 7x.
So it is more than a microscope?
No, not always. So the reason why I say that is with the microscope, your magnification generally does not change with the distance that you're working at. Here, you have to bring the 3D nearer and nearer if you want a wider field. And beyond certain point, you cannot bring it down. So it has its own limitations.
Yeah, it goes out of focus. And in two cases, we had the problem of getting the field focused and we had to switch over to microscope. This was later on rectified by the company's personnel.
What system you are using?
Sorry?
What system?
This is the stores.
Stores one.
Stores 3D.
Stores, no, the exoscope.
Exos. Yeah, stores.
The
exos.
stores has graduated from
3D
VTOM.
exoscope.
They had originally the VTOM. That is the video India. And from VTOM they moved on to this now. Actually what they've increased the focal length.
Sorry?
VTOM had a focal length
No.
of about
It's not
12, 13
the
inches.
difference between
this is
Eagle
just
and
one
this
step
is
forward.
Eagle has a robotic arm. I'm sorry. But
This, the great maneuverability is there, so you can focus the field, the depth of focus, and most important is the assistant manages the focusing. You both hands are free. You don't just have to tell him. Of course, he has to get used to do that.
So is there a limit to how many new tricks a monkey can learn, an old monkey?
Yeah, this is a new armamentarium. We can, not in all cases, but add on to endoscopy and microscope. Not the end to it.
I'll just give one important comment that there are a lot of spine enthusiasts here, sir. When we do a anterior approach from a posterior surgery, the microscope that you can tilt, it has its limitations. Whereas here you can pull the 3D and it is absolutely flat with the back. So it is giving you a much, much better angle. So as far as tumors are concerned, or if there is a retropulse fragment, so this gives an excellent view for you to pull those out.
Yeah, in some of the cases we find it to be better than endoscope or a microscope. Let's see.
Yes.
No,
Look,
our team has not had any headaches till now.
Ashish and Alok, I'm old enough to have seen the microscope introduced in neurosurgery. My boss was clipping aneurysms with his loops. and then he was forced to use the microscope, and when the aneurysm ruptured, he quickly pulled out the microscope, put his loupes back on and goes, "This is rubbish." Now I can't imagine not using the microscope, and I can't imagine buying an operating room without a microscope. Are you at the stage now that you've given it a fair go where you'll discard the microscope and only have an exoscope?
So for my stage, I would continue with the microscope as my workhorse. So I won't put microscope aside as of now with the technology that we have, because there are certain maneuverability issues still there, though we have robotic arms coming up. So the message that I want to give, it's an excellent tool, especially if you find difficult to keep two microscopes, this, and if you have freelancing practice, you can carry it along. So it has its own benefits. So instead of two microscopes, you can have one of these. Also, the beauty is you can integrate this with the endoscope. So it's a one system go for a lot of problems. That is one advantage.
And sir, for somebody like me, finding it endoscopy is a steep learning curve. This is easier to learn and adapt.
But is this, I don't think this is a very dedicated exoscope. This is a modified system of the Whitehound. Am I correct or not? Because if I remember correct, we used to do the transthoracic approach. What is the focal distance? What is the distance?
That can be varied, focal distance can be varied.
So it is almost 600 millimeters.
Yes.
And the technology is totally different, sir. Like we have depth perception because of two eyes and then they're coming together. Similarly, they have incorporated two lenses. And then through AI, they bring and form an image. So the technology between 2D and 3D is very different.
You have to see to believe it, what I'm saying. And sir, as what you said that he removed the microscope, used his loop. In fact, the center where I was trained, Professor Vengsarkar did not even use the loop. And we used to ask him that you should use something. So he always used to comment that my eyes are a microscope.
So excellent.
Yes.
I think we move on to next this thing.
Thank you.
Excellent. One more point that this exoscope or VTOM can be used as a tool to switch from microscopy to endoscopy. So this can be used as a tool to learn endoscopy. We now move on to next talk, and that is by Dr. Subodh Raju, and he will speak on back to uninostril for endoscopic pituitary surgery. Dr. Subodh.
This talk is exactly contrary to what Dwarka talked about. Beautiful surgeries of the pituitary. But why I took this talk is, this is one aspect of pituitary surgery which we as neurosurgeons forget. My talk is based out of nasal morbidity in pituitary surgery. How less can we damage the nose? So, yeah. So uni or binostril, it's a talk. So again I start with this is a pituitary surgery which I did in 2005-06 using an endoscope. But that time if you see, I was using the endoscope but I was using a speculum also with it. That's how I started the endoscopic pituitary journey, by putting the speculum and then using the endoscope. And there's a case of a Cushing's, small, and rest of the pituitary, the surgery was almost the same. Why did I use the speculum? Because I used to get the challenge of repeated soiling of the tip of the scope. During my hand eye, when I was to take out, that's why I started using it. And number 2 point is, I don't repeatedly rub the mucosa. Whenever I take in an instrument and take it out, I am rubbing the mucosa. There is some amount of inflammation which is produced. That's how I started my journey for endoscopic surgery 2005. There are some of the cases. So when you talk of pituitary adenoma, binostril approach is because the newer generation went for forehand technique, both nose, extensive surgery, they are becoming equivalent, better than microscopic surgery. Is binostril surgery for all? Urinostril, is it sufficient? And then last part is Hadad flap an overkill? So this is the snot scoring system which we use in our place for studying the nasal morbidity of patients undergoing pituitary surgery. And I'm sure if you talk to your ENT surgeons who take your post-operative, they must have seen odd sort of complications, including septal perforation, bad crusting, mucoceles, synechias, and these things. So this also helps in the rehabilitation process of a patient of pituitary, which we forgot. We are looking at the adenoma, we are looking at the pre-op MRI, we are looking at the post-op MRI. What line in between is the patient? So this is the olfactory nerves which we tend to use. Too much of cautery, monopolar, coagulation around this area, so leads to loss of olfaction. We have to be careful about. So I did a search. This is basically a review of what other search I did on the internet on what all things. Higher incidence of postoperative impaired olfactory function in microscopic approaches were reported in recent studies. But most of these studies were on transseptal approach. We are talking of transseptal approach. So transseptal approach also affects the smell, quality of smell. Importance of postoperative nasal care, which we don't do as neurosurgeons. So for my center, the nasal wash starts at day 2 only. Once I remove the pack, the nasal wash has to start and it has to continue for 3 weeks post-surgery, the nasal wash. The patients have to be trained and they have to do them. That drastically improves the quality of their nose mucosa. There's the olfactory training methods to promote olfaction. This is again long-term results of endonasal endoscopic transpharyngeal dissection of non-functioning. They looked at olfactory damage was more common in the binostril group, wherever we have done a binostril group. And however, the number of studies relevant to the mononostril was not common complication when we talk of olfaction. Again, olfaction and sinonasal outcomes. Is it when you do as a single surgeon or a group of surgeons? Like in your team, you also have an ENT surgeon with you. So patients in group 2, that is a team of surgeons when they are operating, the post-operative olfaction based on subjective analysis was better. And sinonasal quality of life was not significantly decreased when we talk about the long-term outcomes. We are talking of short-term outcomes. If you work as a team, it is always better. Extent of surgery, and where as we go for extended transpharyngeal surgery, the morbidity increases. Nasal irrigation, if you do the nasal irrigation regularly, it reduces the incidence of complications. So it's always an evaluation of things, starting from the speculum transseptal approach, using the endoscope in the transseptal approach, and this is what we do now. And the simplest in a practice, what Dr. Dwarka stood about NOS 3, NOS 4 grading, I think they will constitute less than 10% of your cases. 90% of your cases in practice will be routine pituitary surgeries. So you don't have, one solution is not there for all surgeries. So here you just do a routine urinostril approach, don't touch the other nose, pack only also the one nose only, and remove the tumor. It's a routine surgery. So then came the concept of mononostril, binostril, then came the concept of 1.5 technique, wherein you are just making a small posterior septostomy to just pass a scope or a suction, one instrument. And whichever instrument you pass, you should not be moving it too much, it should not be generating heat, and it should be constant there. So that is how you take care of the mucosa on the opposite side. So they showed that this was had a versus 1.5 nostril versus binostril endoscopic territory, and the short-term nasal quality of life was better with 1.5 technique compared to a binostril technique. Again, numerous studies on monostril, binostril, you know that. With binostril, because the surgery is more extensive, it demonstrated a higher rate of epistaxis than a monostril, but the extent of reduction was better in the binostril technique. Invasive adenoma is better with binostril technique. The surgical trauma was greater in binostril technique, and the risk of epistaxis, olfactory damage, post-operative discomfort was increased also in binostril technique compared to a monostril technique. So, one more thing we added during the surgery was to use a longer pituitary scope, not than the 18 centimeter. Nahi. This is a 26 centimeter scope which we use for the pituitary. So you're cluttering around the nose, because you're putting 3 instruments. So around the nose here, the cluttering of the instruments had decreased drastically by using a longer scope, pituitary scope, which has a good handle to grip it also, and it doesn't get heated too much on these things. So this is where we move to the routine thing, mucosal incision, and that is a time when we started using the debrider also. This is a redo case basically. Already surgery has been done, but for the completion, we did again a complete opening of this sella. So you can see the previous scarring. And the drill used, removing the cellular floor. Rest of the surgery is the same as these things, and taking a scissor to open the dura instead of a knife. And the rest of the pituitary surgery is using the curette to take it out. Doing a proper wash. Packing. There was no CSF leak, so no need of any pattern. So in all the cases, what we did was, whenever there is an extensive CSF leak where you want a Haddad flap, instead of using a Haddad, we used to use a rescue flap. So our Haddad flap is never harvested first in these cases. Same way, another case, there are simple pituitaries which constitute the, again, bulk of my practice. And this is a 1.5 tech where we done, I don't call it 1.5 also, because we just make a small hole to pass the suction. I don't pass the endoscope from that, because the endoscope also generates amount of heat in that. So my thing is passing the suction through the small opening in the septum, actually, posterior septum. And this is the end of the surgery. The suction is always from the opposite side, and then placing a nasal pack unilaterally only. This is the opposite nose you can see here, absolutely pristine except that small opening down below for passing the scope. The next question about the Haddad flap or the pedicle nasal flap which you are talking of. Outcome, this is the pituitary surgeries. Risk of nasoseptal flap harvesting is there and may be an important factor for post-operative outcomes in these patients. Use of nasoseptal was noted to increase the post-operative nasal symptoms in the short term, not in the long term, immediate, because more crusting happens. The more you have dissected, more crusting happens. So they did whether in other cases using a fascia lata and fat, is it sufficient? They found that it is also sufficient, and your quality of, and the nasal quality improves. The morbidity decreases when you are not taking Haddad flap and just using a fascia lata in these cases. They have used the flea middle turbinate flaps also, mucosal flap for repairing instead of using Haddad or a temporalis fascia in these cases, and they found a better outcome in these cases. So use of uninostril approach, preservation of the middle turbinates, avoidance of maxillary enterostomies, and avoidance of raising the nasal flap improve the immediate post-op outcomes. We should recognize more points of attention during nasal operations, and the nursing people have to be trained more to take care of the nose, including the irrigation regularly. The patients have to be taught about nasal irrigation. It's not easy to understand, but if once you teach them, they do it regularly. Nasoseptal flap to be used judiciously, early nasal irrigation, and uninostril or 1.5 nostrils suffices 90% of the all pituitary surgeries. Thank you very much. Welcome to Skull Base 2026.
Any question or comments, please?
Dwarka is ready to ask.
Can I?
No, I mean, I don't deny that. I mean, see, the problem is 50% of our tumors are invasive tumors, so the load is different. So
Yeah,
the type
absolutely.
of patients we get is much different. But in fact, we have moved away from uninostril approach. We're actually doing the interceptal approach. So this is basically going back to the olden days in which we used to do a sublabial raise the tunnel. So actually now, if you actually do the same intermucosal approach, interceptal approach, and reach the sella, then you don't actually have to do a mucosal flap repair. All you have to do is to just oppose the mucosa together, and you don't even need to do a flap also. Just have to place of fat and some Norton fascia and just put the mucosal flaps together. So it is actually even more easier than a uninostril.
I think Adesh has a talk on that.
Yeah, actually, now it's like we are going back to the transseptal approach and try not to enter into the nostril itself as anterior as possible for you, depending upon the contour of the septum. Make the at the mucocutaneous junction, just take a vertical split and go through it, as we used to do in our classical microscopic transseptal approach. I'll be talking about that in the next session.
Yeah, my point of raise was we should not forget about the nose when as pituitary surgeons and give equal importance to that morbidity. That's all, my point of view. Thank you very much.
I think it was an excellent presentation, very honest presentation. I'd like to make a comment for the young neurosurgeons and the residents that you must question and you must always be a little bit skeptical about what you read in the literature. I am one of the authors on a paper published in Otolaryngology by Richard Harvey that states very emphatically that the nasal complications do not increase with nasoseptal flap or with a binostril approach or with sacrifice of the middle turbinate. And he wrote the paper and asked me if I'd be a co-author because we do so many cases together, and I said yes, but I completely disagreed with the conclusions of the paper. I said to Richard, I said, actually my experience, Richard, is that when these patients come back after they've had a Haddad flap, they have crusting, they have terrible smell, they have a lot of problems. And he said no, that they didn't. But just you have to question the literature.
Absolutely.
And what you've done is very good. I think you should publish this because it just makes sense. It makes sense that the more mucosa you destroy, the more nasal dysfunction you're going to have after surgery. But the literature is very questionable about that. There's evidence for and against that contention. So yeah, it makes a lot of sense to me that the more mucosa you damage, the more you're going to get complications. And what you're doing now is the next phase of a new technique. The first phase is whether it's possible. The next phase is when you should use the technique. And the third phase is where you start honing down the technique and making it even more sophisticated and less invasive. So congratulations, great presentation, and I really like the conclusions.
Thank you very much.
And the final talk of this session is by Dr. Swapnil on the transforaminal epidural steroid injection.
So thank you, the organizing committee and Ashish sir for this opportunity. So there was a bit of mix-up. So the epidural injection technique and all those things I had discussed already yesterday. So after discussion with sir, sorry, sacroiliac joint pain would be a better topic to deal. So, sacroiliac joint is a bit limited motion joint, like it has a range of motion hardly of 4 to 5 mm of range of motion. It is strongly supported by ligaments, muscles and everything, but as with whole of spine, it transfers your weight or your upper body weight to your lower limbs, and it being a source of pain is a common entity. Now, it is one of the joint with largest surface area, and the main pathological site, the pain site, is usually the inferior part and the ventral position part, which is the synovial part. The upper part is usually the fibrosed part. So what are the etiologies? So most common is an old age patient with a history of fallen buttocks or any history of pelvic injury. Pregnancy patients, due to the physiological changes of expansion of the pelvis or the laxity, there is pain in sacroiliac joint. Repetitive stress, spondyloarthropathies like ankylosing spondylitis, osteoarthritis, it's a rare thing. Length discrepancy. So I have seen many patients who have either they are posted for THR or they have undergone THR. They have bit of limb length discrepancy and they suffer from a lot of sacroiliac pain. So if you try to understand the nerve supply, we need to see it's a thick joint. So it has nerve supply both from the anterior surface and the posterior surface. And this becomes very important when we plan for RF ablation, because you cannot approach the anterior side for the denervation. So you have to rely only on the posterior surface. And that is why with nerve ablation, RF ablation, you might not get that good results at times in such patients. The symptoms, patient might complain of a deep pain, or even at times they will point it out like it's a superficial pain and very well localize it to PSIS or that zone, or they might keep their hand over the medial side of buttocks and say this is my pain zone. And what you need to understand is that they usually have a non-dermatomal referral pattern, which is like 70 to 80% of patient will have a non-dermatomal pattern localized to the posterior aspect of their thigh, not going beyond the knee joint. But there are cases that might extend their pain. As the chronicity of pain increases, the referral pattern may change, or it might go below the knee joint also. The precipitating factor most commonly is they're sitting down or lying down on the ipsilateral side, or while climbing stairs, they might complain of pain in that area. For clinical tests, as I told earlier, it's a kind of an immobile joint. So what we need to do is we have to do traction. Basically, both the bones should move in opposite direction to bring on the test positive. But there are battery of tests. There are many cluster of tests proposed for sacroiliac joint. No one stands out like this is the single test which will help you out the most. So you should at least have 2+ tests, at least 3 tests should come positive, and it should elicit the concurrent pain as the patient has. So the most basic test is the 14 finger test that patient points out at the PSIS and says this is my zone of pain. The Faber-Patrick test, the patient lies down supine with knee flexion over the opposite limb, and the limb which the knee joint, knee joint of the limb which has been flexed, we are testing for that side. So basically your other hand is on the ASIS and you are pushing it down, and similarly other side. So basically with the lower limb acetabulum, you are trying to create a distraction between the sacrum and the iliac bone. Similarly, the Ganselin's test, now it's a bit difficult to perform. You have to bring the patient on the edge of your examination table. You are pushing down the other limb, and the limb which you are testing, you have to flex it. Distraction test. Now in this test you have to clearly explain the patient that please do not coordinate with your anterior, because if you press the ASIS, he is going to have pain over the ASIS also. So you should clearly explain the patient that you have to look for the posterior pain which is happening. Thigh thrust, again, you are distracting both the bones. Lateral thrust, patient with in lateral position, you are trying to press over the iliac bone. And sacral thrust, basically with patient in prone position, you keep your hand over the sacrum and try to press it. So even with this, we should also keep in mind the differential diagnosis. So lumbar facet arthropathy is very commonly associated because the nerve supply, there is a bit of overlap between the nerve supplies, and sometimes lumbosacral radiculopathy might present in this form. Myofascial pain is the most difficult part to differentiate because the gluteus muscles and all those, they develop trigger points in the chronic patients, and it is very difficult to differentiate. And because all those tests which I have told you, they will result in some compression over that site, and if they have trigger points, so they will have the repeated pain. Angst-Pond patients, usually young patients will be there, and they will have the bodily symptoms present in them, that multiple joints are involved and they have a stiffness, early morning stiffness is present. Psoriatic arthritis, spinal stenosis, somatic dysfunction, and cluneal nerve entrapment. Cluneal nerve entrapment, basically the pain would be a bit lateral, and so if you have seen all the clinical tests and when you come to radiology, even after that, if you say what is the gold standard to it, for me the gold standard and the literature says it is the diagnostic block into the sacroiliac joint. So usually you'd give is just local anesthetic to confirm the diagnosis, and once it has been confirmed, you can do it with steroids or an RFA ablation. So in X-ray there has been there is a grading, New York sacroiliitis grading, in which we can see that the grade 0, there is no changes, and in grade 1, we can see there is some erosion happening over there, and as in grade 2, along with erosion, we can see there is a juxta-articular, some sclerosis has started, and now in grade 3 there is a widening of the joint over here, and both the sides we can see, and in grade 4 there is a complete ankylosis. We cannot make out where the joint is. So MRI, basically we have to see is it an active inflammatory lesion or a chronic lesion. MRI can help you out with that. If there is a marrow edema, capsulitis, synovitis, like you can see there is a T2 enhancement present. And in with chronic cases, there is much of sclerosis, erosion present. Now coming to the management, NSAIDs, they do wonderful if patient has Angst-Pond, and physiotherapy helps good. But the interventions, if you have a definitive diagnosis that you feel it's going to be sacroiliac joint pain, interventions, they have an excellent result. And RF is rarely required. So I am a pain physician. I don't have any experience with the fusion surgeries, but I have seen it in literature, but it is very rarely practiced nowadays. So anatomically, we have to understand one thing, that it's an overlapping, that the ilium part is basically overlaps the sacrum. So you cannot make a direct straight entry into the joint. So you have to just overcome the ilium by making your C-arm fluoroscope bit contralaterally oblique. Okay. So it is one of the rare procedures which requires a contralateral oblique view. So if you see in simple AP view, we are able to appreciate two joint lines. Now, the two joint lines, basically the medial one is the posterior joint line, while the lateral one is the anterior joint line. So when we take a contralateral oblique view, we can see the joint lines have moved apart, but the widening in the joint line is present more. So this approach is better. But why, if you take an ipsilateral oblique, the joint lines fuse, but the joint opening is reduced. So entering the joint becomes a bit difficult in this way. So the patient lies down in prone position. Our target is the caudal part, which is the synovial part of the joint. Align the joint lines for maximum radiolucency. Basically, you have to move your C-arm continuously. I cannot just say 5 degrees sufficient or the 10 degrees sufficient. You have to move your C-arm so that you get the maximum radiolucency present. Then contralateral oblique view or cephalocaudal tilts are required better take a cephalocaudal tilt, because as you see there are two surfaces. If you don't take a cephalocaudal tilt, you might be seeing the anterior border which is down and trying to target, and you might enter into the pelvis. So once you have visualized the joint line, you enter the joint, and it gives a typical feel of entering a joint. If you are going to hit and enter it, the problem starts even if you have entered the joint. Giving dye is challenging. If you are able to give 0.1, 0.2 ml of drug, it is very hard to give. Prefer using 2 ml syringes, because that creates a definitive pressure. And just simple dye, just see in AP view, we can see both the anterior and posterior joint lines are filled with the dye. Lateral view, it's a bit difficult to appreciate, but if you see, this is, it has overlined the joint line. And in this picture, you can see very clearly the dye has spread along the joint. Now, RFA, as I told you, there are two nerve supplies, two areas to target, and anterior you cannot target with radiofrequency ablation. But still, if you feel like you can benefit this patient with radiofrequency ablation, I would suggest there are separate modes available for radiofrequency: pulsed, thermal, and cooled RFA. Pulse basically targets, you can target even a motor nerve with a pulsed RFA, because the temperature stands out at around 42 degrees centigrade. So there is no exothermic reaction present. But thermal RFA, your temperature goes up to 70 degrees, up to 80 degrees, and you target the sacral foramens. So there are high chances you might target the your motor nerves over there, and you can cause more disability to the patient. If you feel you want to go for an RFA, I would prefer using cooled RFA. I have used it around for 3 to 4 patients. The long-term follow-up of those patients which I have is more than 1 year, more than 15 months, they are pain-free. So basically the technique becomes very easy, because you have to go just AP view and just along your 1 o'clock to basically your 5 o'clock positions, you have to move your needle and create lesions. And you have to go up to your S3 foramen. Contraindication simples: infection, bleeding disorder. Now pregnant patients suffer from this pain, and we cannot give much of NSAIDs also to those patients. So what we can do after discussion with your obstetricians, what I have done is going an ultrasound guided approach rather than for your fluoroscopic approach. And you can just deliver the drug, even plain local anesthetic if you have delivered. You have basically broken the pain cycle. It's not about the duration of relief from the lignocaine. If you have breaking the pain cycle, basically if the initial pain was 9 to 10 out of 10, and you have bring it down to around 5 also, it's a 50% relief for the patient. Complication, if you enter the pelvis or intravascular, that's why I always use a dye. Thank you. That's it.
Well, thank you very much for sticking to your time. We have time for questions or comments. That was a fantastic summary of the condition, and very educational. Any comments? Questions? No, thank you very much. That brings a close to the session. Is Ashish here? We're running behind, so I wonder if we still need a break, a tea break. Maybe a 5-minute tea break, or maybe go straight on, do you think? Where's Ashish?
Sir, we will continue with the sessions.
I think we should continue.
Yes.
And is that okay for everyone? Because we're running behind. Yeah.
Thank you to all the speakers for the wonderful session. I would request the chairpersons to felicitate our speakers, please. I would like to call Dr. Subodh Raju. Our next speaker, Professor Dwarkanath.
Oh yeah, okay, fantastic.
Dr. Alok Agrawal, Dr. Swapnil, Dr. Swapnil, Dr. Subodh is here. Thank you, Professor Teo and Professor Yadav. We'll continue with our next session for the long videos. And I would request Professor Manmohan Singh and Dr. Vasant Lakwale sir to chair the session, please. Thank you. Over to you, sir.
Should I, Mr. Chairman, should I start? Mr. Chairman, hello, should I start? Okay, thank you very much. Time is of the essence and I've only got 15 minutes, so here we go. 15 minutes and 5 minutes discussion. So this is an approach that's been around for many, many years. It was first described by Krauss in the 1920s, popularised by Ghazi Yazhigil. It requires excellent neuroanesthesiology because it was originally described in the sitting position, and the sitting position increased your risk of air embolism, quadriparesis, surgeon fatigue, but it was very, very good for CSF egress. So the SCID approach has now been changed. A lot of people don't use the sitting position anymore. I personally have never used the sitting position and find with good neuroanesthesiology, you can now do the patient in a recumbent position. So the big question is, should you use SCIT or should you use an infratentorial approach or a supratentorial approach? And the simple answer is, of course, the 2-point rule. Always think about the 2-point rule and the long axis of the tumour. If the long axis of the tumour points to infratentorial, then it's an infratentorial approach. And conversely, if it points to a supratentorial approach, then it's an interhemispheric transtentorial approach. Do you go midline or paramedian? Or just remember this, if you're trying to look at the camel's head and stand behind the camel, you won't see the head. The hump will get in the way. And so too, if you do a midline approach, then the superior vermis gets in the way. If you do a paramedian approach, you can see the head. So if you do a paramedian approach to the pineal region, then the vermis doesn't get in the way. So here's some examples. This is a pineal cyst with clear aqueduct stenosis. I have evolved my positioning. I used to do them prone. I then did them in the lateral decubitus position, and now I do them in the supine position. So supine, head turned, paramedian incision, about 2 finger breadths away from the midline. So that's the positioning. Head up, contralateral rotation of the head, a little bit of flexion, but not too much to obstruct the venous outflow. Mark out the transverse sinus and make the incision about 2 finger breadths away from the midline. Make sure that the incision incorporates the transverse sinus because you have to skeletonize and blue line the inferior margin of the transverse sinus. Straight incision, down the bone, self-retaining retractor, burr hole at the level of the sinus so that you can see the inferior border of the transverse sinus. Small craniotomy, but again, the craniotomy must incorporate the transverse sinus. You've got to see the inferior border of the transverse sinus. Open the dura, reflect the dura superiorly against the sinus, and you'll start to see all these bridging veins. You can sacrifice the bridging veins with impunity. Please do not be worried about sacrificing these veins. They can all be sacrificed with impunity. Having done hundreds of these cases, I've never had a situation of a swollen or venous congested cerebellum by sacrificing these bridging veins going up into the tent. So there's that pineal cyst, there's the post-op, and here's the video of the operation. So this is a right paramedian supracerebellar infratentorial approach. This was a germ cell tumour. We've done the straight incision. This is in the days when I used to do them lateral decubitus, but now I do them supine. Okay, so let's stop right there. Superior, medial, lateral, inferior, V-shaped dural flap reflected against the sinus. Now remember, you've got to see that inferior surface or the inferior margin of the transverse sinus. If you don't see it, then you're not going to be able to get this supracerebellar approach. No fixed retraction. You're looking for the bridging veins. Do not tear the veins, sacrifice them. So the first thing you do is start looking for the bridging veins. You move your microscope around. If you find them, you sacrifice them, cut them, and then continue your journey to the pineal region. The arachnoid will always be opaque over the pineal region. And because it's so opaque, it's very difficult to tell what's beyond it. My point to you is always presume that there's a big vein beyond it. Always presume that there's going to be some sort of vein beyond that opaque arachnoid. So cut through the arachnoid very sheepishly, very carefully, because there could be a big vein just beyond it. Wide opening of all that arachnoid. Take your time, nice and slow, and then you'll see the more important veins that can't be sacrificed. The pre-central vein, for example, I have sacrificed it on a couple of occasions and I've got away with it. But in fact, there's the literature does support that you should try and preserve the pre-central vein, especially if you've sacrificed the bridging veins on the way in. So save the pre-central vein if you can. Operate around those large bridging veins. The first vein you're going to see is the pre-central. The next vein you're going to see is the basal veins of Rosenthal. And the next veins you're going to see superiorly are the internal cerebral veins. And then, of course, you're going to see the vein of Galen. You must preserve and respect all of those large, deep bridging veins. Do not sacrifice them. So you can see that we're doing slow dissection of this tumour, maintaining the bridging veins, no fixed retraction on the cerebellar surface, easy access because there's a lot of CSF egress. CSF comes out of the pineal recess, CSF comes out. As soon as you start dissecting over the top of the cerebellum, you start getting CSF out. So please don't worry about that. That's not going to be a problem. And you don't have to use the sitting position if you don't want to. Now, I'm not against the sitting position. It's just that it does require good neuroanesthesiology. There's a lot of fatigue because your arms are up like this. There is an increased incidence of aeromolism. So if you can get away with not using it, then I would suggest you try and get away with not using it. So if it's a large tumour, you've unfortunately got to fragment the tumour. This is a small window through which you're operating, and so it's very difficult to pull out a tumour en bloc. So you can see that I've halved or maybe reduced the size of that tumour so that we can get them out between those bridging veins. Now we're taking out the rest of the tumour that's been sort of pushing down on the brain stem. And you can see that we're operating through these windows, these venous windows. You've got to be very cognizant of those windows, you've got to be very cognizant of those veins and try and maintain those veins. The small ones that supply the pineal gland, sure, you can take them, but the large ones, the large bridging veins that have a name to them, you should try and preserve them. Always use the endoscope after the case, if I can just freeze that, just to show you some really nice anatomy. The endoscope will ensure that you've left no tumour superiorly, inferiorly or laterally. Whoops, sorry. I just want to show you this nice anatomy before we go any further. Okay, so what we see here is the splenium of the corpus callosum. We see the two internal cerebral veins coming superiorly to join the vein of Galen. This is the basal vein of Rosenthal. The other basal vein of Rosenthal is on the other side, and they're the deep draining veins of the brainstem and mesial temporal lobe. So you cannot sacrifice the basal veins of Rosenthal or the two internal cerebral veins or the vein of Galen. So splenium, internal cerebral veins, left and right basal vein of Rosenthal, left basal vein of Rosenthal, and the precentral vein is back here behind the endoscope. These are small perforators that supply the top of the cerebellum, the brainstem, and the pineal region. You can sacrifice some of these small vessels, but try and preserve them if possible. The endoscope's now looking into the pineal recess. The back of the third ventricle is right here. There's the vein of Galen, basal vein of Rosenthal, splenium of the corpus callosum, top of the vermis, and the back of the third ventricle. You can just see the third ventricle through there, that little hole right there. This is the putamen here and the putamen on the other side. And at the end of the operation, there should be no footprints. In other words, without fixed retraction of the cerebellar surface, you should not damage the cerebellum, and it should be pristine after the operation. Okay, do you do it open or endoscopic? I think endoscopic, pure endoscopic is a bit of a gimmick. I've looked at the craniotomy size of those people who do them purely endoscopically, and it's the same size as my craniotomy. So it's not as if you're reducing collateral damage doing it pure endoscopically. You know, I find it very difficult to dissect as well with endoscopic instruments as I do with open instruments. So I would say to you, do it open, minimally invasive, small craniotomy, and use the endoscope to look around corners at the end of the operation. So it's endoscopic assisted as opposed to endoscopic controlled surgery. So I always make sure I use the endoscope because you'll always be surprised at residual tumour that you may not see with a microscope. So this is a falcotentorial meningioma, and this is the approach here. So you would think that I could get a good resection of this entire tumour just with the microscope. But if you look at the video now, you'll see at the end of the operation, I really missed a significant portion of tumour with the microscope that I could see with the endoscope. I know that looks tight there, but it's not tight. All it takes is a little bit of retraction of the superior surface of the cerebellum, and CSF starts coming out immediately. So please don't worry. You open the dura, the cerebellum looks tight, but slow retraction of the cerebellum, and CSF immediately starts coming out. And then once you get, of course, to the arachnoid, then you get good egress of CSF. So this is all the microsurgical resection of this very, very tough falcotentorial meningioma. You can see that it just did not suck. It would not cousa, so I had to cut it bit by bit, fragment by fragment. And then I put the endoscope in. Before you see that, before I put the endoscope in, you'll see that it looks like I've got a good resection. There's the back of the putamen. It really looks like I've got most of the tumour out using the microscope, but in fact, when I put the endoscope in, you'll see that I've left a significant portion behind that's hidden by the tent. These are the dural sinuses in the tent. This is the top of the cerebellum. We're putting the endoscope in now, and this is a cavity that I created with the microscope. And look at this. This is all tumour that was hidden from the microscope above the tent and seen very nicely with the endoscope. So we now use endoscopic technique, endoscopic dissection, and this was very, very firm, so I tried to suck it, couldn't suck. I ended up using one of those hybrid instruments to cousa the tumour out. Remembering that beyond this tumour, of course, are the internal cerebral veins and vein of Galen, so you've got to be very careful that you don't suck too hard and appreciate the anatomy beyond this tumour. How much time? Okay, so we'll finish up now. That's the instrument I use. It's called the coblator. Irrigates, sucks, coagulates and burns the tissue as well and dissolves the tissue as well. And there we are using it now. It's malleable, so you can actually angle it more, and you can see it's actually doing a pretty good job with that very, very tough fibrous meningioma. And at the end of the case, it looks very, very good. This is just burnt tissue, but the tumour's gone, and post-op tumour is gone. Sometimes a contralateral approach is more appropriate. In other words, if the tumour is going out to the right, then coming from the left is actually a better approach. So just remember that you can look to the other side from a contralateral approach. And that's a case of that. And then finally, in terms of the cosmetic outcome, it's very good. Make sure the incision's always underneath the hairline. There is no reason to extend that incision below the hairline, so it can all be covered after the operation, and it heals up very well. Thank you very much.
Hello, I think this is a wonderful presentation, Dr. Charlie, and always nice to see your surgical skills at this difficult location. And any questions from the audience? Yes.
Would the next speaker like to come up and set up their thing while I'll answer questions?
About this bridging veins,
Yes.
you said that you had no problem.
No problem.
What about the same thing
So,
works with
next
the
speaker-
superior petrosal vein for trigeminal neuralgia? Because there is a big discussion on this. The area drained, but these veins are very good. But the literature says superior petrosal vein still has some patients going for some problem. Amazingly, the one which you are showing it, even we also have experience, they don't produce anything. Do you have anything anatomical? Because
I just have to be honest with you. So I know the literature. I've heard other speakers come up here and say, don't sacrifice those veins, you'll get problems, and they show their cases. I just have to tell you, I've never had a problem. That's just the truth. And it could be that I don't use fixed retraction. I think that's important. If you sacrifice a vein and then have pressure on the brain that you've sacrificed a vein, maybe that has something to do with it.
Yeah.
But the short answer to your question is no. I've sacrificed the vein of Dandy many times. That's the superior petrosal vein. I've sacrificed all those bridging veins many times. I've never had a problem. And so that's the truth. I'm not saying that people don't get problems, and I'm not telling the young surgeons to glibly take it without any sort of concern and with impunity. I don't think that's the case, but all I can say is my truth. And the truth is I've never had a problem.
thank you.
I would like to tell you, first I will thank you for such a wonderful presentation. And I would like to ask you to give us the pearls of wisdom when we reach the brain stem, how we become a bit extra cautious not to damage it.
Yeah, no, it's a very sensible question because you are right there at the back of the midbrain. You just have to be very cognizant. So I've damaged the vein, the draining vein, one draining vein once, the basal vein of Rosenthal. And I did it because I didn't look at my bipolar. And it turned out my bipolar, the little bit of plastic had torn. And so there was this bit of plastic that was sticking out from bipolar. And all it took was me rubbing that bipolar against the basal vein of Rosenthal, and it tore it. It tore a little hole in it. And so I guess I tell that story because when I teach my residents now, my fellows, it's all in the detail. Have you watched Jack Reacher? Jack Reacher is this new TV series about this tough guy. And one of the mottos he has is details matter. And when you have a brainstem, when you have a part of the brain as eloquent as the brainstem, details matter. Everything's important. You can't be too rough. You shouldn't be too quick. Your instruments have to be perfect. When you're bipolar, you've got to remember that you might be bipolaring something that you can't see. It's all in the details. So, yeah, and you're right there at the top of the brainstem, so you have to be very, very careful. That case of the torn basal vein of Rosenthal, I was just very lucky. I packed it, but you can't pack too hard. So I packed it, elevated the patient, kept my fingers crossed, said my prayers, and I got away with it. But, you know, I shouldn't have got away with it. When you're dealing with the brainstem, every little detail counts, and if you have a problem, then, you know, it's going to be disaster.
Thank you, sir.
Can I ask a question?
Yes, please.
There are very limited number of surgeons using thick bipolars. So what is your thought on using the thick bipolars? What are the advantages? And where you think that you generally avoid those? And using these thick bipolars, after you've known connectomics, has it made any difference?
So what Ashish is referring to is that I believe that you should have two sets of bipolars. One set is for subarachnoid dissection. They're sharp. They're very, very important in identifying and dissecting around small microperforators and cranial nerves. They're important. And remember, most neurosurgical bipolars have sharp tips. Okay, now you should have a set of bipolars for glioma surgery. Why? Because the bipolars for glioma surgery serves a completely different function. When you use bipolars for glioma surgery, you're expecting the bipolar to melt the tumor. In other words, dissolve the tumor. So it's all about disseminating the heat across the ends of the bipolars. So the thicker and the broader and the greater the surface area of the bipolars, the more the heat will be disseminated and dispersed. And so you won't get coagulation, you'll get melting of the tumor. So thick bipolars are for gliomas, fine bipolars are for microdissection in the subarachnoid space, and you shouldn't mix the two up. On top of all of that, remember, every person, every group, every company that's made a set of bipolars have made them badly. Every one of them has an exposure of about 3 or 4 or 5 millimeters. Now, when you're looking down a microscope, you're looking at the tip of your bipolars. You have no idea what structure is leaning against your bipolars behind your field of view. So when you coagulate the tip of the bipolars, you can be coagulating a cranial nerve or a vessel or the brain that your bipolars are resting on. I don't know why they did that. A good set of bipolars, the insulation will come all the way to the tip, and the only thing exposed will be 1 or 2 millimeters of exposure at the tip of the bipolars, whether they're sharp or fat bipolars. So please be aware of your bipolars. I have seen so many good surgeons using standard bipolars, and they're coagulating by looking at the tip of the bipolars, and behind them, guess what? There's a vein leaning against the bipolars, and they coagulate the vein. It's not bad surgical technique, it's bad equipment, and it's your fault for not insisting that your bipolars have insulation all the way up to the tip. So please think about that when you buy your next set of bipolars, that the insulation comes all the way up to the tip, that you have bipolars for glioma surgery and bipolars for subarachnoid space surgery.
The other part was, after you've seen connectomics, and as you said that there's a lot of heat dissipation with the broad ones. So has it made any difference in your surgery?
No, it's not made no difference.
Okay, thank you.
Thank you. Dr. Ashish Tandon will be presenting the endoscopic interlaminar approach for migrated lumbar disc. Dr. Ashish, please.
Good morning, one and all, and thank you for joining and coming to Jabalpur for this meet. Today I would be trying to allay the fears of use of endoscopy for migrated discs. So basically, when we are doing migrated discs, especially with transforaminal, the rates were not, or the results were not that encouraging. And perhaps that was one reason why interlaminar was brought in and it was popularized. So I will show you 2 videos, one each of down migrated and up migrated discs. So this is for a caudally migrated disc. So she was a middle-aged lady with severe pain along with low back pain, and there was weakness in right lower limb. And I hope you appreciate this large piece here as well as this down migrated herniation. Almost the whole thecal sac was covered and was involved, and she almost had cauda equina, and this is another piece in here. So extremely large piece. Here I've used a stenoscope, so it's a 8.4 mm scope, and this is cranial here, and this is caudal. 12 o'clock is always medial, and 6 o'clock is always lateral. So here, this is the interlaminar space, and I'm drilling in here. This is the superior lamina. Now, the important thing to understand, when you are drilling, you need to bring the scope a little bit nearer, but obviously away from your drill. These instruments here, the curate is excellent to separate, and then you use your long kerosene to sort of cut open. Now, the important thing here is that you need to see your interlaminar window, and you need to go, you have to decide where exactly you are reaching. So you need to reach far more inferior to sort of deal with the fragment. So again, putting some tension on the ligamentum flavum and opening it. So at this point you can use angle kerosenes or angled through cuts to reach, and be sure, and this is very important, this is where we tend to make mistake, is we don't go lateral enough. That is an extremely important step, to go lateral to the nerve root. That's very important to avoid nerve injury and for you to successfully deal with the fragment. So here, as I was opening, there was a fragment that popped out, and you can easily see the root which is inflamed below. So here is the root, and I am gradually cheesing out the fragment in here. So basically, you need to upcut or drill the part of superior articular process as well as the inferior lamina in this case. Now here, this is the axilla. So here is the root, that's the axilla. So after this fragment was removed, I wanted to go further inferior to, sort of reach to that part. And the important aspect here for a down migrated disc is where you're docking. So it needs to be a little cranial so that you are looking downwards. So that is important. So here, this is the axilla here, gradually sort of clearing the compression. And here, using 90 degree to further go inferiorly and clear these fragments. But you would appreciate that all this work is being done with the stenoscope, and there is nothing that is even touching the neural elements. So however, you can do the same job with the simple routine discectomy scope as well. So this is a struck fragment here, which is being removed. And then I introduce the root retractor through the stenoscope and open up the annulus. This has protected the nerve root here, and because I hope you appreciated on the MRI that there is a good fragment which is within the disc as well. So again, confirming here if I have left anything. So this is a bit cranial in here. And because of the 15-degree angle, you are able to appreciate under the neural elements. And here, finally, we are going down inferior, cross-checking again. And as I was doing it, there was another fragment which I could bring in and then remove it. So finally, again, cross-checking, superior, inferior, that needs to be done in all procedures. So this is after I have removed the endoscope. So these were some large fragments, and this is the post-op that we could get. So this is a near complete excision. This was immediate post-op. Now coming to up-migrated lumbar PIVD, and we know that when we are using endoscopy, the results of up-migrated lumbar disc are a little inferior to the down-migrated disc in herniation, especially when you're doing a transforaminal. So here, this is a case with a large fragment going up, almost nearing the end plate in here. Sorry. So again, severe pain and a huge fragment popping out. So docking, and I'll just stop here. I'll just stop here, and I want to show this. Okay, now see, yesterday when we were doing cadaveric dissection, I was talking to a few of the delegates that we need to look at the interlaminar window, and that this X-ray tells you how much bone you need to drill. Okay, in routine cases where there is no hernia, there is no migration. So, for example, this is the inferior articular process. It tells you how much you need to drill to reach to the medial pedicular line. So that's important. So here again, 12 o'clock is medial, 6 o'clock is lateral. On the right you have caudal, and this is cranial. Now here again I would want to draw your attention to reaching. This is the tip of the inferior articular process. So you need to reach to the facet joint. So I am trying to expose the facet joint, getting it cleared here. So, and then I start the drilling at the tip, and then I sort of take it superiorly. So you need to expose the inferior articular process. So this is the inferior articular process that I am drilling. I already know how much I need to drill, and then confirming it on X-ray that I am going sufficiently cranial to sort of pull that piece. Again, using curette and upcut. One of the instruments that you may have noticed was a monopolar that was introduced to me by Mahesha, and sort of he told me to use monopolar as well, and it can be used. So it's a very simple instrument. Here exposing just the part of ligamentum flavum that is required to be exposed. Again, reaching cranial, confirming it. There's always a vessel medial to the pedicle, so you need to take care of that vessel. Then gradually sort of dissecting. There are always fibrous bands, so you need to clear those bands, and this is the large piece as we were dissecting here, sort of came into the field, and gradually sort of you separate it. and then you can pull it out. But again, in all types of discs or migrated discs, there is generally another fragment that you tend to lose. So keep looking and don't be satisfied with one large piece. Herein, I have opened the annulus and sort of trying to remove the free fragments here. And then again, trying to find more fragments going cranially. Again, till this point of time, I have not retracted the root. So, and then you sort of, once space is created, then you tend to use your sheath to rotate and protect the root. And the almost final pieces coming out. See, this is a huge piece which is still left, which we excised. So again, the same routine, looking for further pieces, and these fragments keep coming. This is the axilla here inferiorly, and the root is quite free. So again, keep confirming that there are no fragments left. That is an important strategy and a must. Good hemostasis, looking under the root. And these were the fragments that we were able to excise, and this is the post-op. So what are the outcomes? So with full endoscopic surgery, as you look at this paper, has high success rate for management of high migrated herniated discs. In patients with high-grade disc migration from L1 to L5, TELD is effective and safe. However, for L4-5 and L5-S1, high-grade upward and down disc migration, interlaminar endoscopic lumbar discectomy is the favorable option. This was again a question yesterday by Dr. Patkar, that how does it compare with a microlumbar discectomy, and this is an important paper. It says that though microlumbar discectomy is still the gold standard for treatment of lumbar disc disease, and mainly because of its familiarity amongst neurosurgeons. However, reduced tissue destruction, that's number one, better cosmetic results, with equally good results, if not better. Endoscopy could replace MLD as the first line of treatment for lumbar disc herniations until we have more or lesser invasive approaches coming. So for those who are taking up endoscopy in spine, especially for migrated discs, down migrated disc, do a little bit more of cranial docking so that you're able to look down. For up migrated discs, likewise do caudal docking. Bony drilling, you need to confirm that you are able to reach there till the tip or almost till the tip of the migration, and keep looking for smaller sequestrated fragments after a large piece has been removed. So that is another very important step to look at. Once again, extremely thankful.
Ashish, it is a wonderful presentation. So I have a question. So you are doing squastectomy, actually you are taking out that squastrated segment of the lumbar disc. So do you go with that clearing up that disc proper also?
Sorry, can you?
So you are taking out that extruded segment of the disc.
Yes.
So you go into the disc space
Yes,
and take
yes,
out the always?
Yes, I always go.
Okay.
And I'm not satisfied. Also, sir, with the type of patients we have and the ethos in our country, the first surgery is the most important surgery. If you have a recurrence, then obviously it's a failed surgery for the patient. So
my second question is that in case you find that the disc is quite tough and it is partly calcified, which is usually case in many patients which we see in day to day, so that how do you modify your approach?
So there's no modification. We have one of the largest series of calcified disc herniations with endoscopy. So now we have almost 8 or 9 cases of fully calcified disc. I'm not talking about the floating, fully calcified discs. And we use chisel, which can go through this. You cut the chisel and you excise the disc, almost very similar to how you do this. The use of upcuts are more common. The only place where if the root is highly stuck to the calcified material, then we are just doing decompression and not tackling that.
So do you think that the biportal has some advantage over uniportal?
Okay, so my take on it is, first of all, I'm not into biportal, so, but I feel whatever I have seen, so in monoportal you can do everything through one incision. It's a smaller incision. The amount of fluid and dissection that you do is much lesser.
I think this is even the minimally invasive
Yes,
as compared to the
it's much lesser.
Yes.
So, see, so basically, if you want to jump to the next level, you need technology and you need to invest on it. And that is what is making the difference between biportal and monoportal.
Thank you. Any questions from the hall? Thank you, please.
So, when you speak of microscopic, it is for me mostly tubular. So, microscopic tubular. So, those cases when there is a recurrence or after a long time I am doing the same area, I still feel that my learning curve is not there to take up that challenge of doing the redo, especially the chronic redos with endoscopy. So that is my primary indication. Yeah, apart from that, we are able to deal with all types of disc herniations.
One more question, sir. You are doing monoportal, but still, what is your say on biportal? Advantages and disadvantages?
Again, I think, as sir asked, I am a monoportal person, so I cannot comment on biportal, but generally I have seen that the dissection required for monoportal, it is very precise. You are reaching right onto the inferior articular process tip and lamina, and there is very minimal amount of dissection that you do. So what I feel is, for me, as I see it, I'm pretty happy with monoportal. And then the frontiers are being challenged. There are a lot of people, I think today in itself, Rakesh would be there, Achal, Sukumar, they would be demonstrating how they have taken endoscopy to the next level. So we are challenging the frontiers with monoportal. Sir.
Can I answer your question?
Yeah, please.
So there is always any conference we go debate about monoportal, biportal. So for all the beginners, I would suggest you go and learn both. Then you understand, being a neurosurgeon, what true minimal invasiveness is. So you might think that I would have done a better microscopic discectomy than UBE. Such is the muscle damage you do with UBE. For a simple disc, you are doing a multiple cervical decompression, multiple dorsal decompressions or lumbar decompressions. Yes, biportal helps because you can skip the scope port. And when you are doing fusion, definitely it saves time. But not for a disc, a simple disc you are operating or just a migrated disc, where a monoportal can give a better outcome than a biportal. So why you want to use a biportal technique for that? So, but looking at future, definitely you should learn both, because biportal also has its own role where you want time is the factor. Definitely elderly population, multiple levels, you will require biportal. So today you want to learn, monoportal has a little bit longer learning curve, biportal the learning curve is less, but there are enough studies now to say that the facet damage, post-op hematomas are highest with biportal. So true invasiveness you talk about, then definitely monoportal is the least invasive. Thank you. Sir.
Yeah. You had a question.
I think a lot of discussions regarding this endoscopic, but for the youngsters, I couldn't say that interlaminar microdiscectomy, as you said, that it is still the gold standard for many people. So the youngsters should also learn that technique, that how to do that. And many times you are going from the one side, okay, so that central disc, which is also going to the opposite side and compressing the exiting nerve to the opposite side also. So it is a very simple technique, and it doesn't require very fancy equipment, and you just have around less than a 2 centimeter of incision. You are not going to the muscle, you are taking through that natural corridors, through that muscle interfacials, intermuscular spaces. So it is also one of the minimally invasive technique. So without any fancy equipment, and it has got excellent results. So we have been brought up in that atmosphere, and endoscope has actually added to it. So that technique is also should be learned by all. Yeah, I think Dr. Patkar can.
See, the people with more gray hair, they are talking about microlumbar, like me, Manmohan. And those with more black hair and new hair are talking about endoscopy. So this thing is going to go on. But I will tell you, for everybody behind, I agree completely with him. Microsurgery is the mother and everybody else is the children of microsurgery. First learn, the microscope does not change where is the pars. The microscope does not change where is the facet joint. The microscope, whatever gadget you use is immaterial. First learn the anatomy, learn good open surgery. What happens, I am seeing the trend nowadays is to attend 1 or 2 workshops and start with endoscopic surgery. And then end up with disasters, and gradually they'll learn. I come from the city which is the birth of endoscopy. In fact, I did a lot of endoscopy before, and I reverted into doing microsurgery, maybe because I've become impatient with passage of time. I do occasionally percutaneous transforaminal, but I feel that first you should learn good spinal surgery. Secondly, unless and until you're a good spinal, you cannot treat the complications of endoscopic surgery. Because of this, the city where I work, because of my age, I get patients which have undergone incomplete decompression or post-operative instability. And then the endoscopic surgeon calls me up and says, "Sir, will you please take over?" You should be able to solve all the complications also. And that you can learn after you have learned proper spinal surgery, microsurgery, endoscopic surgery. These are higher and higher steps, like the 36 chamber of the Shaolin, that movie is there. The last step is 36 chamber. First learn. If you don't learn the first steps and suddenly jump, people like me, Parthiban, when we started, that time microsurgery, Dr. Ramani started microlumbar discectomy, we progressed on to that. Parthiban, what are your comments with what Manmohan said?
Yeah, the mic was with me by the time you have taken. See, basically, we all started with microscopes, right? And earlier, our teachers were without microscope; they were doing laminectomies. I do not know how many of you listened to Professor Balaparameshwara's lecture. Professor Balaparameshwara lecture. He said he has done 5,000 laminectomies for disc prolapse, and he was happy. Believe me, now he is no more, but then I have to bring back to the younger generation who may not know that generation at all. Dr. Balaparameshwara has removed very big spine, lamina, then goes to lateral. Bilaterally he does. And that time, the biomechanics was not well taught to us. Subsequently, there is one monogram written by Dr. Kalyana Raman. I do not know how many of you know Kalyana Raman. Senior surgeons will know. Professor Kalyan Raman has written there, he does not need a microscope because he is having myopic eyes. And then he said one thing, why should the patient come with a radiculopathy and also back pain? The back pain is coming from the facet joint, and he was removing the facet also. This happened 40 years ago, 50 years ago. But later on, the generation changed. Professor Ramani came, introduced microlumbar discectomy, and we were the forefront students, myself, Patkar, and then we promoted, we have written books, we have written articles, many. Subsequently, in the meantime, the technology comes in. The technology comes in, and young generations have come. And we have to accept only one thing very clearly. We should know about the biomechanics. Because of the biomechanics came in, endoscopy came in, percutaneous came in, and endoscopy monoportal came in, and then Sukumar is speaking of biportal. So each one is doing, but final result is that we should have a good neural decompression. So my personal feeling is now, after this, how to tackle the bad situation, that is what we wanted to encourage. Here, there is no need to discuss about which is good, which is not good. How will you tackle the problems that come when you are taking up one particular technique? Can you say that this one particular technique, as you said rightly, again on the secondary cases, you don't like to get into with your monoportal. Sukumar, I do not know how many secondary failed cases, repeated cases, calcified, those things would you still like to do or slightly open it with a microscope? Because you also drive the microscope. Am I correct? So what I am trying to say is that as you rightly pointed out, our generation feels that first you should know a good microlumbar discectomy. And after that, if you do this monoportal or biportal, you see how easily you will do it. You will do it just like that. The problem with you is that the moment after you are passing, you are taking up on one endoscope. And so when you get fail, you are seeking the seniors. You are sending it, sir, what can I do with this? Can I remove it? As Ashish was talking about it, there are so many surgeons who are not removing, I am not talking about all, are not removing the intradiscal part of the disc, and it comes out within about 1 month or 2 months, and subsequently the patient does not go there. He goes to some other doctor. So these kind of things are going, this is an evolution of technology. But the important point to the students is that they should know microlumbar discectomy first. And then you take up all these instruments, and there are beautiful teachers, they are there. So we have to be very careful with that. Thank you.
I think that's wonderful comment. So my just closing remark is that interlaminar microdiscectomy is a minimally invasive technique. It is hardly less than 2 centimeter incision, and you can do everything. So I'm not discouraging, but thing is that you should also learn that. Thank you.
Ashish, excellent talk. Now I would call Dr. Rakesh for monoportal endoscopic lumbar canal stenosis decompression. Dr. Lohana.
Good morning, everyone. So next talk monoportal endoscopic LCS decompression. So once you have sufficient experience with endoscopic discectomy, ipsilateral lateral stenosis, you move on to contralateral decompression. So I will share this case in video. So this was a 68-year-old lady who had a bilateral leg pain and was unable to stand more than 10 minutes, unable to walk more than 100 meters. And that was going on for 6 months. She was pulling on. And for last 1 week, she presented with a acute severe right leg pain, which was round the clock with right foot weakness. On examination, she had right EHL ADL weakness grade 3. And there was mild back pain. And that was her MRI, which was showing severe L4, L5 stenosis with, I think, either a small, we expect recent deterioration, maybe there may be a disc component as well. And axial, you can see this severe canal stenosis at L4-5. X-ray flexion extension is mandatory to rule out dynamic instability. There was no instabilities. So my plan was to do a monoportal endoscopic LCS decompression. X-ray AP view also becomes important in endoscopy, where you would see the basic window, how much bone you need to remove to decompress, and how laterally, how far is the pars. You have to preserve the pars so that inadvertently you should not be doing a pars excision, otherwise post-operative instability may occur. So AP view becomes important in endoscopy. So this procedure is performed under general anesthesia, prone position with bolsters. This is how endoscopy suite looks in anesthesia trolley. My C-arm, I will be standing here, and patient, myself and the monitor comes in one line. C-arm monitor would be on the leg end side. The first thing is docking. So docking is done at the spinolaminar junction. So my target to dock here. So incision is around 1.2 centimeter and first dilator goes in. So basically it's a single dilator system. The first dilator gets in, you check in AP, then you get sheath and you remove the dilator and then you insert your scope. That's how you begin, and that's what you would see. So that's a rostral, that's caudal, that's medial, that's lateral. So there was RF and plasma. So you identify anatomical landmarks. You start drilling with a burr and you begin at the level of spinolaminar junction. So inferior aspect of the superior lamina, just as in MIS or open lumbar canal stenosis, lower aspect of the superior lamina is being drilled. So drilling is very important technique in endoscopy. Just in neurosurgery, drilling is integral part to get better at endoscopic techniques. Drilling is very, very important. So your hands should be stable and drill, and the sheath should move in just as a single one unit. So you start drilling outer cortex, marrow and inner cortex, and so drilling medial to lateral, and this is I am coming to inferior articular process of superior vertebra. I am coming towards midline, towards the base of the spinous process. And then you can use punches to take out the inner table, and you can see that's a midline and that's a superior aspect. So you drill till you see the upper margin of the ligamentum fluum attachment, and then you use your punch from medial to lateral, take out the lamina, and you come towards IAP. So basically you separate, you see margins all around of the ligamentum fluum. You reach to the inferior border, and that's an inferior lamina. You drill superior aspect of the inferior lamina, or you may use punch. Yeah. So that is the inferior vertebral, superior margin of the inferior vertebra, and you start drilling. Take out the outer part of the ligamentum fluum. So basically you drill contralateral base of the spinous process, go towards opposite side, and till you see the opposite side of lateral margin of the ligamentum fluum, and then you start using punches to take the ligamentum fluum out. Either you can take complete ligamentum fluum out in a single piece called the butterfly technique, or you can use a piecemeal taken out with a punch. So there you can see thecal sac, and you start taking ligamentum fluum out in a piecemeal way. You have to make sure that your sheath stays towards laminar attachment, and you should not be pressing with the sheath to the dura. That's the ipsilateral traversing route. So coming to the contralateral side, and so that's foraminotomy being done. So that's ipsilateral foraminotomy, taking medial facets, and you can see the disc level there. So etching hemostasis is also very important. So this is contralateral side, using punch and taking out contralateral lateral. This is decompression. So you go lateral to the contralateral traversing route and do a foraminotomy there. So you can see that contralateral traversing route. Lateral margin of the ligamentum fluum is being taken out. So there you can see a fat lateral to the contralateral traversing route. So inferiorly, you have to make sure that you reach till superior aspect of the inferior lamina and take out the ligamentum fluum completely. So supro, inferior, medial, lateral, on all sides, you should go lateral to the ligamentum fluum and take out the ligamentum fluum completely. So that's a contralateral lateral recess and contralateral nerve root, and doing that contralateral foraminotomy. So contralateral superior compartment is clear. Now contralateral inferior compartment, and freeing that near the foramen area below the level of the disc. So basically you divide into 4 compartments: ipsilateral upper compartment, lower compartment, contralateral upper quadrant and inferior lower quadrant. So it's basically 4 quadrant decompression you do. That's the disc. As there was ipsilateral acute right leg pain, we found that acute fragment. It's using RF to coagulate the annulus. So that's ipsilateral traversing root. You see lateral to it. You make sure that ipsilateral root is free. There is no more compression. That ipsilateral foraminotomy. Then you check over the top. Go lateral to the contralateral root and confirm that contralateral lateral recession is free and contralateral foraminotomy has been done. And once you are satisfied with adequate decompression, then you come out. And that's how you close. It's just single or 2 stitches. So post-operative protocol, we use usually 3 doses of IV antibiotics, high sitting ambulation on the same evening, climbing stairs next day, patient is discharged on next day, and suture removal at 10 days. And how does it look on post-operative imaging? Like this is another case, but you can see 4 or 5 severe stenosis, post-operative MRI, axial view showing this was pre-severe stenosis with a disc herniation, and that's a post-op. You can see excellent decompression with very minimal footprint behind. And how does it look on CT? This is the post-op CT. You can see that's how much bone you remove post-operatively. So you preserve this spine, interspinous ligament, preserve this facet, and through this just window you complete your decompression. Learning points. So it's important that you study your preoperative MRI and X-rays very carefully. Divide it into 4 compartments and for the pattern so that decompression is ensured. Preserve ligamentum fluum till bony work is done. In initial cases, get a post-op MRI, it will help you get better. And begin with single level stenosis, and once your operative time is reduced to less than 1 hour, then only you should switch to multi-level cases, and don't get disheartened by initial struggle, as every expert once was a beginner. Thank you.
Thank you, Dr. Sushil. Any questions from the house?
Yes.
Wonderful presentation, Rakesh. So, what is that? What are the difficulties you face while doing endoscopic stenosis decompression? Is it the ligamentum flavum removal, tackling the epidural bleed, the dural injury, opposite side decompression? What is that you find difficult?
Yeah, that's very important question. So during learning curve, what I found difficult was over the top decompression, contralateral bony drilling. I have to be mindful of the sheath. My initial case is that sheath was pushing on the thecal sac and bleeding as well. Contralateral lateral recess bleed was also an issue. Contralaterally taking up SAP, drilling of SAP was also a difficult in initial cases. So yes, it does have a learning curve, but if you start drilling properly and if you take out spinous process well, I think that taking care of hemostasis at all steps, probably it would be easier. And while drilling, I have switched over now to use diamond burr to reduce bony bleed, especially in osteoporotic patients. I found that while I was using cutting burr, the bone bleed was higher, so I switched to diamond drill. Yeah.
In some cases where is ligamentum flavum badly adherent with the Duran root in contralateral side, if there is dural tear in root prolapse, how you will manage it?
So, endoscopy is basically does hydrodissection. So, and your magnification is quite high. So,
these are the rare things.
Yeah,
Rare,
rare thing. So, so if there is a small dural tear, I still proceed. But if there are dural rootlets coming out, once that happen, I switch over to MIS. I use tube and tackle that.
I think that is a very important question.
Reposition is very necessary.
Yeah,
one has to reposition the root inside, apply a clip and put a glue.
Yes.
And that is enough.
So my question is that because in monoportal always doing underwater, so if there is a CSF leak without any obvious injuries, which is visually perceptible, how do you identify that?
So basically, sir, at times there are surgeons who have started doing intradural work as well. So irrigation is not that harmful. If the pressure is less, then it's manageable. So in a dural tear with monoportal.
My question is different. My question is that if there is a tear which is not visually, you can't see that, because in microscope, if there is a tear, there is a CSF leak, because we are not working underwater.
Okay.
So
if there is kind of puncture kind of tumor, if you don't see it, probably it will seal on its own, probably, because in a monoportal the window is very small.
Yeah.
When you come out, there is hardly any dead space, so probably it would heal.
Sir, in endoscopy, because of the saline irrigation, your field is so clear. Even at the smallest of the smallest puncture, we can see either a arachnoid prolapsing or a root seen through the defect most of the time. So, if saline irrigation is not proper, or there is intraoperatively lot of bleeding from the bone, or epidural bleed is there, definitely surgeon can miss that. And roots are prolapsing out, definitely you can see. But a small puncture can be missed by even an experienced surgeon if there is bleed. But if you have done a good hemostasis end of the surgery, most of the time we can identify.
Rakesh, how do you deal with multi-level stenosis, and how do you deal with the fatigue, and what is the time duration?
So I see 2.5 to 3 hours is my maximum time. So I have done till 2 level. More than 2, I might switch to MIS. So I begin with endoscopy. If I see I finish 2 levels in 2 hours, I may do another 3rd level with MIS.
No. Rakesh runs in the morning. He runs about 10 kilometers to improve his time. You are not telling that.
Yeah, thank you. So fitness is important for every surgeon. So
Yeah, so I do regularly 3 levels now. To begin with.
So that's what I'm saying. If your 1 level duration falls less than 1 hour,
Yes.
then probably I would. So my total duration I would feel at a 2.5 to 3 hours is max I would do endo. If I am pulling beyond that, I would definitely switch over to MIS.
The more you experience, you become an experienced surgeon, you do faster. The steps are simple. So initially, not more than 2 levels. Now I do 3 levels regularly. Yeah. So main thing is the drilling. So fear of drilling, you start with diamond burr, but as you gain experience, you use more cutting burr, which is faster.
Right.
And with the current Kerisons which we have now, so we can do it more faster. Yeah.
Thank you.
Thank you, Dr. Rakesh.
Yeah, thank you.
Sir.
Thank you, Rakesh. I would call Sukumar. Yeah. Because I saw Sushil there. He is going to speak on a endoscopic fusion with listhesis.
Good afternoon, everyone. So, since morning we are debating whether to, which is the gold standard for microdiscectomy. Definitely for discectomy, lumbar discectomy, open discectomy, microdiscectomy, endoscopic assisted or endoscopy, most of them done correctly, they are equally good. But when we talk about beyond discectomy, so what is that we should learn? So definitely endoscopy is picking up as we saw the cranial endoscope advancements. Definitely spine endoscope advancements are now being done. Endofusion, thoracic surgeries, cervical surgeries, and we have started even doing intradural tumors also. So when you talk about endofusion, my own evolution started with open fusion. Then I used to do a lot of MIS fusions. Then still there was something which we could have done more or better or less invasive. Then switched over to transcambin fusion. Again, transcambin fusion has its own limitations. So then switched to posterior fusions. Then we have developed our own technique called ASERF technique, where we resect entire en block, facet, pars and lamina as one block and use it as a good autograft. So it's a bridge between monoportal and biportal technique. So today I'll be showing both techniques so that you can have a bird's eye view on both. So transcambin approach is the approach where you go through the Cambin's triangle and do the end plate preparation and insert a cage for a case where you have decided you need to do a fusion in that patient. Something like this. So I'll just go through a case, a young lady, 35-year female with significant back pain and left leg pain with grade 1 listhesis and instability like this. And you intend to do a fusion in this patient. So what I have done is already I have put a guide wires. Nowadays I don't put guide wires, this is an older video. Then you just take a true AP, true lateral. The key here is you land, when you compare to transforaminal disc surgery, you land more medially because you need to go more ventral. The key is the needle position. You can do it under monitoring. Nowadays we do under now monitoring. We have a probe where we can use it as a root stimulator. So once the dilator goes there, this can be done under local, epidural or general anesthesia. I started doing under local and epidural. Now I do all my cases under GA. So once you are there, you just tap the dilator into the disc space. The dilator, when you see AP lateral, it should be in lateral, if it is anterior, in AP it should be just crossing the midline. So this allows your cage to be more anterior. Once you are there, here you can do a blind C-arm guided decompression, because nowadays we have tools, expandable reamers, but I always use a scope to debride and remove the disc and the end plates, cartilage. So you can just debulk the pulposus and see the end plates, both cranial and caudal. So you can use articulating curettes to remove the end plate cartilage. You can see the nice end plate, but adequate preparation is the key. So in transcambian approach, time is very important. You should not stay there for very long, because chance of traction on the exiting route is there. So you should be careful. So once the lower end plate is done, switch to upper end plate, remove the saline irrigation allows you to flush out the fragments. Now we have mechanical debriders also, so that our work is faster. Endoscopic CUSA is coming up maybe in 1 year we get an endoscopic CUSA also, which is flexible, so we might have a faster end plate preparation or interbody preparation in future. So you do a curettage, both lower and upper end plates, create a good end plate preparation. So now you can see both upper and lower end plates are seen nicely. Good petechial bleed is seen. Once this is done, then you can pack the graft. So biggest drawback of transcambian is here you need to use some synthetic grafts. Either you use a allograft from the bone banks, or you can use a synthetic graft which is available in the market. So it increases the cost. So once it is done, you just pack this area with a good graft, whichever graft is available. So here I am using a Kronos by Medtronic. So that's a epidural space, that's the end of your annulus, that's a traversing area. If any stenosis or need to address the traversing route, we can address the traversing route also. Now I pack the graft, I push the sheath inside. Here I am taking a bone marrow from the iliac crest once and mix it with the graft. This is available in the market, the calcium graft. So pack it as anterior as possible. So this is a key for a good interbody fusion. This we need to learn from our orthopedic colleagues. Always learn the fusion techniques from orthopedic colleagues. You want to do a good fusion, you always want to have. So you can fill the graft here also. This is a designed case which is a tapered tip. So nowadays we have a lordotic cages also. Here you can stimulate the nerve while going inside. We have a monitor probes now. You can tap the cage inside. You can see that the cage is nicely sitting as anterior as possible, and you remove the handle, then put a scope inside again. I always put a scope inside to see any graft is dislodged or any root dural injury is there. So that's the exiting root, nicely preserved. That's a cage inside, sitting inside. Any graft here dislodged, you can remove it, and that's the end point. So that's a post-op X-ray. So limitations, as I said, if you are dealing with a case like this, definitely stenosis decompression need to be done. Graft, as I said, you have to rely on allograft or synthetic graft, and radiation, definitely transcambion has more radiation exposure. So then you can modify, you do a transcambion interbody work, then you can do a posterior decompression. Again, it takes time. So to circumvent that, you can go posterior, where you can do a regular, as we do with MIS fusion. You can go there, remove the facet, and do a fusion from posteriorly. So again, we have just modified this technique where to have a more graft, so we remove the entire bone as one block, the facet, pars, and the lamina, which I will be showing something like this, where you need a good bilateral decompression with a good graft. We can do this with a en bloc removal of the bone. So we land just medial to the, at the medial pedicular line, junction between the facet, lamina, and pars, where we can address all the three. The isthmus of the pars is seen easily, this joint line is seen easily, and the medial part of the laminospinous junction is seen easily. So we can drill and remove the entire bone as one point. So for example, this case where there is a grade 1 listhesis with stenosis, so I'll just, you can see here, this is a case where a similar case as previous, but more significant stenosis, bilateral disease with degenerative listhesis. So we can go posteriorly very easily and do all the things at one go. So landed laterally, keys, we should be in line with the disc space. Because we are doing monoportal here, our dilator should be parallel to the disc space. So here I am standing on the left side. So I just few minutes will go through just this video. So I'll just exposing the lamina, and just exposing the lamina as we do in any microsurgery or MIS surgery. So exposing the lamina, so that's the lamina ridge. Facet is towards the 6 o'clock. So what I am doing is I am just drilling the, making a trough so that we can chisel it out and remove the entire bone as one piece. So I am just drilling the laminospinous junction here, making a trough so that I am just decorticating the outer cortex. I can easily remove the, then I am going to the upper aspect of the lamina. I don't want to remove the entire lamina. I will just remove the lamina till the ligamentum flavum attachment. So that's enough for our stenosis decompression surgery. So as I come lateral, you see the pars. So that's the pars. So the glistening white is the pars. So that's the pars. Pars is a most compact bone. So you see it as a glistening pearly white bone there. So I'm just drilling the pars, taking a C-arm shoot here so that I am flush to the upper pedicle. So once I do this, before this I will detach all the ligamentous attachment to the bone so that removing the bone becomes easy. So once I do this, I have detached marked the spinolaminar junction, marked the pars. So now I'll take a custom-made endoscopic chisels. So I just start chiseling it. Don't go through and through. Just 2/3 of a bone chiseling is enough. So just come cranial, slowly come lateral. So you can see the clarity here because of the saline irrigation, and you do it properly. You get a very good vision what you are doing. So now I am cutting the pars. So this is a pars. So pars need to be cut through and through because it's more tough bone. You can take a C-arm, help here, take shoots in between, just go through and through. So here what are we getting? The partial lamina and entire facet, inferior facet and the pars. So such a big is the graft we are getting. And again we anyway remove the tip of SAP once we remove this. So that's epidural space until the ligamentous attachment cranially. Once we do this, just use a curette just to remove the bone, lift the bone. That's epidural bleed. Just tackle the epidural bleed with RF. Lift the bone. So biggest advantage here is the graft. You are getting such a big autograft, and with this we have last 3.5 years we have done around 400 cases, and we are seeing fusion rates as early as 8 months. So good fusion starts because you are using a autograft. So I detach the entire bone. I take a bigger punches and just come out with the scope. See, I'm just coming out, the sheath is coming out, leaving the bone in the subcutaneous plane, and I just deliver it out like gallbladder we do with laparoscopic surgery. You just delivered it out, the entire bone. Go inside, remove the superior facet tip, and then from there surgery is same. I've retracted the root with the sheath. Now I'm just entering the disc here. The cranial side is the exiting root, you can see there. So I'm holding my sheath is holding the traversing root. So now I just use its normal shavers which we use in open surgery. Once it is shaved, the end plate cartilage which is remaining, I just remove it. See the clarity and the completeness of your clearance. That's the end plate, and you can go as anterior annulus. Now I pack the autograft. You get roughly 8 to 10 cc. You can pack as much as possible depending upon the need. So pack the graft, pack it as anterior as possible. And what I do, a different technique here is, I am using the screw port for the case incision. Whatever case I use a screw port, the same way I use a cage, so that I am visualizing. Till now I was doing monoportal, my dissection was very limited. Now I am just dilating the tract, and with this I use a cage goes through this port where I will put a screw later. So this is the cage which came inside. So I am completely visualizing what I am doing. Previously in the transcranial approach, everything was blind. So if there is a anomaly, you might injure a root there. But here, everything you are seeing, same like our posterior fusion. My assistant will hold the root with a dissector or a retractor. Then the biggest advantage is you can put as bigger cage as possible. I have put 16 to 17 mm cage in individuals who require a bigger cage. So this is a static cage. We can use an expandable cage also if needed. So I just put the cage. So the entire thing is visualized. You can do a stenosis decompression, root decompression, ipsilateral, contralateral with a good graft packed anteriorly and cage insertion. So that's the beauty there. So this is the end point. These are just 1 minute. So are a few examples. Grade 2 listhesis done easily. So listhesis with again stenosis done reduced easily with a good stenosis decompression. Grade 2 listhesis again. They are the very difficult cases. done very nicely. You can do it because have a control. You see what you are doing. You can 2 level, 3 level can be done easily if you gain experience. And as Rakesh said, your fatigue is not there. This is a end point I am telling. These are some of our follow-ups. You can see this is 8-month follow-up in a patient. See the interbody fusion because of the autograft. Excellent fusion. This is one more case. You can see the nice bridging of the interbody there. So this is 1 year follow-up. And this is one more case. You can see the fusion posteriorly and anteriorly. So this is all because we are using autograft. So these are the outcomes. So definitely a fusion correctly understood, as our seniors were telling, you need to have a very good understanding of open anatomy. If you don't have a 3D anatomy, your MIS miserably fails. So you should have a good understanding of 3D anatomy. You can do wonders with endoscopy. Thank you.
Thank you, Dr. Dr. Sora. And any questions from that house?
Fantastic. Very good demonstration, Dr. Sukumar.
Thank you. Developed a probe where we can use that. So
where do you position that probe?
Yes. So when you are putting a needle or a dilator, we can use that probe to stimulate whether any nerve is in the vicinity.
Okay, you
so can
stimulate on the sheath.
Yes.
Okay, yeah, thank you.
Yes.
Hi Sukumar, and welcome to MP once again. And it is always a nice treat to watch your videos and your work. Just one question is, there is a lot of discussion in indirect decompression and direct decompression.
Yes.
So what is your view on that, and when will you consider a patient who is fit for indirect decompression or a direct decompression, or when will you consider a patient for indirect decompression?
Yeah, so I keep asking this question to my orthopedic colleagues, or rather big spine surgeons who do a lot of O-lifts, where they say that there is a 3D modification of the canal only if you do an indirect decompression alone. But there are a lot of limitations for that. So I was talking to Dr. Amit Jala last time. He has some indications for direct decompression. When patient complains of pain, even on lying down, he always do direct decompression. Second, when there is lot of subarticular stenosis, entrapment of the root, so he does direct decompression along with indirect decompression. But beyond that, he says all my cases indirect decompression helps. But to do a good indirect decompression, indirect jacking up the height, you need to have a good lordotic achievement. You need to have put a oversized cage for that. And if you are doing a transcambian approach, and more than 10 mm, in my own experience, more than 10 mm cage you are using through transcambian approach, patient will have bad paresthesias and sometimes even neuropraxias also. So that's why I have shifted to posterior approaches more now, because you have a control, you are seeing what you are doing. And definitely if there is a foraminal pathology in the MRI, I always do direct decompression.
Even in my view, actually, being a neurosurgeon, what happens, patient come to us quite late. Even when he comes to us, he is already having a symptoms for maybe 6 months or 1 year. So there is a lot of paraspinal, parafacetal and paraligamental changes. It is always nice to decompress and then I think fix.
And one finding what I have seen my own cases when I do indirect decompression alone, patient has some transient weakness also. Because you are distracting without decompressing, patient will have neuropraxia. So that's why we have seen some element of neuropraxia post-op in indirect decompression cases. So that's why I stopped doing indirect decompression. Always being a neurosurgeon, seeing the nerve is always a pleasure. So we do direct decompression also.
I have a point to make here. See, indirect decompression is nothing but so when you open, when you are doing it, I think you feel that. You feel it is distracted. You get distracted, oversized, slightly over 1 millimeter, 2 millimeter oversized cages will work up for that. There should be an obvious osteophyte. Unless it is obvious osteophyte and the foramen is filled with the osteophyte, cannot compress. So I think better to see it than do
Direct
it.
decompression is always better.
We should not go with a fixed mind that I'm going to do indirect.
Yeah.
And unless you have a ligaments are good and ligamental taxis is there, and that comes only on the younger generation people who are not very old. Very geriatric patient, I don't think that it is possible.
I'm from era of Phillips. We did posterior lumbar into body fusion, then transforamen. I never needed a cage more than 10 mm, 11 mm.
Yes, sir.
This new thing of 15 mm cage, 16 mm cage.
Yeah.
What is the normal physiological height in the lumbar spine of a disc? To a person who's 55 years old. So I think there is a big study which was published recently where Paul Lynn actually had put this concept that there is no need to put tricortical grafts, just curate, put bone chips and fuse in that position, and the results are equally good. All this jugglery to try to push, then say whether the exiting route is going to get stretched, whether the patient is going to get post-operative paresthesias. Paul Lynn never did all this. Paul Lynn did just curated the disc space, put bone chips and put the screws and locked it.
Yeah, there is a lot of debate how much disc removal is adequate, how much end plate preparation is termed adequate. So there is a lot of debate on that also.
Yeah, Sukumar, see, there is also we have to understand one thing. We distract, put the cage and then compress it. Right? So we should have a very nice mind and also should be very clear how much we are going to distract and how much we are going to compress. Because we have seen surgeons who are distracting. You see you see the X-ray lateral view, it's like a crocodile opening its mouth. And then the graft is in the mid without being compressed. So when you compress, some people have compressed in an osteoporotic bone and crushed it completely. Yes. So all these things we have seen over a period of time. So it is, I think everyone have a personal experience and we learn by age, by cases.
Yeah. Concept of treating the imaging is entirely different. Nowadays the concept of treating the imaging. Second is some say is the philosophy of the ligament of hypertrophy.
Yeah.
And that is an entirely different concept. In that cases the indirect decompression and direct decompression comes. But most of the cases we feel is there is always in stenosis some component of the ligamentum flavum is there. And in that case direct decompression is important. And
yes. So most of our patient comes late, so better to do decompression. Thank you.
Thank you, Dr. Sukumar. So our next speaker is Dr. Dwarkanath. He'll be speaking on a role of bypass in aneurysm, sir. Dwarka. So, yeah. Sumit nahi hai.
Thank you. Sorry, I have to leave for Bangalore. So this was a talk, instead of Dr. Sumit Sinha, and recurrences. So these are cases which have been basically sent to us by our endovascular colleagues, which they have not been able to treat endovascularly, and you are going to come across these cases in your practice, and you'll be wondering what to do with them. So these are some giant aneurysms, basically complex aneurysms, whether They are larger giant, dissecting aneurysms, calcified aneurysms, blister aneurysms, those which cannot be treated, recurrent aneurysms. So the first question you need to ask is, can you be clipped? If it can be clipped, you should go ahead and do it. It gives excellent results. For example, all these aneurysms, this is a giant IC aneurysm, this is a basilar top, these are multiple aneurysms, this is a giant ACOM. All of these aneurysms can be clipped once you understand the anatomy carefully. For example, this multilobulated MC aneurysm, which is a trifoliate involving the MCA trunk as well as the MCA branch, M2s, can be clipped, rather reconstructed. So this is the aneurysm. Just for want of time, I'll just go through it. If you see both the M1 and M2, this is an M1 aneurysm and it's not continuous, so you need to reconstruct it. So which is what we did with multiple stacked clips. So this is how you reconstruct an aneurysm. Similarly, the trifoliate aneurysm. So the question is, what if it cannot be clipped? Then you have to evaluate for bypass. So these are some aneurysms which are very difficult to clip. For example, how are you going to reconstruct this aneurysm? Or for matter this aneurysm, or for matter this aneurysm. These are aneurysms which cannot be clipped, and for that you need an alternative treatment. So the question is, you need to ask yourself at what type of bypass will you use, whether it's a low flow bypass or a high flow bypass, and it has lots of anatomical issues as to the size and donor and the recipient vessel, what graft you are going to use, etc. The one thing which absolutely helps you is the balloon occlusion test. If the patient fails balloon occlusion test immediately, then this patient is not going to withstand occlusion. You need to actually do a high flow bypass. But if he withstands BOT for some time and then falls down with hypotensive challenge, then you can do a low flow bypass. For example, if the patient withstands both occlusion as well as hypotensive challenge, you can just ligate, especially in older people more than 75, do an ICL ligation. Results are very good. So these are the types of bypasses. I will not go through it in detail, the interposition graft, side to side ECA M2. I'll just quickly run through them. So basically bypasses are divided into low flow, intermediate flow and high flow bypasses. So that depends on the flow rate. So the classic example of a low flow bypass is your STA-MCA bypass. The intermediate flow is your pica bypass, and the high flow is using the radial artery or the saphenous vein as an intermediate graft to do the bypass, and these gives almost 130 to 130 ml per minute. There are differences between radial artery and saphenous vein. This radial artery has lesser chances of occlusion, but it's a shorter graft. So of course you need a very good team, and the sutures are 10-0 for a STA. For the high flow we use a 8-0 and a 6-0 in the neck. So I think for the want of time, I'll just quickly go through this low flow bypass. This is for a moya disease. So this is the ECA which has been, STA which has been exposed. Then doing the craniotomy. This is the STA over here, opening the dura. So the technique of a low flow bypass is similar whether you're doing it for a moya disease or for a or for an aneurysm, because only the donor location, recipient location changes. So this is fish mouthing the donor STA, then you are going to occlude the segment where you are anastomosing it to, making the corticotomy, making the vessel opening. You do the fish, you do basically what we call the heel stitch, the toe stitch and the two sides. So the place where it lands is the heel stitch. So that is taken first. Then the place where it goes is the toe stitch. That is taken next. Then you do the side stitch. You do the distal side first, and then you do the proximal side the last. We use 10-0 or 11-0 ethylon. So we use interrupted stitches. So this is these are the side sutures which are being placed, and once we do the one side, then we go back to the other side. So this is done almost under 25x to 30x magnification. So these threads are very, very, very thin. So then at the end of this, you have to get a you get like this. We do an on-table ICG to check the flow of the blood, and once that is done, we are sure that the graft is patent. So this is the entire principle of the graft. For example, this case in which the aneurysm is coming from the M2. So there is no way of clipping this aneurysm. We'll have to sacrifice the M2. So instead of that, what we did was, we did a bypass to the M2 distal through the aneurysm. And then you can see that the flow for one M2 is from the ICA, while this is from the ICA which continues to be, while the flow for the other is from the ECA, which is STA, which is going into the distal M2. So both the M2s have different supplies, one from the ECA, one from the ICA. So similarly, where these cases where we can get away by blocking one vessel, we do a low flow bypass, or we do a complex MCA double barrel bypass. So sometimes we do a rescue bypass in case we are finding that the parent vessel is getting partially occluded on table. So this is one example of a rescue bypass, which is basically an augmentation bypass. So this happens when we feel that there might be a decreased flow after clipping the aneurysm, so we augment it. So you can always, for example, this multiple aneurysms of the pica, which is a single pica, one pica is absent, there's only one pica which is coming from the left side. If you see right side has no pica, there is no way you can treat this aneurysm with the conventional endovascular or microsurgical clipping. Multiple aneurysms, you need to reform the pica because both the picas are, the entire pica territory is from this one vessel. So we did the occipital artery to the P2 bypass. I think for the want of time, I will not go through it. So if you see, we have taken the occipital artery, anastomosis to the pica distal to the multiple aneurysms, and gone back. I'll just show you that part where we are. So we have anastomosed the pica to the, occipital artery to the pica distal to the aneurysms. You see, these are the multiple aneurysms along the entire pica course. Now this is going to be trapped. So you can see the two segments which have been trapped. And then you do an ICG, which shows filling of the doesn't seem to be there. But anyhow, we can see the post-op DSA showing good filling of the pica from the occipital artery donor. On the other hand, high flow bypasses are done when the patient has failed a balloon test. For example, giant thrombosed ICA aneurysm, where we trapped the ICA and did a high flow from the cervical carotid to the M2 segment. So similarly, these patients, these are patients who cannot be treated with the conventional methods. The giant dysplastic MC aneurysm, there is no way we're going to treat this with any endovascular method. So for this, we did a high flow bypass, and you can see the bypass functioning and the aneurysm completely disappeared from circulation. Similarly, you can do it for the giant cavernous IC aneurysms, complex IC aneurysms. This is a bilateral cavernous calcified aneurysm with vision loss. This is a high flow bypass. So again, a ruptured giant IC aneurysm with a high flow bypass from the cervical ICA to the M2 segment. Similarly, I mean, you can do it for such difficult cases. I mean, you see this serpentine MC aneurysm. This patient is not going to be treated by any other method, so you have to do a high flow bypass for this patient. You could sometimes do a reimplantation of one MCA onto the other MCA, for M2 onto the other M2, which we did because we were unable to clip this aneurysm. This patient, by the way, was COVID positive, and we did a reimplantation onto the one M2 onto the other M2. So these are again sent by the endovascular colleagues. This is a giant basilar top, which was not clippable, not coilable, not flow diverted. So we did an internal maxillary artery to the P2 bypass with a radial artery interposition graft. So you can see the radial artery interposition graft taking off from the internal maxillary artery division and going into the P2 segment distal to the aneurysm, and the aneurysm was trapped. And this is the postoperative CT where you can see the aneurysm is extruded from circulation. The IMAX actually is a good donor, but it's a difficult vessel to find, and you have to dissect it very carefully lest it gets injured while doing a dissection. So this is a radial artery which is coming out from the IMAX here inferiorly and then going into the aneurysm. You can see the aneurysm starting to, which is trapped, which will eventually thrombose. So of course this is not that it's going to be a risk-free surgery. There are going to be issues. There are going to be kinking. The greater saphenous vein has a higher incidence of thrombosis. Because we give heparin, you have to be careful about extradural hematomas and reperfusion injuries, delayed blockage and infections. So I think we have time, so I think I'll just go back and
Dwarka, hurry up because the next session is yes.
Okay, so since we are run out of time, I'll just go quickly. So sometimes what happens is the graft failure. For example, here the graft has failed and the patient has developed an infarct. This is another patient who's had a graft infarct. But in some cases, we are able to get back the graft. For example, this patient, if you see here carefully, immediately we shifted the patient onto the CT room, and we got a CT angio which showed the graft had got blocked. So we immediately took back the patient into the OR, inserted the Fogarty's, and were managed to salvage the graft, and the patient recovered without any fresh deficits. So the question, so the decision making is first, these are unclippable, uncoilable aneurysms. So the first thing is to do a BTO and see whether how is the distal collateral circulation. So if the patient has failed the balloon occlusion immediately, then the patient needs a high flow augmentation. But if he has failed only with an additional hypotensive challenge, then you can get away with a low flow augmentation using the STMC, using the superficial temporal artery as a donor. But if he has passed both the balloon occlusion as well as the hypotensive challenge, and in old people above 70-75 years, then you can simply get away with the Hunterian ligation of the carotid artery in the neck. So this is for all the youngsters. Neurosurgery is changing. When we were young, of course, bypasses were very, very less. Now because of the complexity of the cases which are going to come to the neurosurgeon, as well as the failed endovascular cases which are going to come to us, you have to learn the art of the bypass. And even though we don't do much cases, I mean we do around 12 to 15 cases a year of high flow bypasses. But still you need to have the knowledge so that you can save these patients and you can give very good results. So thank you.
Thank you, Dwarkanath. I think we are already running short of time. Next session is due. Thank you. Okay. Yes. What about that organizers, please? Because it is now 12:15. So next session is for 1 hour. Yes, sir. Dr. Sushil, please. Okay.
No, I'm not going to talk on anterior. Actually, what happened, I was just told at last minute to speak, and then they said that. Then I found that I'm already speaking on anterior topic later on in the day, so I thought that I'll speak on posterior occipitocervical fusion. 12 cases a year in Niemann's. You will have many more cases of craniovertebral anomaly in your career. So focus on what I'm talking, rather than focusing, it's not easy to just get up and start doing. In the Niemann's, they're doing 12 cases a year. Not very easy to master. So let's get on with this. Please start the video. So posterior occipitocervical fusion, there has been a lot of controversy. I know that my friend Atul always says that you should not include the occiput, but I feel that there are many patients where occiput is important and you should know how to do it. I have made certain modifications in the technique. I will show you my technique. This was a case where there is a atlantoaxial dislocation with inflammatory destruction of the tip of the odontoid process. And you can see the atlas and axis, the joints are destroyed and there is instability, plus a high riding vertebral artery and the fusion of. So most important thing is that these patients have to be intubated very carefully with fiber optic, and my wife is my anesthetist and my life partner for 35 years, but I have to keep quiet when she is doing the intubation, avoid any flexion. This is I always use the skull traction, and of course neuromonitoring. The baseline is recorded both in supine and then prone position. I don't like to fix the head. I keep it on a U-rest because I need to give traction and then extend the head during the final fixation. This is how the patient is fixed. It's very important to have good fixation and correct fixation of the head. Expose the occiput right from the occipital protuberance and identify the atlas, the axis, the midline C2 axis, lateral mass of C1. Now I have modified the entry point for C2, which has been published in Journal of Neurosurgery. This is the C1, C2 joint. This is the left-sided joint. This is the C1 entry point, just under the posterior arch. This was the technique of PARS described by Dr. Goel. This was described by Harms. And this is my entry point, which is just under the facet joint. So if you go under the facet joint, there is no discussion about vertebral artery. This technique has been published in Journal of Neurosurgery, even Global Spine. So no talk about where is the vertebral artery, whether it's going to come near, unless and until it has come dorsally. So the entry point is just at the midpoint of the facet joint, downward and medially. That is the place where the most dense bone is available. This is how the joint is opened. The screw for C1 is upward and medially, and the screw for C2 is downward and medially. This is preparing the joint with an osteotome or drill. You can use anything you want, but this is the key of the operation. Prepare the joint properly. This is the entry point for C1. Again, the entry point for C2, subfacetally, downward and medially. I don't like to tap too much. I've got a special tap of 3 mm, which is only of 1 centimeter length. Over tapping is what makes the screw loose. Just a few threads to give direction to the screw to get impacted, and then after the first few threads, you pass the screw. People make the mistake of tapping the entire screw length, and that ends up in loosening of the screw and lysis around the screw. So this is what I like to do with the joint. I put a small micro drill of 2 mm and prepare the joint. Now this is so far it was in cadaver. This is now live surgery. I always divide the C2 root. I don't waste time in protein, and I don't find I have any problem in dividing the C2 root, and I try to check the trajectories with navigation and see that my trajectory is coming correct. Of course, the neuromonitoring fellow is there watching for MEP, especially when I manipulate the head. To identify the joint, it is a very important trick is to pull the head and see, and you know where is the joint. This is how the joint looks. You can expose the joint very easily. The anesthesia is of great help for hemostasis. If they keep the tidal volume low, if the peak airway pressure is less than 18, 19, you are not going to have any bleeding from the epidural veins. So you see this is a tracking to see where my screw is going to go in C2, which is just above the high riding vertebral artery, the C2 screw. And the trajectories which I showed you, how I tried to take the trajectory for C1 upwards and medially and for C2 downwards and medially. You have to spend a lot of time on the CT scan preoperatively to study the exact. We talk about trajectories, but they vary from patient to patient. Patients don't read textbooks. You have to sit with every patient's CT scan on the previous day. It's not like you get up in the morning and I'm doing this surgery and that. You have to spend a lot of time on this console yourself, studying all the anatomy, making 3D reconstruction, and knowing how to put the screws. Always the C1 screw is slightly lateral upwards and lateral to the C1 to the C2 screw, because the joint is slanting. If your screw is coming one above the other, you are going wrong somewhere. Remember this very important technical point. The C1 screw is always a little up laterally as compared to the C2 screw. I get the C1, C2 screws in position. Then I go and do the other side, opposite side of the joint, once I've finished those screws. before cutting the C2 root, in spite of having seen the CT, because sometimes there are accessory branches of the vertebral artery which are not seen, you know. So I like to poke with the needle and see, and before I cut the C2 root, again I take the navigation to check the position and whether I'm going in the correct direction. All these are redundant. I've done many cases without navigation, but once they are there, then you feel that you should use it, and it does increase safety, but you should not become over-dependent. You should use the navigation in your brain of what you have seen in the CT scan for a long time on the previous evening. Don't be over-reliant. If there's a problem, I start using the navigation in my brain and forget the navigation picture which is there on the console. In this case, I have also used C3 lateral mass screws because of the destruction of the C1 joint. Then I first fixed the rod. One of the biggest problems is after having got everything into position, that your rod is not getting adjusted. And you keep on bending, you know. Instead, first fix the rod loosely in the cervical screws. And I've stopped using the midline device, which is usually what is marketed. I've got these specialized plates made by Jeon for me, where you can use 3 screws to fix this plate device, and on medial side it holds the rod. So once the cervical screws are fixed, this plate, I'm sorry that it is off center, but this is how the plate, there are 3 screws on the plate, and it fixes onto the occiput. I like to study the CT scan and find out where is the most dense bone on the previous evening. You should not just put the screws wherever you want. The screws should be bilateral. They must be bilateral. Even if little CSF comes, no problem. But use bilaterals, use bicortical screws. So you see in this case, I have selected how the bicortical screws, and you can see this device which holds the rod. No struggle. Otherwise, what happens? People put the midline device and they're contouring the rod multiple times. Every time you contour the rod, you make the rod weaker. Before you fix, you must pull and extend the head. That is this to get the reduction and correct the instability. All of you must know how to use the rod reducer. If the rod is not coming into position, these gadgets like rod reducer, rod pusher, it is mandatory to have studied them and find that the implant fellow has deposited them on the previous evening, because suddenly on table you say, no, he forgot to put the rod reducer. It's not acceptable, you know, and then you're in trouble. So this is how they are put. And on table, you should see these are the plates which were made by Jeon, 2-hole or 3-hole, and you can use this instead of the single big plate device, because that one occupies a lot of place. You have to get the rod into it, and it can be difficult to get the rod into the implant and into the cervical screws. So in the modification which I have proposed, it is very easy to fix the cervical screws and then get into the occipital plate. So you confirm on table that everything has been fixed, and this is the post-op imaging. You can see that, you know, it is back in position and the dislocated. This is another way of correcting, is to pass the C2 screw in an upward direction and then push the C2 screw upwards, and you will get a correction of the atlantoaxial dislocation. This also I had proposed long ago. Pass the C2 screw up, use monoaxial screws in the C2, and then push the C2. The whole idea is that if you push the spinous process of the C2 towards the C1, you will get a reduction. Now this was a case where the atlas has been destroyed on both sides, and plus the patient has, because of that, the patient has got basilar invagination and atlantoaxial dislocation. This was the technique proposed by me, where you expose the cervical spine in the front and understand that there is nothing dangerous lateral to the transverse processes. There is a safe area lateral to the transverse process of C2, C3. So these are again rods which are made by Jeon, where you can bend the rod in 2 directions and push them bluntly into the soft tissues. Then there is a specialized plate to fix them onto the vertebral bodies in the front. And after having done that, you can turn the patient prone, and the rods are available posteriorly. You can cut and keep as much as you want. And then again, the same plates which I have shown, those were used to fix the rod to the most dense portion of the skull. And then the domino connector is fed on to the rod which has come posteriorly. And in the domino connector, you can pass the rod. Again, pull the head, extend, and you can correct the deformity. distraction to correct the, this is the final construct how it looks. This got published again in, neurosurgery. So you see there's almost no bone because of fibrous dysplasia, and this is how this is put to correct position. This patient was bedridden for almost 3 months. Was at the end of 1 week she was back to walking, and she says she's very happy. Her catheter is out. And of course, no talk unless until you got a long-term follow-up. Now, I've been doing these cases. I've done not many, only 8 or 10, with long-term follow-ups of more than 2 years. So this is over a period of time with DemoSab. You can see that this thing is getting fused. It has been published. Thank you very much, my dear friends.
Any questions? 1 or 2? We are getting late. No question. Thank you, Sujay. Excellent job. You are doing it for long time, no doubt. I think our session is over now.
Thank you to all the speakers and chairpersons. Now I would request the chairpersons to felicitate our speakers. Professor Charles, to you. Thank you, sir. Dr. Ashish Tandon, sir. Dr. Rakesh Lohana, sir. Dr. Sukumar Sura, sir. And Dr. Sushil Patkar, sir. Thank you, sir. Quickly moving on to the next session, I would request the chairpersons for the next session, Dr. Parthiban, sir, and Dr. Sushil Patkar, sir, to chair the next session, please. Thank you, sir. Over to you, sir.
Thank you. I think we go on for the pre-lunch session, and we call Rakesh to speak on MIS surgery and complications and how to reduce that. Rakesh.
So yes, thank you so much, sir. So morning we were discussing that we should discuss what can go wrong and how do we bail out, and I'll share my journey of complication, the lessons we have learned during that journey. So what I'm talking about is a tubular system. All surgeries under microscope. So there are 3 types of system. One is fixed diameter matrix system, expandable X-tube and quadrant system. My majority of cases are done through matrix 18 millimeter tube, disc through 14 millimeter tube. So complication can occur if your planning is wrong, then you are going to fail. It can occur at an execution stage. So there may be complication while docking, during decompression or during fixation, and there may be post-op, which may be early or late. So planning is the most important thing in spine surgery. Your diagnosis has to be right, your clinico-radiological correlation has to be there has to be robust indication. Gray zone indication and getting into failure is the bad thing. So and your option has to be right based on your own competence. So I would decide, can I do it with interlaminar endoscopy? Then I would do it. If not, I'll try tubular, and if none of them is possible, I'll do it at open. So every surgeon would have their own comfort zone, own expertise stage, and that's how they should decide. So as I said, planning is very important. Like this was a case of a congenital stenosis, severe stenosis. This is not a case for a beginner. One of young enthusiastic endoscopy guy did this with an endoscopy, and you see patient present with a post-op failure, post-op foot drop, and MRI showing still severe compression. So these cases are big no at early stage. I'll share my journey. So this was a lady with a pain following a trivial trauma. The confusion begins with MRI. They reported as this is a T12 fracture with query malignancy. We got a PAT scan. PAT scan showed some bright spot. They said maybe recent osteoporotic fracture versus MATS. So we thought maybe MATS. So we decided to do a just posterior MIS, 2 above, 2 below fixation. Patient was well for some time. Biopsy turned out to be negative. And then on follow-up, 2 months later, she came back with a severe back pain. And what I saw was implant failure. Then what do we do now? So we decided to extend 1 level superiorly, 1 level inferiorly. So became a 3 above, 3 below fixation, added cement there. So this was the follow-up. So lesson learned, anterior reconstruction is very important. So now what I will do now today is just fixation, anchored level screw and short segment. That's what I do now. Second case, 35-year gentleman, severe cervical radiculopathy, not responding to conservative measures, and that shows C56 right foraminal disc. Went ahead with a MIS, C56 laminoforaminal with discectomy. Now I do it with tubular. This was old case. So this was my first dialer, went straight to this disc level. So that scared me. Pulled back. When I entered with a microscope, I realized that interlaminar window was very wide. There was very thin laminar and wide interlaminar window. So probably my dilator went there. So post-operatively, patient had right arm pain relieved, right grip weakness. Fortunately, that improved in next 48 hours, but had hypoesthesia in perineal region and left thigh. He had bladder, bowel was continent, but sexual dysfunction for almost 6 months. And this was post-operative MRI, which showed that this is the contusion. Probably my dilator went through on the cord. So the lesson learned, beware of wide interlaminar window. First dilator tube must be under CM guidance, and you have to be vigilant at every step. Next step, next patient, 62-year-old gentleman with a severe claudication, dynamic X-ray, no instability, MRI showing severe stenosis at 3, 4, 4, 5 with a disc herniation at 3, 4. My plan was to do a 2-level MIS decompression with discectomy. Serial dilators placed 18 millimeter tube under microscope, decompression started. It was a very tight canal with a thin dura. At one point, while taking a ligamentum flavum out, dural tear occurred. So there's noodles coming out. What do we do now? Whenever there is a very tight canal, it's very difficult to put the roots back in. I tried to put now roots back in, but it was not budging because anteriorly severe compression, your ligaments are still there, decompression has not been done. So dural tear occurring at early stage is a challenge. So after making efforts, the roots were not going inside. Then I covered it with a patty and started decompressing at opposite side and completed the decompression, keeping the roots outside. And once the decompression is done, I could put the roots back in and then used T-seal and the Duragen. And the post-op patient did well. So whenever there is large dural tear with nerve roots coming out, try to put nerve roots back in. Head low position, transient apnea, low volume ventilation may work. Cover with F-gel patty. You can continue surgery away from the site of tear. Make sure you don't pull out nerve roots at any stage. and primary suture as in when it's possible. If not, then you can use either Duragen or glue. If it's a struggle, you may change to a larger retractor, and don't hesitate to convert to open. Keep your ego aside. If there is small minor dural tear, what we do is usually we use a muscle patch. So we harvest a muscle and use the special ENT instrument. They use it for tympanic membrane or substitute. So you can make a patch from this muscle and cover it with, and you can use glue. The next case, 75-year-old lady with a long-standing back pain, leg pain, and this was an MRI showing 4 or 5 severe stenosis. Dynamic X-ray was showing listhesis. So my plan was to do a MIS T-lift. Everything was going well. Placed opposite side screws, ipsilateral K-wire placed, disc prepared, and while putting in a cage, I felt a loss of resistance. And when you got C-arm, you see that the cage is migrated anteriorly. The cage went vertically. There is no way you can retrieve that. It is a very scary scenario. So patient was hemodynamically stable. We completed posterior fixation, consulted a vascular surgeon, arranged 3 PCVs, because as soon as you turn supine, they may go into hypotension. So it's a very scary moment. So we arranged everything. Fortunately, when he turned her supine, the vitals were stable. We kept her in ICU under observation, and when you got a CT angiogram, we were very lucky. The cage was standing between aorta and IVC. The cage here, this is the cage, aorta, IVC. So we consulted vascular surgeon again. What do we do? He suggested we should take it out, otherwise patient may develop pseudoaneurysm later on. So we went ahead anteriorly and cage retrieved, repositioned, and that's a post-op. Started her on teriparatide, post-op. Eventually she recovered well. So lesson, the cage placement must be under C-arm, especially in elderly osteoporotic. Make sure they don't push the cage anteriorly. Next case, 36 years old female, acute lumbar radiculopathy, not responding to conservative measures, and this was the case. L5S1 large disc, MIS right L5S1 discectomy was done, uneventful surgery. Patient had a complaint of loss of vision in right eye. So immediate post-op, patient woke up with no vision in right eye. Ocular evaluation was done. There was retinal opacity was there, cherry red spots, retinal arterial attenuation, optic edema and pallor. There was no external event, so there was no external injury. It is internal. It's called central retinal artery occlusion. So management as ophthalmologist suggested, ocular massage, oral Trental, injection mannitol, prednisolone was started. Fortunately, her vision started recovering in 6 hours and 90% recovery at 6 months. So this is a condition called CRAO, central retinal artery occlusion. Prone position is at risk. Avoid extraocular pressure. Avoid hypotension. And early detection and treatment only could be a salvage. Ophthalmologist said that you are lucky, patient recovered, but many patients of CRAO do not recover. So if you lose that 6 hours window, vision loss may be permanent, and risk of vision loss should be included in a consent. Next case, 66 years old female with a neurogenic claudication. We did MIS LCS case. We did MIS L4-5 with bilateral decompression. Patient was doing well for 48 hours, then developed bilateral foot drop with urinary retention, and we got MRI that showed hematoma.
Last
yes.
few.
Yeah, hematoma, you should keep it in mind. This last case. Okay, so we skip this. This is important. Yeah. So this was a case of far lateral disc herniation. We did MIS far lateral discectomy. Patient surgery was uneventful. Patient had a lower limb monoparesis with paresthesia. Didn't realize what was going on. So we did MRI. MRI showed that disc is out. We got whole spine screen. Couldn't find anything. We did brain, just a small event, but that should not explain lower limb monoparesis. We got a CT and that found a small hematoma. On table there was no hypotension, no bleeding. We got a CT angio that showed that it was diseased vessel. That's why probably there was no hematoma there, and there was abrupt cut off here. So consulted a vascular surgeon, and when we look back at MRI, you can see that probably my disc forceps went here and probably it bite. So laparotomy was done. Distal thromboembolectomy was done. Iliofemoral bypass was done. By that time patient developed compartment syndrome. Fasciotomy was done. So minimally invasive surgery turned maximally invasive, but unfortunately that was not enough. Patient had acute renal failure and we lost him. So you have to keep in mind vascular complication. It is rare, but it can happen. And early detection and early intervention only could have saved this patient. So the take-home message is MIS has a long learning curve, and one will have to progress gradually. Try to prevent complication by all means. Better patient selection, detailed planning, perfect execution is the key. Proper post-op evaluation follow-up protocol has to be there. And if any complication, identify early, keep your ego aside, tackle as soon and as best as possible, and try to learn from others' mistake. That was the basic purpose
Thank
of
you,
presenting this
Rakesh.
talk.
And
Thank you,
what impressed me was your honest presentation.
Thank you, sir.
And the message should go to the youngsters. Excellent. No questions for this session, pre-lunch, because we are waiting for the inauguration.
Yes.
Thank you very much. And I call my friend Dr. Rao, Oya Rao, to speak on the endoscopic approach for the subdural hematomas. Dr. Yadav, yeah. I think this guy should do this one, connecting.
Okay. So, thank you very much, respected chairpersons and dear friends. Today I'll be talking about endoscopic treatment of chronic subdural hematoma. Chronic subdural hematoma is a surgical emergency, and endoscopy is one of the treatment options. Endoscopy is one of the treatment options, and this is especially useful when mouse दिखाओ ना, especially useful when we have solid or organized clot. Cursor. When we have a solid इसका ऐसे थोड़ी इसको करना है यहाँ. Anyway, no problem. So this was so especially useful in organized or solid hematoma, or when there are septations, trabeculosis, or there is bridging vessels or laminar type of hematomas. So these are some of the indications. This is septation. ये कहाँ है? ये क्यों नहीं आता है? So septation here, and then this is a bridging vessel. So one should be able to find out the bridging vessel is one of the dreaded finding. If you go for borehole irrigation, this might rupture and cause a recurrence. So how to differentiate whether there is some bridging vessels. So if you find the inner membrane is pulled towards the dura mater, then it is likely to be bridging vessels, because the vessel pulls the inner membrane. So how to differentiate it from the fibrous septa and the bridging vessels? If you have fibrous septa, they do not pull the inner membrane, but if there is a bridging vessel, it pulls. This is another indication, solid hematoma, difficult to do by simple borehole, endoscopic picture of organized hematoma. So these are good candidates. The laminar type of hematomas are also indications. So what is laminar? You have a superficial cavity, then you have intermediate cavity and a deep cavity. So unless you remove all these layers, the recurrence is likely to happen. So endoscopy is the treatment for this. The another good indication for endoscopy is when you have a thick inner membrane. So if you find a thick inner membrane, there are problems, two problems. One is that the thick inner membrane does not allow your brain to expand, and there may be recurrence. And if you find a thick inner membrane, that means there is another cavity. So usually there is another cavity which may be small, but if you don't remove this part of it, then there is a recurrence. So in the surgery, burr hole should be made as little as possible. It should not be medial. If you make it medially, you go in the brain, and it should not be on the flat surface, as we do in, even if the flat surface has a maximum thickness, because with endoscopy and rigid endoscope, you have to reach up to the most distal portion. So at the most lateral portion, the burr hole should be trapezoid shape. That means the inner, the table should be drilled little more. Our modification is that we drill both. We drill inner table and outer table. So this helps us to allow the endoscope to reach at the most distal portion, straight entry into the chronic subdural hematoma. So here you can see that even the endoscope is not able to, it has limitations. See, this hematoma is very big. So if the E portion of the hematoma, most distal portion, if you make a burr hole here, and if you go through the rigid scope, this E portion, if it is a solid clot, you are not able to visualize. So you need some kind of retraction to retract the surface to see, to retract the brain to see the most distal portion. So we devise a retractor, novel retractor, which is a silicone tube to retract the brain dynamically during surgery, in endoscopic surgery, to visualize this. Second indication is when the width of the hematoma cavity is very small in a young patient. So young patient, when the hematoma width is very small, you cannot put 3 instruments. The endoscope, one suction and another instrument. So you need some space to do work bimanually, and therefore you need to use a retractor which we devise. This is a silicone tube. We cut our tubular retractor into 2 and use this as a tube. So this is the silicone tube which we use. It's a soft tube, it does not injure brain, and we apply 3 sutures on outer side so that it does not migrate during surgery. These are some of the instruments. Some of them were devised by us. This is Dr. Manas Panigre. He passed the infant feeding tube through the hole in the suction, so that you can use this as a suction irrigation. So to reduce the number of instruments in endoscopy, this is one thing. We asked a company to join 2 suction tubes. So this is suction irrigation during surgery. And we also modified this. We use this tube because at times some breathing vessels are at the corners, and the available bipolar do not reach there. So we insulated the wire, VP shunt wire, and put infant feeding tube. So this can be used to coagulate a vessel which is far away from your view. So this is okay. So this is a chronic subdural hematoma with thick inner membrane. the liquid portion was sucked, targeted suction is done, this solid clot was removed. You see, after removal of this hematoma, we are not able to see the brain vessels. So if you don't see the vessels on the brain, that means there is thick inner membrane, and this thick inner membrane need to be excised. There was some clot underneath this small hematoma. So one is this small hematoma should be removed, otherwise there will be recurrence. Second is that this does not allow brain re-expansion. This is another organized chronic subdural hematoma, pre-operative, post-op, and this is the organized clot, which we can make out that this is very difficult to remove when you use burr aspiration technique. So now the full hematoma has been removed, and one can see vessels through the inner membrane. That means there is no need to open the inner membrane. In the result, endoscopic treatment was found to be particularly useful in 151 patients, that is around 44% of patients. So these patients were organized or solid clot or having a septa or having a bridging vessels, or there was rapid re-expansion of the brain. When the patient is young and there is a small width of the hematoma cavity, there is a rapid re-expansion and you cannot remove the distal portion of the clot. And even endoscopy was needed a retractor in about 15% of the cases. And these were patients with rapid re-expansion when there is a small cavity, especially in young patients, and where there is a large hematoma in the curved cavity. Okay, I'll finish fast. This is pre and post-op. This is again pre and post-op. And these are our recommendations. So either endoscopy or burr hole should be done when there is a monolocular cavity. So simple cavity, liquid fluid. In such cases, either endoscopy or burr hole can be done, but it should be done, you should get a MRI done, because CT scan can miss the bridging vessels and it can miss even organized clot. Endoscopy is useful when there are septations, bridging vessels, when there is thick inner membrane, organized or solid clot. And the same indications, if the endoscopy facilities are there, then you can make a small keyhole craniotomy plus in a calcified hematoma. Middle meningeal artery embolization is required when we have a thick outer membrane, stable patient. If the patient is drowsy or unconscious, then you need hematoma removal also, or in recurrence and patient on antiplatelet or antithrombotic drugs. Thank you very much.
Thank you. Thank you, Dr. Yadav. Thank you very much. Thank you very much, and I call the next speaker, Dr. Deepak Agarwal. Dr. Deepak is going to talk on innovation and entrepreneurship in neurosurgery.
So this, Dr. Ashish wanted me to present this talk, and that's why I'm doing it. I will try and finish it in time, but I cannot commit. So this is my personal journey, and I will just share with you from where it started and where it has progressed. Can we go to this? So if you look at innovation specifically in healthcare in India, we are lacking, very lacking, I would say. We don't have an indigenous MRI. There's one which is just been developed, still in testing at a few places. Unfortunately, no CT. Nobody has developed a CT yet. Nobody has developed an indigenous ultrasound also. And we all know even central lines are mostly imported. So this is the status we are. We are very happy with the status quo in our everywhere. And my journey started long way when I was here assistant professor at AIMS. We had the latest at that time, the stealth station from Medtronic, and at that time it used to use disposables which were called as the fiducials, and it was costing around $100 per set and very difficult for us to procure it on a continuous basis. So at one time, because of all the policies, the stores just stopped supplying us. So that machine became inoperable because obviously the fiducials were not there. So I started experimenting and finally zeroed in on vitamin E capsules. So you can see here on the image that I put vitamin E capsules on the patient's head, and we could register very well. And we did a study also which was published, which showed that registration with this capsules was equally effective as compared to standard fiducials. And this is how we registered there. And it was very well taken up. We did hundreds of procedures with this before we got the next machine where it allowed for laser registration. And the Americans and the Japanese specifically liked this research, although it was a very, very low-hanging fruit, I would say. And this piqued my interest in, doing innovations. The other innovation, I would say, in the device or in the product category for neurosurgical procedures was what Dr. Yadav just showed back in chronic subdural. And I was also exploring what to do for chronic subdural, and I thought, why don't we modify a burr cap so that we can use it very simply to actually suck out the subdural in a way which is non-traumatic. So the advantage of this cap is because it does not touch any surface. You see, this is the inner membrane out here, the inner part of the cap. It just fits into the burr hole, and there is this suction tip where we can just connect a standard suction cannula. So this is how we do it. This is a standard thing. We just make the marking so that in case we need to convert to craniotomy, and make the standard burr hole, fit the burr hole cap, my cap which we have made, connect a standard Romson suction catheter or drain which we normally do in every surgery, but instead of keeping it in the subgaleal space, we connect it to this cap, and we apply pressure as much as we want, and we keep it for a few days. So you can keep it for 5 days, 6 days, it keeps sucking out, and that suction effect is a miraculous thing. It removes the subdural. Even if there's a membrane, there is no membrane, there's septation, everything, the brain comes up, and specifically for recurrent subdurals, it's excellent. So whatever our experience is, very small things, nothing major to be done. The senior resident can do it in the night, middle of the night, you don't need to come in. Any kind of subdural, we've got excellent results, and we have published this paper. So you think about it, absolutely non-traumatic. If you see the literature, it is the external membrane. Some people say the external membrane bleeds, it strips off from the bone. Some people say internal membrane, nobody is clear, but the recurrence rate remains 10 to 20% in all, despite everything. You can try anything, endoscope, non-endoscope, craniotomy, recurrence rate remains 10% in the best of the centers. When I come to the surgical innovations, a long time back we made a new technique, and Dr. Manmohan was there with me with this, where we started shielding the draining vein, and we had very good results sorry, of preventing PRI changes and early bleed in gamma knife patients. So this was the technique where we tried to save the vein. And actually when you see the avium, the biggest problem previously was the venous side used to constitute 40 to 50% of the AVM. So when the angiogram was seen by the radiologist, they used to mark the whole thing, including the draining vein and all the venous structure. When you exclude the veins, the AVM size decreases substantially, less than 40 to 50%. So the AVM becomes more accessible. You give less radiation and you shield the draining vein, so the outcome becomes much better. The other thing which I started doing was DRES, which we all know. Then DRES, at that time, the Japanese person who had taught us, Dr. Tiara, he used to bring in a bipolar which was very, very fine and used to cost $1,000. So he used to do all his DRES with that. So obviously we did not have it, and we had to modify. So the modification we did was using the micro scissors. That's a standard scissor, and instead of doing coagulation, we started just using the micro scissor for a tracheotomy. And this also we have published, and we found that, if you remove that expensive bipolar, anybody and everybody can do this. Any neurosurgeon, any center, you don't require anything at all. You have your standard micro scissors, you do standard laminectomy, and you can do this procedure very safely and very easily. So I will not go through this. We'll have another talk on this. And this was another innovation, I would say, in complete spinal cord injury. And the reason I'm rushing is just because I want to show you this one. This is a little, I would say, controversial, because everywhere I present there is a controversy, and we'll talk about only Asia A now. I hope everybody is very clear. No Asia B, C, D. Asia A, we only patients with Asia A, and the only way to say that a patient is Asia A or not is obviously you see for perineal sensations and for the anal. So every patient, 100% you're satisfied is Asia A, you go on. And if you look at the literature over the last 100 years, there is no management, I would say, progress for these patients. Even in the best of centers, the chances of spontaneous recovery is less than 2%. I think only those 2% are those patients which were not properly assessed also, because Asia A will not improve. So we started thinking, and we said that for brain, if we can do a decompressive craniotomy and then a lax duroplasty, why can't we do the same thing for the spinal cord? And because we don't do it, we just do a standard, laminectomy and screw fixation. We never touch the dura. So we said, why don't we start touching the dura opening and doing a duroplasty in the spinal canal? So this was the hypothesis, and we said it's obviously similar to the brain. The cord edema also occurs. The cord swelling also occurs similar to the brain, which peaks around 7 days. So this was the thought, and so we came up with this lax duroplasty. And I'll just share a couple of cases. This was a 49-year-old female, spondylolisthesis C45. So high ventilator dependent patients, quadriplegic. And this is the X-ray, MRI you can see. And you can even see that there is some cord signal changes out there. So this was the intra finding called as bulging when you open the dura. And we have put in a ICP, EVD test to see the pressure before we opened the dura, and the pressure was quite high. And you can see the cord which is bulging out from the dural margins. So we did a lax duroplasty and standard fixation in this patient, and miraculously the patient's power improved to Asia C during the hospital stay, and we could wean her off the ventilator and discharge her on post-op day 7. Till then no patients. Asia A means it's like a death for the patient, dies on ventilator. So this is the patient at 6 months, you can see, walking with support. We don't have that kind of recovery for every patient. Second patient, 51-year-old motor vehicle accident, came as M1, intubated, MRI brain normal, had multiple arrests. The organ donation team also came into it. Fortunately, the relatives refused. After 1 week, the patient became conscious. but was quadriplegic with absent renal tone, so Asia A.
Conclude.
Yes, we'll just couple of slides. So we again the same thing. We did the same thing. You can see the lax neuroplasty pseudomeningocele formation. Patient improved, not that much, but C, and this we also published. So we have done many cases, and we have a rate of around 20 to 30% very good results from this surgery. So I will come to final the entrepreneurship, just 2 slides. So then I said that all these things are good, but they don't make you money. These are things which are helping our patients and everything, not helping us. New innovations, surgical techniques, new innovations and everything. So at that time, you know, before COVID, 2016, so I had a person, and I zeroed in on a ventilator because we all are dealing with ventilators. Fortunately or unfortunately, we were at the right place at the right time when the COVID happened. So we were already in the market with the ventilators, and we sold more than 15,000 ventilators. So this was part of the entrepreneurial journey. The other was that I was involved with a prescription transcription service. This was also my idea. I gave it to them, the GoodMed, and it is deployed in major hospitals. You can check it up. So in the latest funding round, which happened a couple of months ago, they raised 100 CR. So, you know, these are the things which you should also think about, doing things which are related to your field. So to conclude, innovation, entrepreneurship are very important, but you need to have a mindset towards it continuously. And obviously there are significant challenges in any surgery, anything, and it's important to persevere. Thank you so much.
Thank you. Thank you, Dr. Deepak. Thank you very much. I call Dr. Manmohan Singh to speak on comprehensive management of brain AVMs.
Good afternoon, everybody. So I'll be talking on the comprehensive management of the AVMs. So as we all know that the AVMs are vascular abnormalities consisting of the fistulous communication between the arteries and the veins, and they usually present with hemorrhage, epilepsy, chronic headache, focal neurological deficit, and the learning disorders, especially in kids. So the latest classification, that is special response class grading system, that class A requires surgical management, that is that very good outcome, B multimodal, and the C, especially SM grade 4 and 5, they require conservative unless they bleed or develop neurological deficits. But again, this is a gray area, and there are a lot of things have happened in the last decade. So how do we manage brain AVMs? Conservative, microsurgery, stereotactic radiosurgery, endovascular, and usually the combination of all these modalities. So conservative management is limited to that extensive malformation, deep location, not amenable for the surgical or neurointerventions, and very advanced age or the medical conditions of a patient. So endovascular management approach is adopted with the following intentions. So that is either curative or adjunct to surgery or adjunct to stereotactic radiosurgery, which is gamma knife. So treat associated other vascular abnormalities like aneurysm, intranidal or the flow aneurysms, or the palliative treatment just to reduce the intracranial hypertension, because this is a lot of venous hypertension in the brain. So embolization, if you look at the results, that the complete obliteration is variable between 10 to 40%, and multiple sessions are required. It is never a single session. Very rarely with a small AVM which is single feeder may be occluded in one single go, otherwise multiple sessions are required. The patient with angiographically cured AVMs but they are still at risk of bleeding. So angiographically AVM is gone, but why it happens? Due to the unseen feeders, and because of that, a lot of the muck which is there in that anidus, that a small feeder may not be visible, and then the recanalization, the recruitment at the later date. If we look at the literature, that complete obliteration of the AVM, as per the Frizzle et al. Series, that complete obliteration is only at 5%. So this procedure is also without any, not without complication. The permanent neurological deficits occur between 6% to 6.6%. Microsurgery for the brain AVM, it is still the gold standard, and angiographically care rate up to 100% can be achieved in grade 1 and 2 in experienced hand, and angiographic care rate falls significantly for that higher grades. So preoperative embolization may be required in few patients with the small and some medium size AVM can be completely excised without any preoperative embolization. But in the higher grade, that preoperative embolization may be required to reduce the blood flow, to tackle with that intranidal aneurysms, or the deep feeder which may be there, very difficult to reach at the first go, that may be tackled so that the surgery becomes easy. So another aspect which we usually do not see, especially as an adjunct to surgical excision, which is the radiosurgery. So this looks a little interesting. The large AVMs usually always carries the high risks, both perioperative and even the post-operative deficits are high. Then in large AVM, what we do is that we always go with the intention of palliation many times, that the volume stage or the dose stages. Many times the complete occlusion is never achieved, but it reduces that size of the AVM significantly so that you can go ahead and take out the AVM surgically completely. So this is again a very good way to tackle a large AVM, even grade 4 AVMs also. Treatment is always tailored according to a clinical scenario. Now this is, you see that there is a large hematoma due to the very small AVM bleed. And there is no way to treat it with the embolization and waiting for that. Go ahead and take out the hematoma, take out the AVM, and the patient is cured for life. And same thing is that a small AVM, grade 1, and go ahead, take out surgically, and the patient is cured on table. Surgery is the choice for the small non-eloquent area, but in eloquent area, in the experienced hand also, that patient we can operate with very good results. Multimodal treatment many times is always indicated, or many times we deliver to the patients. Now this is a very typical case I always show to in the conferences. So this is a 15-year-old boy, initially opted only for embolization, done twice, and then I gave this gamma knife surgery for this patient also. But even then the patient bled. So now that there is no option, because there is always a persistent AVM. You see that very small residual AVM is still there. So ultimately landed up excising this AVM, very small AVM, but it is always better to go ahead in the first go. The grade 1 and 2 AVM, we should always convince the patient that this is the treatment of choice, because other procedures always carries complications. So this is again a large AVM, so which was given gamma knife therapy. You see that in that. So this is the AVM which is gamma knifed on a volume fractionation and almost complete obliteration. You see that. So this is very small AVM which is residual here. Now in first look you can always miss it, that whether it is there or not. Probably we can always say that is completely cured post gamma knife, but still this patient bled. So you see that, and then I went in and excised this hematoma, and we saw that there is a small AVM at the periphery of this cavity was still there. Excised, and then it has completely cured after the surgical excision. So even the gamma knife sometimes can lead to this sort of problem. So the long-term follow-up is always required, and make sure your AVM is completely gone. Even a very small residual AVM can bleed in later life. So this is again a very large AVM in the posterior fossa. You see that very large venous pouch, large AVM which was embolized and then gamma knifed. And you see that because a lot of things has happened, but in 2015, again this patient bled. So this is the pre-operative DSO, and you see that there is hardly anything visible, very small blush here, but then again had to go in and take out that whole previously embolized and gamma knifed thrombosed AVM, and with a very small neovascularization was there, which has actually bled, and then we can hope that this patient doesn't bleed in future. So this patient came in the middle of the night, GCS 5, a large hematoma with the SM grade 2 AVM. But thing is that at that time we just took out the hematoma and then let the patient improve. There was a decompressive craniotomy, and after that because of the patient did not improve to 15 by 15, patient remained a persistently vegetative state, and then we did just a gamma knife and followed it up. So radiosurgery is another way of treating that. It is definitely a very good option, and it has changed that outcome. And current scenario that gamma knife is considered the treatment of choice, but with some limitations. It is very well tolerated by the patients, and AVMs which was previously labeled as untreatable, we can definitely make them treatable, but many times with the combination of the therapies. So factors which influence that obliteration is the volume of the AVM, then target, whether it is a compact or diffuse, radiation dose. Higher the dose, less is that chances of higher is the dose that is obliterate that AVM completely. And drawback of radiosurgery is that there is a latent period and there may be a dose related radiation edema. This is definitely is there, and many patient faces that, many times asymptomatic and symptomatically also, and risk to the critical structure like to visual apparatus or the brainstem. And radiosurgery is also not without complication, transient neurological deficit, cranial deficits, and then there is maybe hemorrhage. So we had that hemorrhage around 6% of small and the 11% for that large AVM with the 6% mortality. And these are few cases the post gamma knife complete obliteration. And then we do with a very grade 4 or 5, we do that volume staging, which is a different way to treat that in small segments. And it is also a very encouraging technique to tackle the large AVM and there downstage them, then you can go ahead and operate them. So you see that this AVM downstage to this level and you can surgically excise it. And this is our data at AIMS, and more than 80% of reduction in volume, not 100%, but definitely reduction in volume. And this is that guidelines for the North American multidisciplinary management guidelines, that is grade 1 and 2 surgery, and radiosurgery may be offered for grade 1 and 2 if the patient doesn't want it, but we must convince them. Combined therapy for higher grade with embolization or the SAS, and the surgery alone is not recommended for grade 4 and 5 AVM. To conclude that cerebral AVMs are challenging lesion, but they can be tackled very well with the different modalities, and each case requires the careful evaluation. Every AVM is entity and it has to be dealt accordingly, and multimodal treatment must be adopted whenever indicated and to have the best outcome. Thank you.
Thank you, Professor Manmohan, and thank you very much. I call Professor Charlie. Where is he?
Charlie.
Charlie is there.
Start the next one. Call Adesh.
Okay.
Adesh can give his talk.
Can we give Adesh, and he's going to speak on is keyhole brain surgery still possible in second tier and third tier cities?
So we all have been talking about minimally invasive brain surgery, and as we all know that minimally invasive brain surgery aims at making smaller incisions, smaller craniotomies, smaller durotomies, and minimal damage to the brain. I would like to thank Ashish sir and his team for giving me this opportunity to speak, and by the time they set up, yeah. So I learned my keyhole concepts in neurosurgery from Dr. Teo, what he taught us today morning as well, entry point, exit point, the long axis of the tumor, and the gravity assist. But one thing I realized that all this, there was a word that large craniotomies are being made which are not needed. But why in the first place it used to happen is because we are not sure where we are entering. In majority of the cases, a navigation may not be available at every place. This keyhole navigation has been possible because of the availability of a navigation machine which gives you the exact marking of the skin, the precise craniotomy, and you can reach bang on the lesion. But what happens when you don't have it? I mean, when I returned back after training from Professor Teo, we did not have any navigation machine, and I was looking for options as to what can be done to circumvent that. there were many available options at that time, but somehow we were not comfortable using this. We decided, let's look at the basic points. What do we need for deep-seated lesions? That is the long axis. And for the superficial lesions, as to the surface marking. We had a few resources. All of us have good mobile phones, good tablets, good laptops these days, very good computing power. And obviously, most of the patients now come with CDs and DVDs. We get navigation grade imaging very easily these days. So what we did a software-based planning, and it was divided into two parts, a pre-operative and the post-operative. Pre-operatively, with the help of the axial cuts and the VR images, we labeled the ROIs, the regions of interest, and decided upon our marking. I'll show you as to how we do the incision marking. As you can see in this case, the patient has been placed, and the 3D VR image on this tablet is being made in a way that it is simulating the patient's position. And now, by windowing the VR, using the variable window method, we can see how deep is the lesion and where is the lesion if we go at this particular skin point. So that's how we mark the tumor and then the incision. In fact, we do keep, you can see an A incision and B incision. In case things go south, we can always convert into a bigger craniotomy. Intraoperatively, we either use a touchpad, which can be used to navigate the images, or we can use a mouse which is covered with a sterile drape sheet, and you can easily do the intraoperative VR windowing, variable windowing, wherein you can see the tumor and understand as to what is the anatomy of the tumor. So I'll show you two types of examples, some depth lesions and a couple of surface lesions. Depth lesion, this is now a mesial temporal lesion. This patient came with intractable epilepsy. As you can see, he has a mesial temporal lesion on the left side. It was pre-operatively diagnosed as a tuberculoma because the T2 images were hypo-intense. But since the patient was not responding to ATT of 3 months and the lesion was increasing in size, we had to take him in. As you can see here, pre-operatively we decided we will be entering through the superior temporal gyrus. We marked our entry point and craniotomy point based upon the VR images. And intraoperatively, this was the way the patient was positioned. Again, the lesion was marked. A linear incision, small craniotomy, and through the superior temporal gyrus, we entered inside the tumor. As you can see, a small transsulcal approach, we could go inside and take out the tumor in totality. And this is the post-operative scan, which shows that we could take it out completely. It was a tuberculoma, in fact. Coming to some more deep-seated lesions, this is a pineal region tumor. Again, the long axis was going below the tent. So we decided to go supracerebellar infratentorial approach. Here you can see again deciding as to how much the neck tilt has to be so that we make the tent as vertical as possible, and then making a small craniotomy, and as Professor Teo told, not to put any retractors there, we could take out the tumor completely. This is the post-operative scan. A temporal metastatic lesion, similar way. Again, the marking has been done on the VR images, and the same is then marked on the patient's skin directly using the help of this volume rendering. Once the marking is done, a small craniotomy and the whole tumor is removed. A posterior thalamic tumor which was cystic and extending into the pineal region. Here you can see again the positioning has been done based upon the vertical axis, and the tumor could be removed in completion. Now coming to a few surface lesions. This is a left parietal glioma, as you can see. Again, preoperatively, we did the ROI marking of the tumor and decided upon that what would be the position of our patient's head in order to access the tumor right on top of it. Marking the skin incisions, again a linear incision, small craniotomy, and this is the post-operative result. A right parietal glioma, as we evolved, we started doing more difficult cases with smaller incisions. Now, this was a right parietal glioma. As you can see, it is actually just behind the motor strip. It is pushing the motor strip anteriorly. And in this case, since the lesion size was considerably large and the motor strip was at stake, we still took a curvilinear flap. So that's how the patient was position prone, and to keep the tumor on the top, we are doing this variable windowing again. We decided our craniotomy, and post craniotomy, as you can see, after durotomy, we have marked the lesion based upon the anatomy which was seen on the surface. And it's almost like in toto, we have taken off the tumor here. This is a right posterior frontal glioma. It was just abutting anteriorly to the motor strip. Again, as you can see, we did a surface marking on the patient using the very same technique. This was the position, and when we opened it, we were the small durotomy, we were bang on the lesion, we could see it and we could take it out completely. Another left frontal glioma, again a large one, and as you can see in the previous image, we have shown that there is a red marked area which is actually the point where the tumor seemed to be surfacing. And this is the marking, and intraoperatively this was probably the point where it was most near to the surface, and we could take it out completely in total. This is the postoperative scan. A right parietal epidermoid. Now we would not like to do a very large craniotomy for an epidermoid, especially when it is surfacing. Again, using the same principle, we decided as to what should be the position of the patient, and marking the incision accordingly. And again, after the small craniotomy and durotomy, we are bang on the lesion. So we have had a good experience with these cases over the last many years. In fact, we found that we had statistically significant results with, as compared to the incision length, the surface area of the craniotomy, the duration of the surgery, wound complications, and the length of the hospital stay. We in fact last year published our results. And to conclude, I would request all my young colleagues who are working in centers where you don't have a navigation machine, but still you can give your patients the benefit of keyhole surgery if you use what is easily available to you. And the best part of this is that once you keep seeing the images again and again, day in, day out, in the night before surgery, you are doing your 3D reconstructions, you're rotating the brain up, down, all the sides. So your overall understanding of the brain anatomy also improves, making you a better neurosurgeon. Thank you.
Thank you, Adesh. And then the last talk by Dr. Charlie, and he's going to talk on the keyhole pterygium approaches.
Okay, so this is a very quick talk. It's very simple. It's simply discussing the mini pterional approach. Essentially, the mini pterional is exactly like the pterional, except it's mini. So indications, limitations, positioning of the patient, complications are all the same as the pterional approach. So this is a pterional approach that you and I were taught. We were taught to make the incision as close to the tragus as possible to avoid damaging the frontalis branch of the facial nerve. But if you look at the literature from our plastic surgical colleagues and our anatomy colleagues, it in fact is an overkill. And what I mean by that is if you look at the course of the frontalis branch, the course of the frontalis branch is such that it falls in front of the 50-yard line. So if you make a point at the tragus, put a point at the external canthus, dissect that line. That's called the 50-yard line. And the incision should be approximately, 1 or 2 millimeters behind the hairline. So that's the danger zone. It's not back here like we were taught. That is the danger zone, and if you can avoid that, then you'll avoid the frontalis branch. It's very, very simple. If you can bring your incision forward, then of course you can reduce the size of that incision. It's as simple as that. So, all these lesions that you would normally use the pterional approach, you can use the mini pterional approach. So instead of these big incisions from tragus to the midline, bring it forward, curve it forward, here's your tumor, and you can use that sort of mini approach to achieve the same goal as a pterional approach with very good cosmetic results. Again, here's another case. There's the incision. Another case, there's the incision. So here again, tragus, outer canthus, 50-yard line, hairline, 1 or 2 millimeters behind the hairline, and that gets you to the pterion, which is right here. Heals well, no frontalis palsy. Another case, heals well, no frontalis palsy, and the list goes on and on and on. So here's an operative case. Okay, so the first incision is through the scalp to the aponeurosis. Thereafter, you open the temporalis fascia in a double-breasted approach. In other words, you don't make the temporalis fascia incision directly underneath the skin incision, you make it more posteriorly. By making it more posteriorly, you can then reflect the frontalis branches anteriorly in that fat pad where they lie. So a double-breasted opening, skin incision, more posterior temporalis fascia incision, that will then reveal the fibers of the temporalis. Look for the fibers of the temporalis and incise the temporalis along the fibers to reduce the amount of necrosis that you'll have of the temporalis muscle. You can make that incision in the temporalis muscle according to where you want your craniotomy. If you want it to straddle the sphenoid wing, then you make it along the sphenoid wing. If you want it more subtemporal, then more posterior, more subfrontal, then more anterior. Here's the pterion. This is the, you can see the sort of valley in the groove of the valley, and this is where we're going to center our craniotomy, so that when we eventually open the dura, we find the sylvian fissure. And again, the operation is exactly the same as a pterional operation. So here's the sphenoid wing, frontal fossa, temporal fossa, splitting the sylvian fissure and taking out the tumour, as you would normally a pterional approach. And at the end, you'll see there's exactly the same as the pterional. So sphenoid wing, frontal, temporal, splitting of the sylvian fissure, tumour gone. Simple as that. Thank you.
Thank you, Charlie. I think there's no question on this session. Thank you very much for the extremely nice presentation. We call the organizing team to take over now, please.
Thank you to the chairpersons and the speakers for the session. I would request the chairpersons to felicitate our speakers. Professor Y.R. Yadav, sir. Madam. So, madam. Dr. Deepak Agrawal, sir. Dr. Manmohan Singh, sir. Dr. Adesh Srivastava, sir. Thank you, sir. Now we will begin the inauguration ceremony for our conference. टेबल नहीं लगाना So nameplates. कैसे बैठेंगे? सक्सेना सर नहीं आए अभी। नवनीत सक्सेना सर दिख नहीं रहे। नवनीत सक्सेना सर नहीं दिख रहे ना अभी। ठीक है, आ जाओ। हाँ?
Good afternoon to one and all. It gives me immense pleasure to warmly welcome everyone, respected faculties, all the delegates, and now we formally commence the proceeding of this inaugural program. And now I would like to request our distinguished guests to kindly grace the dais. I would first like to invite Dr. Alok Agarwal, Chairman of Organizing Committee and Senior Neurosurgeon at Aditya Hospital, Jabalpur, who is one of the pioneers in the development of neurosurgical care at our city. Sir, please kindly come to the stage. May I now invite Dr. Professor M.P. Gupta, Senior Surgeon in Jabalpur and former Medical Superintendent at NSCB Medical College, and currently the Director of Ashish Hospital in Jabalpur. Sir, kindly. Thank you, sir. Now I would like to request Dr. Amitesh Dubey, Director of Neurosurgery at Adi Shankar Hospital, Jabalpur, and a member of Organizing Committee. Sir, please. Thank you, sir, for joining us at the dais. Finally, I would like to invite Dr. Prashant Kushwa, Senior Neurosurgeon at Jabalpur and Organizing Co-Secretary, to kindly grace us with his presence. At last, I would like to invite Dr. Navneet Saxena, Dean of NSCB Medical College and a renowned ophthalmic surgeon, who usually is known for his zeal for supporting all the activities at our city. At present, we'll just wait for him. Sir is a little late. And I request all the dignitaries, sir, please kindly light the lamp, and we'll start for Saraswati.
We would request Dr. Yadav sir, Parthiban sir, Patkar sir, Goyal sir, and Dakwale sir to join for lighting the lamp. Please, sir. And Dr. Ashish Tandon sir.
श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती क्लेशजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
I would request all the dignitaries to please be seated. I would request Dr. Alok Agrawal sir to welcome our chief guest, Dr. MP Gupta sir. Book is there. I would request Dr. Ashish Tandon sir to welcome our organizing co-secretary Dr. Prashant Kushwaha sir. Now I would request Dr. Alok Agrawal sir, the organizing committee chairman, to guide us with his valuable words. Thank you.
It's a privilege to welcome you all to the 15th Minimally Invasive Endoscopic Brain, Spine and Pain Cadaveric Conference. Minimally invasive surgery is not only a small incision and optics, but it is to preserve anatomy and physiology more effectively. Endoscopy has changed surgical philosophy. Cadaveric workshop, which was held yesterday, was a bridge between theory and operating room. And we had galaxy of stars guiding us. Future of brain and spine surgery will be more precise and patient-oriented. Coming to Jabalpur was highly rewarding experience. I do hope so on behalf of organizing committee. Best wishes and thank you all.
Thank you, sir, for your speech. And now it's time to hear from our respected chief guest, Professor MP Gupta. Sir, kindly enlighten us with your words. Thank you, sir.
All the speakers and participants of this very important, valuable conference, neurosurgery, all the aspects of the neurosurgery, different techniques, advancement, and so on. It's really, as we all know, these conferences, workshops are very, very useful in training the young doctors, young colleagues, young surgeons. I heartily congratulate all the participants. Thank you.
We would like to welcome Dr. Navneet Saxena sir, guest of honor for the occasion today. And I would request Dr. Ashish Tandon sir to please welcome Dr. Navneet Saxena sir. He is currently the Dean of NSCB Medical College in Jabalpur, and he is a renowned ophthalmic surgeon, and he is always there to help us for arranging all these academic sessions around in the city. Thank you, sir. Thank you for coming. I would request Professor Navneet Saxena sir to come here and enlighten us with few words, sir. Please, sir.
Good afternoon. Sorry for being late. Endoscopic brain surgeries and management of pain. Today we have all of us gathered here. On the dais, my dear friend Alok sir, Gupta sahab, Prashant, and Amitesh, sorry. और मेरे दोस्त बहुत पुराने और बहुत लंबे साथी, मैंने आपके साथ काम किया है, आपने मेरे साथ काम किया है, यादव सर, आशीष, बहुत सारे लोग हैं जो यहाँ बैठे हैं. और इस वर्कशॉप का, that is the aim of all the workshop, what I believe personally, I am also a clinician, goes to All India conference and state conference and all. So this is the place, in fact, where we can interact with the stalwarts of their own field, with the experienced surgeon with their old field. And we can take the advantage of the experience of the senior surgeon. You can discuss with your problem, what problem you had, because in life nothing is bookish. You have to develop your own clinical sense, your own clinical style of treating, your own style of surgery. And I always say when I speak to the first year student, and recently, I think last couple of years, there is a program which is standard program by NMC, and it is being done in all medical colleges. Just to share my information with you, 1 month, that's the foundation course, and there are different topics are there to interact with the students of the first year. And I am teaching their medical ethics. So I am not comfortable at all teaching ethics, because he is the first year boy. He doesn't know anything about medical fraternity. He doesn't know anything. And we are teaching ethics. So I teach my postgraduate, yes, that's the ethics. So just want to share in this forum that at least we can practice ethically and always benefit the patient. That is my motto of doing cataract or ophthalmic surgery throughout my life. So I congratulate all the office bearers and organizers to bring all those brilliant brain together here and discussing your all problems in all deliberations. So enjoy the scientific evening and the Jabalpur town for the tourism as well. Thank you very much.
Thank you, sir, for your valuable insights. As we come towards the conclusion of this inaugural session, I would now invite Dr. Prashant Kushwaha, sir, for his vote of thanks. Sir, please.
Good afternoon, respected dignitaries, colleagues, and dear friends.
So on behalf of the organizing committee of the 15th MIS Brain Endoscopic Spine and Pain Management course and cadaver workshop, we extend our heartfelt gratitude to our honored guests. And first of all, we would like to thank our guest of honor, Dr. Navneet sir, Saxena sir, who is Dean of NSCB Medical College. Thank you, sir, for your presence and gracing us and your encouraging words. Your support inspires us to keep advancing neurosurgical education here in Jabalpur. Also, sir, to our chief guest, Dr. MP Gupta sir, we are deeply grateful for your time and blessings as we continue this 3 days of learning. Your leadership and presence sets the tone of this gathering. We would also like to thank all the faculties who have come from all over India and abroad, delegates and the team behind the scene. We hope these sessions spark ideas and collaborations that last well beyond this conference. Thank you so much. And I'll request everyone to join for lunch. Thank you.
I would like to invite everyone for group photograph now. And lunch is arranged at 2 places. Firstly is at the front of the hall in which we are sitting, and next is in the restaurant. So wherever you are comfortable, you can join for lunch. And we are already running late, so I request everyone to come fast after lunch so that we can start our next session. Thank you. I would request everyone to join for group photo, please. We will be starting our next session from 2:15.
Hello, check. Hello. Hello, check.
थी। इनो सिर्फ 6 सेकंड में शुरू करेगा।
Good afternoon, everyone. So we'll move on to next session, session 4, post-lunch session. So already we are running half an hour late. So our welcome first speaker, Professor Dr. Sushil Patkar, sir. He will be speaking on percutaneous transforaminal endoscopic lumbar discectomy techniques and tricks. Over to you, sir.
In spite of the blood sugar going high, it's not getting connected. Pardon? Hello? It is not connected. So I'm going to talk on percutaneous endoscopic discectomy. I have gone through the entire spectrum. I began in an era when I used to do the myelogram myself. Then we used to do laminectomy. Dr. Goel must be remembering, that was a time when CT scan also was not there, MRI was not there, and then we progressed gradually on to microlumbar, then endoscopic. Of course, I have no disclosures except gratitude to my mentor and to my beloved wife who has shared my journey right since my registrar days. These were the people who revolutionized. See, the whole argument of shift towards endoscopic disc surgery came because of the argument that backache does not disappear after lumbar spinal surgery. So whatever true endoscopy you do has to avoid the back muscles. As long as you are going back into the back muscles, you are not following. These people proposed the idea that you must not go into the back muscles if you really want good results. So Hijikata and Cambin, then of course, Anthony Young. I trained with Sebastian Rutten for some time, and of course with Gun Choi. These are the two people who kind of changed my concepts to certain extent, not completely though. So they were, during when I started endoscopic discectomy, the trick was to go and do the inside out technique. I come from Pune, which is the birthplace of endoscopic spine surgery. Gore was in the next door hospital, and I was in his contemporary that time in neurosurgery. You all must be knowing about Satish Chandra Gore. And he pressed on, and I got disillusioned. So the inside out technique of Anthony Young was to go and do indirect decompression. And that I didn't find impressive. And then came, of course, microdiscectomy. All the other techniques were through the posteriorly, through the muscles. So they were, in a way, against the philosophy of endoscopic disc surgery, which was because you are not supposed to create this scar. The lamina has no role in production of the pain. The ligamentum flavum has no role in production of the pain. So why are you removing it? If you are removing that, that means you are against the principle of the main objective of endoscopy. So these are, I apologize for the slides, these are the pre-op, post-operative pictures. And the whole concept was to go outside the muscle, what Sebastian Rutten brought the idea that you must go into the foramen rather than into the disc. And see the differences between microlumbar, tubular retractor, and percutaneous foramen, transforaminal. So the trick was to get the correct position of your sheath. And the correct position also, this is a case of a large disc which has been removed, and you can see the difference in the pre-op and post-op. And this is the position of the cannula has to be positioned correctly. And these were the people who thought of this, that there is a big space available to us. This is my friend Satish Gore, who really struggled and pressed on with various companies to make during my time, the problem was the biopsy forceps. The biopsy forceps were very delicate, and the maximum operating channel was 2.7 mm. And therefore, endoscopy did not take up in our country so well. This was the operating channel, and then it has progressed now. Now the channels are much bigger, of course. The trick is to get your needle correctly into the Cambin's triangle, lateral to the medial pedicular line, and once you do that, that should be done avoiding the peritoneal cavity. So there are various techniques described how to put the needle and how to, but these were essentially the way of how to go in for the prolapsed fragment. And this was the technique which was described by Sebastian Rutten. The main impediment was the superior facet and the ligament, so you had to have a technique where you go correctly, and this was my contribution. I used to take the patient and make them prone on the bolster like you are going to do in the theater, and then see the trajectory, how far lateral I can go without violating the peritoneal cavity. And you would be surprised, sometimes it can be very, very far lateral, and safely you know where you can enter into. The more horizontal you are, the more your vision improves. The more oblique you are, the less your vision improves. This I had published to use CT scan and simulate the position in surgery pre-operatively, so you can go far, far lateral to put in your cannula. And this was how the cannula should look when you are in the final position before you start the discectomy. It should be lateral to the medial pedicular line, and it should be looking into the disc space, then your job is done. If it is a clover, your job is over, they used to say, in pile surgery. So this is how I used to first, I do the epidurogram and see the exiting route, then get the cannula in correct position, and then start the operation. Now these are a few cases, pre-op, post-op, pre-op, post-op, pre-op, post-op, pre-op, post-op, pre-op, post-op, pre-op. This is a migrated disc. Of course, it is in continuity, you don't have to struggle. You catch it and you catch the horse by its tail and it is going to come out. And the end point is that you will see the hole in the annulus and there will be a gush of little blood from the epidural space, and sometimes the disc fragment will be so big that you will remove the endoscope and get it out without the endoscope, and you can see the epidural space pulsating. So yes, you see this woman who had come to me from UK, and you see the agony in her, the disc is removed, and then you can see the smile on her face. You can see this is immediately after the operation. I used to do them in local, then I started doing them in general. I used to get some friends from abroad to learn. This was Pandurang Kulkarni, those who know, he was a spine surgeon at King's Hospital, London. He had come to spend some time with me. And this was the pre-op, post-op. But of course, I will not waste time, discussions, contraindications. They have changed over a period of time. But yes, there is evolving evidence that this transforaminal endoscopic discectomy is a good option. I have also published my work over the years in various journals and the textbook of WFNS textbook, etc. But it's just going on and on. But if you see, there are certain cases which are difficult, but that difficulty is changing. But still, microlumbar remains the gold standard, according to me also. Transforaminal endoscopic discectomy will become the gold standard over a period of time. The difference between various endoscopic disc surgeries is like that. Whether you are doing microlumbar, whether you are doing endoscopy, the end result is both of them reach the finish line. Focus on relief of the pain. Focus on decompression of the root. Change the name of the operation. The operation is not discectomy. The operation is decompression of the root. Everybody wins. Then over a period of time, I changed the focus, and this is one big problem which stopped me from transforaminal surgery. There is a significant amount of radiation, and in our frenzy, how many of you use thyroid shields and eye goggles while doing endoscopic dissection? You don't use for your eyes, do you? No. So you are exposing, over a period, so many cardiologists have died of lymphoma. At present, amongst my colleagues, there are 2 patients who are undergoing treatment for lymphoma and leukemia. So don't be very fast. First, protect yourself. I wore the Geiger counter and I checked, I was getting, in 3 months I wore the Geiger counter, and I found, because this is not the only operation that we do. We do radiofrequency, we do pedicle screws, we use the C-arm for so many things, and we expose ourselves to undue radiation. And therefore, what Dr. Manmohan said in the morning, I am more inclined doing quick microlumbar and getting out, but then sometimes patients insist, and you have to remain in the market, so you keep on doing things. Over a period of time, of course, endoscopers come. I have zero experience of percutaneous, but I have started doing biportal in a few cases, especially single level cases. I use the Manmohan system, which is just across the road from my hospital. And it is nothing else but laminectomy, discectomy, or laminotomy, discectomy. And you can see for a single level canal stenosis, you can get a very good result. Yes, there is less muscle damage. I do not find in literature any great evidence to prove to me that by doing microlumbar or by doing biportal, there is a significant reduction in morbidity. This whole theory came because of muscle injury, because of measuring the C-reactive protein and creatinine kinase after surgery, but it has not got translated to clinical results. So, yes, there is a learning curve. We must encourage the younger people to do more endoscopy, and we should understand our limitations ourselves, but the newer generation will take over. I will recall your attention to this article. There is no treatment better than rest in lumbar disc prolapse. No treatment. I have, whenever patients come to me because of improper relief, I ask patients, did you undergo a 6-week trial of conservative treatment? And believe you me, no endoscopy surgeon gives a 6-week trial of conservative treatment. Once the patient comes, MRI surgery ka zarurat hai, he operates them. And when they are not happy, but while talking, they always say in their slide, we should give an adequate trial of 6 months. I used to do a lot of disc surgery over a period of time. When I found out that when you advise rest and you wait, many patients become all right, they don't need your services. So we must learn to accept that. Now you look at this Nancy Epstein, she was the editor of, and she was sued by the society because the endoscopic gadget people made her resign when she published that people are hiding their results, and she was forced to resign from ANS. Osman had also written an article in support of her that they are not evaluating the evidence of endoscopic surgery properly. So you should know that, you have to be best versus reasonable is what is important. Don't get fascinated. Don't get attracted to birds in the sky. Don't look at Dr. Atul Goyal and try to remove some tumor from the skull base, saying that if Dr. Atul Goyal is doing it, I will also do it. You have to learn how big your wings are and how much power is there. They can become strong with exercise. But don't listen to his attack the tumor. One size cannot fit. You will be in deep trouble. There will be a whole big bloody mass over there and you will not know what to do. So take home messages, it is doable. Percutaneous endoscopic discectomy is there on the horizon. All endoscopies on the horizon. It will take over gradually, not immediately. Thank you, my dear friends.
So, excellent presentation, sir, as always. So, in your practice, when you were doing transforaminal discectomies, how many shoots you used to take to dock the needle and dilator there, average?
To reach, in the beginning, of course, many. After a period of time, what I realized, what I started doing after I put the needle wire, and over the wire, once I put the dilator, after that, once the dilator was in position, the sheath had gone inside, then I did not require shooting to confirm where I am. The only problem was we all feel that, once you're there, you can remove. Whether you will succeed or not is also dependent upon the amount of fibrocartilaginous nature of that disc.
Yes.
Some discs are soft, which are finished within 2 minutes, and some discs you keep on struggling. It is not just the disc, it is the disc, the ligamento disco complex, I call it, the posterior longitudinal ligament, the annulus, and the disc. Every time people show videos, they want to show the videos of the soft disc. The soft disc is called, this is the disc I removed. But it is not always like that. Some of them are, very, very tough, fibrous, long-standing. And then you feel that, you have not removed, so you do one more shoot, and without the shield, howsoever we have this tendency of, going far away and standing far away from the Siam and seeing, but still you are getting exposed to radiation.
Yeah.
So this the topmost cardiologist of Pune developed a glioblastoma. The first neurosurgeon of Pune, he must be Dr. Shankar Gokhale. He used to not wear lead apron to do angiogram. Those are angiogram. And by the age of 50, he had a lymphoma and he died at 52. So we take these things very lightly, but I wore a Geiger counter just to find out how much I am getting exposed. And then they told me, you are exposed to 3 times than the required dose. And then I was really worried. I said, oh my God, I don't want to be a martyr for, spine surgery.
Thank you, sir. So, any questions? Yes, sir.
I think your point is very well taken that the rest makes the difference. So at AIIMS, I can tell you that our waiting list is more than 1 year. For brain tumor and spine, it is endless. And if you look back at those patients who has been given date for surgery for the spine, I think 80% of the patient, the time their turn comes, they are cured. So they don't require surgery. So I think that is very important to wait, especially if the patient is not having significant neurological deficit. Just for doing the surgery for pain, you just have to keep yourself restrained.
I really feel one must do a study of Koreans without their shirts. Because Koreans have such large numbers, you go to any hospital, they have done, 3,000 cases. I think almost everybody in Korea has undergone endoscopic disc surgery. I think it is overused. It is being overused. Nobody is trying to treat the patient with surgery. And so this is not some disease where patient is going to develop some great morbidity. Wait for some time. And best is surgeons when they come to me. Sir, let us try conservative treatment. So whenever it is on ourselves, how many of us are quick to go for surgery? Hardly anybody. So let us give the same thing to our patients. How many of them tell the natural history? So many natural histories. Gogawala has published from UK, the natural history of disc prolapse is to become all right. Very few end up in trouble, but then we have our car involvement, you want to buy a bigger car, a bigger house, then of course.
So, the transforaminal, why it has gone out of the popularity, gone down for the past few years, because main thing is the radiation. So we did our own study. I started the transforaminal. So we used to do our own study, how many clicks we are taking for a needle to be there in the right position. It used to be 150 to 200 shoots to start with. So that was so much radiation we were getting exposed. So over a period of time, we almost stopped transforaminal except for the select indications for thoracic and extraforaminal. Most of the cases we do interlaminar, which takes hardly 3 shoots.
Patty, I want to raise a very philosophical issue.
As usual.
Are you ready?
Of course, as usual.
You know what he said, and you just listen to me. What he says is that I always give 6 weeks of conservative option, and many of these patients are cured during that time and they don't need surgery. What Manmohan said, that they have to wait for 1 year and eventually they don't need surgery.
All right, yeah.
Now in disc prolapse, what happens is, if the patient has a disc, what you suggest? Wear a belt, sleep on a firm bed, avoid movement, complete bed rest, that is what they say.
Rest, not complete.
Listen. Problem is, when he moves little bit like this, he suddenly gets a catch in back, little bit, because that belt is not very strong. So the long-term story of a disc is that it will spontaneously resolve. That is the story. But the problem is, we don't have a belt which can give a strong, movementless belt. Little bit here, during sleep, little bit he turns and gets and starts jumping. Imagine if you just fix that segment. Just do fixation. Means you are giving a fixed belt, no movement, the disc will go. Think about it, we don't discuss it. We don't discuss it. Don't discuss it. So I have to tell you, I don't have to tell you.
That is what I like about it.
Next announcement.
Hello. Dr. Parthiban, he shall be talking on posterior endoscopic cervical foraminectomy, indications and surgical steps. Please.
It's not endoscopic, but then it's more of the conventional and tubular slides. Yeah. This is something for from lumbar to cervical spine. So we have to see that way. If you want to see that, compare this with microlumbar discectomy, then this easily understood by all the youngsters. Cervical, the classical indication is just a radiculopathy, not more than that, no myelopathy, only radiculopathy. And if you see in the scan, you should have a lateral and foraminal disc prolapse, which is compressing the nerve root. Maybe sometime an osteophyte or a disc complex, both combined together giving a radiculopathy. And sometimes it is very good technique for people with a short neck, where anterior approach is not possible. Particularly, I like this technique to be done in the lower cervical level. It combines with short neck and lower cervical, C6, C7 particularly. And if you have any other contraindication for anterior approach. The main thing is it is not recommended for central disc prolapse. So this summarizes the complete. I'm going to show only the videos. So you're going to see only case examples and videos. This cervical microdiscectomy, where is the, yeah. And you can see that this is our classical incision midline, prone position, all these things you all know about it. You localize the site of lesion and you dissect this paraspinal muscles, then you can see the same complex as you see in lumbar spine. This is lamina, this is lamina, and then the facet joint. Lateral mass is there. So a small foramen is what we needed for doing this surgery. Now in this case you can see on the left side the foramen is very narrow, and there you have something like this, the C6, C7 disc degeneration with nerve root compression and radiculopathy. Now this is my technique, and if you carefully look at this is a double hook retractor which I devised 20 years ago, and I use it because it does not plug into the ligament, but then you take up the bones, hold it at the bone on the lateral aspect of the spinous process. So it holds very nice, and retracting the muscle against the bone is much easier than against the ligament. And this can prevent your neck pain post-operatively. And you can see the lamina and facet joint are well exposed. Then as usual you can do a small, with a drill you can make a small nice foramen drilling there, both the lamina inferior and lamina superior here, and medial facet. Medial facet you can remove as you wish, but then a little bit. I'll show you, I go by gradation of decompression on the lateral aspect, and since this is the nerve root here, if you see that MRI, because there's no soft disc, it's only the bulging disc, which was very hard. So the nerve root is well decompressed. I assess this decompression with a probe, and also sometimes we use the IYNM just to confirm the radicular region. It's just at about less than 10 millimeters of dissection what you need, exposure. Now you can see the video here. Yeah. So this is the exposure. This is a double hook, and here you can do the drilling there. Yeah, this part you can control yourself how much you need it. You don't need to go on drilling to very far lateral, but just see up to here and see that the nerve root is well decompressed. Finally, the patient has to be good. People used to say this is a non-fusion technique of decompressing the nerve root, and so you can do the same procedure. So this is the, I can see the nerve root nicely moving, so this confirms I'm pretty happy. And if you're using the IYNM, you can see the waves sometimes changing very nicely. This is another case. Now you can watch here. This is on the right side here. A little bit soft disc, soft extruded disc is there. Same foraminotomy, same. Now you watch here nicely. You can see, in fact, that you can see the disc bulge there. The nerve root is here. And same thing, like what we do for microlumbar discectomy. This epidural gush of blood is a classical example that your nerve root is getting decompressed. So in fact it is very enjoyable surgery, and you should be a little bit meticulous. No need to hurry up, no need to pull out, because you are dealing at C4, C5 particularly. Your deficits are well obviously seen post-operatively, but a good microsurgical technique can solve all these issues here. Now you can see very nicely this epidural gush, that gives you that, okay, you have done a great job. Yeah, a little bit of bleeds, all those things can be packed with Surgicel, and it will give a very good hemostasis, and then can be closed as given the technique. And when you have a hard annulus, sometimes it is pretty hard, as we saw in the first case. You can see here again the same foraminotomy. You can see this very pretty hard. So whenever there is hard, I don't do much. I just leave it just for the roof is decompressed when it is very hard. But when there is a soft, when you try to open it, it's not going, just leave it. Unless there's a huge osteophyte where you can drill it out. Otherwise, you just need to do this. This is the one thing I assess according to need. A small probe is enough. You can put it laterally and see the nerve root is well decompressed. You can take a little bit more time at this place because decompressing at this place alone may not be, but the foramen has to be released. Yeah, this is how you can confirm it gently. And these are the technical points. Basically, this is the step by approach is the same approach. It's a large fragments. Large fragments are sometimes pretty troublesome for all of us. You can see here it's a big, large fragment. And you can see this, even in fact that I was not able to see the nerve root there, but I saw only the disc. The disc was very, very large. In some cases, as we see in this migrated disc at the lumbar region, sometimes it goes up, sometimes it goes down. What you have to do is a little bit carefully explore the axillary region, explore the shoulder region, and slowly retract the nerve root. The nerve root, that means the dura. So the root dura must be retracted very gently, not to push forward. I always use a very sharp hook and do small micro movements until I get this complete chunk of the disc. You can watch here. Sometimes it is funny, you can always pull out with a punch, but I usually try to bring it as much as disc out. Then after that I use the punch. Yeah, like this. You can see the gush. This gush of blood shows that it's a very good decompression has happened. And then you can put the surgicel. You can see the nerve root there. So this gives a very good decompression, and still you can follow the nerve root there. You can follow the nerve root, and you have a satisfactory removal, and patient's recovery is very good in the post-operative period. So you can see that, and how I am using the same something what we do in our lumbar discectomy surgery. Now, morning I was telling you, please know how to do the classical technique. Then you can use anything you like. You want to use tubular, then this is a tubular surgery. Here you can see, here is the, this is an adjacent segment. There was surgery done by me long time ago, ACDF, and there was one level, there was a degeneration, and there was some osteophyte was coming, and then we have to do surgery. This time we went posteriorly, and this is the tubular retractors. Every day you are listening this day and day out. So I need to show that the same thing, same technique through the tubular. Only thing is you are going through the paraspinal, right? The muscles are split. The muscles are not exactly. That's all. Beyond that, nothing else there. And the surgical technique is the same. If you repeatedly see these videos, then you learn a lot. Because you can see the surgeon how, what type of burr he is selecting at what level. This is what I think the younger generation should see, and you can see the punches how going on. Then you can see this. I said both on the shoulder and also on the axillary side. There you can see the disc there. Very nice disc there. Then you can always and take it out. So generally I like this technique and use it very judiciously, not in all cases. Far lateral disc, single radiculopathy, single level, short neck, and lower C6, C7, C5, C6, and we give a very good result. The moment the nerve root is decompressed, you can see this. So you can achieve two things. One is straight away taking out the disc material, and also to extending this foramen otomy. Yeah, and then it is very nice, and then nothing else, nothing more than this. So I have to conclude my talk at this time. Thank you.
Thank you, sir. It was really very nice presentation, very nice and clean dissection. May I request anyone, any questions?
Okay. Yeah.
Troublesome bleeding.
Yeah, it is keep coming, but just wait for some time, hot water, saline irrigation, head elevation, and it settles down most of the time.
Okay.
We hardly have seen, it's just patience, that's all. It settles down. But as you said, if you do the surgery under water irrigation, probably I think that may not be, because every time I take out the disc, you can see it, no?
Yeah.
It bursts.
The bleeding, I think, is a function of the anesthetist.
Yeah.
I learned from Atul. Atul, when I started, if there is, tell that anesthetist to control the bleeding. So the bleeding is because they are bagging the patient too much, or because the peak airway pressure is there. These first two things, if they are controlled, 95% of the bleeding is stopped.
I obviously didn't tell
And when you
anything
try to
because
put Surgicel, they will bag at that time, and your Surgicel will be blown out. But anyway, I agree with you that the bleeding can. But what is your opinion? You are an endoscopic surgeon. What is your opinion looking at this operation of so much muscle damage, dissection?
No.
Sir, this is surgery I love, sir. I begin with open posterior cervical, then switch to MIS, and now switch to monoportal.
Yeah.
So monoportal, it's usually a venous bleed, not that torrential bleed, but it troubles a lot. So at times you finish your MIS posterior cervical in 20 minutes. Another day, same surgery may take 2 hours. But with irrigation, that issue is solved, sir.
Yeah.
So for last 3 years, I've stopped using this MIS, sir. Thank you.
I'm not, but I have seen one in ACDF. I have seen long years ago. There was a drop of the biceps, but then that improved in a laminoplasty case, cervical laminoplasty. But so far I have not seen, particularly about C4, C5. I'm always a bit concerned. That's why my technique, I like to be very, very meticulous, not very crude. If you see the dissection at the axilla and also the shoulder, you have to see where it is, the dura is very thin. So you have to be very gentle in pulling it, pushing, so that you can avoid injury to the nerve fibers inside the dura.
So have you encountered any the bifid nerve root or any vertebral artery injury during your course? No bifid nerve roots?
No, so far. But in lumbar spine, I think, bifid, I think in lumbar spine once I had, there were double nerves going, not in cervical so far.
So I have encountered one bifid nerve root, and believe me, it looks like disc. So one has to be very careful while reading the MRI, and also because I'm a endoscopic surgeon nowadays. So with endoscopy, you can see, you can differentiate between nerve root and disc, because the disc, usually it's a soft disc, you can just hook out and remove it. So one has to be careful in those cases.
Thank you, sir. So we'll go to the next talk by Dr. Adesh Srivastava. He's talking on keyhole brain surgery still possible in 2-tier and 3-tier cities.
No.
I think that one was over. It's
okay. So he's talking on going back to the original approach
for pituitary
adenomas. Yeah. So transeptal approach to the sphenoid sinus.
Yeah. Good afternoon, everyone. Thank you, Ashish sir and his team, for this opportunity. So, can I have the slides? Yeah. We have discussed it in the morning when Dr. Subodh gave his presentation about moving to uninostril from binostril for majority of the pituitary adenoma cases. So, we all know that transsphenoidal surgery has its own fair share of nasal morbidity, and it is well documented that such nasal morbidity is often underreported not only by the surgeons but by the patients themselves, because everyone is overwhelmed with the primary pathology is they ignore what is happening outside. And the literature is equivocal. I mean, everybody said so that we need to reassess the literature, we need to take it with a pinch of salt. So the literature is equivocal that you can find equal number of articles both supporting as well as refuting the uninostril approach. In fact, this recent study from CMC Vellore by Dr. Rajshekhar's group also found that their results with uninostril was much better as compared to binostril. I'll skip all this literature. We also did our analysis at AIIMS Bhopal, and instead of the regular SNOT score, we use the ASK-12 score, which is specific for the anterior skull-base surgeries through the nostril, and they concentrate more on the nasal symptoms rather than other associated symptoms. And we did find that the sense of smell, the sense of taste, and the overall nasal functions were significantly better with uninostril, both in the long term as well as the short term. So what did our study give us the conclusion? That uninostril is preferred over the binostril. But we have evolved further, and our current recommendation is on the principle of do no harm. Stop using the nostril altogether and go back to the corridor which was used in the microscopic era, which is the transseptal endoscopic approach. Now, I'll show you a couple of case examples of how this transseptal approach that we use, it's very common. We all have been using, just that now we have to be more conscious about it, not to enter into the nasal cavity. So everybody has been doing it, but when you do it with more caution and with the thought that you have to avoid the nasal cavity, your results change. So this is a case of a 57-year-old male who presented with a large pituitary adenoma, and there was some evidence of past apoplexy as well. So as you can see, the nasal phase, one thing to note here is that you can see that we do not clean or pack both the nostrils. We don't go through the other side, just clean the single nostril. Then once you go inside, you just do the inspection and then go directly towards the septum. Make a vertical incision in the septum after you have identified the structures as anterior as possible at the mucocutaneous junction. Try to be as anterior as the anatomy of the septum permits you, and then go paraseptally. So once you go paraseptally, you can gradually elevate this mucoperiosteal flap and reach up to the keel of the vomer. Then you fracture the junction of the bone and the cartilage, and either you take out the bone if it is very hard, or sometimes even in many cases you just push the bone to the opposite side. Obviously you need to fracture it at the keel of the vomer. Once that has been done, I'll skip this Haddad flap, this is from another video. I mean, that's why we took the vertical incision, that in case one needs to take a Haddad flap, that vertical incision can then be extended to harvest a Haddad flap. So we are just taking one vertical incision. So this case is, as you can see, we have taken a vertical incision, we have taken a nasoseptal, we have gone transseptally, removed the bony septum, posterior part, and now we are taking out the keel of the vomer. And as you can appreciate, the whole thing is being done through that small corridor, and that corridor is enough. You can easily put in 3 instruments. I mean, your scope is there, a suction is there, and there you can see even the drill is there. And working gently, you can very well reach up to your area of target, which is the sella, without putting your scope again and again into the nostril. We are going through the transseptal approach. Now, rest of the steps remain the same. The tumor is being decompressed, and once the tumor is completely removed, we can begin with the routine reconstruction. And once the reconstruction is done, the nasoseptal flap is just apposed back to the midline. So we have done the full surgery going through one side of the septum. We have gone transseptally. We do not push the instrument deliberately, keeping in mind we don't put anything inside the nostril. This is the post-operative scan, and this is I think 3 or 4 weeks later on we did the direct nasal endoscopic examination. The lateral nasal wall structures are pristine. This is the vertical incision which we had taken. As we move ahead, we can see the turbinates are preserved. There is no damage to them. That's the sphenoid sinus opening. The septum is intact. This is from the other side. And you can see all the nasal structures are pristine and we have not damaged them. This is another case of a 52-year-old female presenting with a NOS grade 2 tumor. Again, the same approach, inspection, and then at the most anteriorly possible point, you go and take a vertical incision, take out the bony part of the septum, take out the keel of the vomer, and then again put in your instruments as you would do in any other case. Take off the, curate out the tumor. You can easily put in a scope and 2 instruments. And that's the closure. That's the post-operative MRI. And this is again the D&E of the patient. I think this is a delayed D&E, probably after a month or so. Now we can still see a posterior part of, there's a small hole in the mucosa, but mostly the mucosa is preserved, and more importantly, the sphenopalatine artery, the location of the sphenopalatine artery, that part of the septum is preserved. Now there are a number of cases, as you can see, all these cases, be it a GH adenoma, be it a non-functioning pituitary tumor, have been operated using this approach, and we could achieve good clearance as one would claim with even a binostril approach. Some multiple cases. So what is the difference between the microscopic and the endoscopic approach? Is just the visualization tool you are using. It is the same classical approach. And one may feel that the transseptal may not give enough corridor, but it does. In fact, when your scope tip travels across and goes beyond the level of the sphenoid ostia, your vision becomes much wider. It's like from a tunnel, you are entering into a funnel. So that was with respect to what the benefits the patient would have post-operatively. When does it matter to a neurosurgeon? When does it matter to us? Well, definitely in recurrences, with the number of cases being done, with the number of surgeons operating, residues and recurrences are going to increase. And when such cases come to you, look at this case, a recurrent GH adenoma, and look at the scan. Unfortunately, I do not have a D&E, preoperative D&E, but look at the scan. There are no turbinates. There's no posterior septum. It's like a hollow cavity. How are you going to reconstruct? The best of the tries with our ENT team, and this is what we have in the post-operative period. Ultimately, the patient requiring a craniotomy and a pericranial patch being tunneled in to control the CSF leak. A contrasting case of a post-operative CSF leak, but done through the transseptal approach. That was the small leak which one could appreciate in this image. Just elevate the flap. Just elevate the previous flap. This was the flap. In this case, we did convert it into a Haddad flap because we did not want to take any chances. But then it was a very straightforward case for us, converting into Haddad and then repairing the CSF leak. And mind you, the other part of the other flap of the septum, the opposite side, has not been touched in this case also. So over last 8 years, we have done about 187 such cases, and we have had acceptable results, I would say. So this approach, the transseptal endoscopic approach, we believe that gives better nasal quality. In fact, we are now currently analyzing our results exclusively for the transseptal approach, comparing it to the uninostril versus the binostril. And we believe that it is much easier and it will serve almost 90% of your caseload. And there are no significant differences in the long-term outcomes. And finally, the million-dollar question for all of us is, what would you want for your own self or for your loved one if, God forbid, they have a pituitary adenoma? Would you ask the surgeon to go inside my nostril through both the nostrils and destroy everything, or would you want it to be the least invasive? With that question, I thank you all.
Wonderful presentation, Adesh. So it's the debate still goes on, uniportal versus biportal, continues to the brain also. So any questions?
No, Adesh, I agree that you should go, expose the keel of the wormer and open the sphenoid sinus and see the cellar with the microscope. Why don't you continue with the microscope? Why you have to introduce unnecessary clutter of instrumentation when you can see the whole field? You're seeing the cellar as you showed. Just take an incision in the cellar dura and enter into the tumor. Continue with what you're doing. Why you want to introduce another? So answer this question.
I was trained in microscopic, the same approach, sir, which you taught us. But then with time we changed, we put in the endoscope, started putting in the endoscope. Yeah.
Let me tell you, I have done more than 5,500 pituitaries.
Sir.
I have never felt the need of an endoscope. No, I am not saying don't use endoscope. I am not saying endoscope, if you, as Dr. Patkar was saying, is now probably the gold standard and all those kind of. But people who are experienced in a particular way, like I am experienced in a
surgeon's preference.
Microscopic. I have gone hundreds of times in the cavernous sinus with beautiful exposure, both hands, control of bleeding, control of whatever, and said and done. With the microscope, you can actually, what you have done is halfway and then change the pathway. That is one question.
Sir.
And second thing is you are talking of NOS classification, why don't you talk about Goel classification? What is your problem? See, the problem is, I must tell you, my problem. If I go to other countries, they talk about my classification. If I go to my own country, they talk of another classification. This is the problem not of you, but of our country.
We'll correct our slides, sir.
You better do it.
Sure, sir.
Dr. Adesh, how do you keep distracted the mucosal flap from the septum without any speculum?
Yeah, so the thing is, your scope is mostly inside.
Okay.
For cleaning the scope, we usually ask the assistant to push the saline along the shaft of the scope. Okay. So the scope itself maintains the corridor open for you.
But you are not taking out and putting in repeatedly.
The scope movement is minimal, actually.
Okay.
In case, sometimes when you don't have a very good assistant, I also use a scope holder. Again, the assistant will just keep flushing. If still it does not clean, then I just take a patty, make a roll of patty, small roll, hold it with a small forceps, and then dip it in the Savlon, go inside and just come out rubbing the face of the endoscope.
Okay.
So that helps. I mean, you have to find your own ways, and once you are up to it, you will be able to find your ways. One more thing, when the flap collapses, especially if your suction pressure is high, in that case, the vertical incision, take it a bit lower down onto the the floor of the nose, a little bit on the floor of the nose. That will make it wide enough for air to enter in so that the suction doesn't collapse the cavity.
Okay, thank you.
Professor Atul Goel shall be talking on evaluation of the concept of central, axial, vertical spinal instability and rationalize surgical strategies.
So I want you to tighten your seat belts properly, because some of you may just fall down. Before I talk to you about my beautiful philosophy, I want to invite you for this conference. This is the 15th Asian Congress in Mumbai. Please come, let's see. I'm going to do one-day live surgery in this show, and I hope and I wish and I want that you join me. What I'm going to present to you is, I know many are young, many are evolving, and some have evolved. But what I'm going to present to you is a complete revolution in spine surgery. What I'm going to present is the future of spine surgery. And what I'm going to present is every sentence of mine is published in high-profile journals. Every sentence that I talk is based on at least 15 or 20 years of experience. So just be ready to hear what I'm going to say. When you talk about spine, to anybody, to whether it be neurosurgeon, whether it be orthopedic surgeon, whether it is microscopic surgeon, whether it is endoscopic surgeon, whether it is whatever surgeon, the issue is one, compression, and the treatment is one, decompression. ये कौन बोल रहा है यार बीच में? ये मेरे को आवाज कहाँ से आ रही है? अच्छा, maybe. So the treatment is one, the issue is one. Compression is the issue and decompression. Agree? Is there any confusion in this? I am saying compression you see on imaging and you treat the images. Let us go beyond compression. And I want to introduce to you a brand new concept. That compression is not the issue in spine surgery. Compression is always secondary to local spinal instability. Compression is a protective phenomenon. It is an adaptive process. It indicates unstable spine. You stabilize, compression goes. And decompression is never the treatment. So this is completely different version of spine surgery. Let us see how we can do. So what the issue is, human body is different. We stand on two legs like no other animal on the planet. We stand on two legs, no other animal. Our body is focused, all our muscles are focused, all are behind, and all are meant to make our bodies straight and sit, stand, dance, and run on two legs. All our muscles are focused on the facets. If you put your finger, there is nothing in front. Put your finger in the mouth, you feel the odontoid process. You press here, you feel the vertebral body. You put your finger here, you feel the vertebral body. There is nothing much around the disc, nothing around the intervertebral body. Those are different issues. There are several articles of mine. Before I start this, I must tell you at least 200 publications of mine are there in the literature for you to see when you go back home, okay? About the disc, about the function of the disc, what is disc doing and all those things. All our muscles are focused on the facets. And when the muscles become weak because of old age, 70 years, why your grandfather is shorter than you? Tell me. Have you analyzed why your grandfather becomes short? Because his muscles have become weak and there is listhesis of facets, there is vertical instability. So I wish to introduce to you a brand new concept of vertical facetal instability or telescoping of the spine in the subaxial spine, in the craniovertebral junction. Fantastic, future, revolution. These words look very aggressive. Believe me, I believe in what I'm saying, and all these are very heavily published, and many people in the world are following this concept. You take it or throw it, but at least enjoy it. So I wish to introduce to you the concept of central instability in craniovertebral junction and vertical instability in subaxial spine. Acute instability is different. Chronic instability, chronic, like lumbar canal stenosis, multi-level degeneration, are chronic processes. When there is a chronicity in the whole issue, there are natural protective maneuvers which we call compression, and why we want to do decompression. Chronic is different. Fixed atlantoaxial dislocation. The whole world, believe me, the whole world was doing transoral decompression. For the first time in the literature, we said that there is nothing called fixed, it is unstable. You open the joint, stabilize the facet, there is no need for decompression. Stabilization is the treatment. Decompression is a negative treatment, we said 25 years ago and published 20 years ago. Now you know the whole world. How many people you have seen talking about transoral? There are still few people who are running the show, but nobody talks about transoral surgery for this fixed dislocation. Open the joint, manipulate the facet, see the facet, they are completely unstable. And you do decompression in an unstable situation, you are harming the interest of the person. So over the last 25 years, we have got hundreds of patients. If somebody tries to argue with me, I said, just don't talk nonsense. Open the joint, manipulate. Facets is the issue, facets. Instability at the facet. If there is a trauma and there is a disruption of the facet, what you do? The whole world was doing decompression. Open the joint, manipulate the facet. Rotatory dislocation. Do you know what the whole world was doing for rotatory dislocation? Do you know? Even in my own lifetime, there was no treatment for rotatory. And if somebody was doing any treatment, it was decompression. Learn the art of opening the facet. Learn the art of manipulate the facet. You give new life to this patient. Now, have you seen anybody in the world doing decompression for rotatory? You will not see any single report. If you have seen, show me. Nobody talks about decompression. Basilar invagination. You know basilar invagination, what the whole world was doing? This article of mine is the most highly cited article in basilar invagination. These numbers don't go by this number. This is very old number. Now it is more than 1,000. So I had classified this into two groups, Group A and Group B. I had said in 1998, in my own article, this one, that this patient, this group needs decompression from front and this group needs decompression from behind. In this article, 2004, we said this group open the joint, realign the facets, you can reduce the basilar invagination. In this group, you do not need decompression, you need stabilization. There is no need for realignment, stabilization. For this group, we said, yes, there is a need for foramen magnum decompression. This is what we said. So this basilar invagination, open the joint, manipulate the facet, and you all know what the whole world is doing today. No transoral decompression. So basilar invagination, look with a different eye of unstable situation and treat with a different vision of stabilization. Both Group A and Group B. Now we turn the corner. I said for Group B, we do foramen magnum decompression. But as we evolve further in the business, both Group A and Group B need atlantoaxial fixation. In 1999, 27 years ago, I published this article that basilar invagination is nothing but lumbosacral listhesis, C1 over C2 listhesis. Like this, there is basilar invagination, tonsillar herniation, syringomyelia. Listhesis is the issue. Instability is the problem. 1999. Stabilization is the treatment. There is no need for decompression, okay? As we evolve further, 20 years ago, we published this most futuristic concept of 3 types of atlantoaxial instability. One is C1 over C2. This listhesis, compression, listhesis problem, stabilization. This kind of basilar invagination, the whole world today will do foramen magnum decompression. But we introduced this retrolisthesis. Look at the facet and lateral profile imaging. You will see this kind of dislocation. You have to stabilize. No atlantodental interval disturbance, no facetal malalignment, presence of assimilation of atlas, presence of platybasia, presence of Chiari, presence of syringomyelia. They are all secondary. They are all naturally protective or adaptive. They are potentially or manifestly reversible following atlantoaxial fixation. Huge concept, believe me, huge and mega concept, and a future of craniovertebral junction surgery. So 3 types of dislocation. One is this, second is this, and third is even when there is no facetal malalignment. Now this slide is a power slide. In my view, a power slide. Now chronic atlantoaxial instability is the father. And all these things are children, like Chiari, syringomyelia, external basilar invagination, C2-3 fusion, os odontoideum, bifid, kyphoscoliosis, C2-3 fusion. All these things that you are seeing, and many more, are currently by the world of spine surgery considered to be pathology. And the treatment for the world of spine today for all the pathologies is one, and that is decompression. I am saying a different version. Chronic atlantoaxial instability is the father. All these things like Chiari and syringomyelia and basilar invagination, when they are present together, like basilar and syringomyelia and Chiari, then they are present together. Or discretely, like you see only C2-3 fusion, only bifid, only os odontoideum, nothing else in the spine. They are the children of this father. You treat the father and children will be all right. Believe me, a concept for you to think about and for concept for the whole world for the future of craniovertebral junction. So essentially, basilar invagination is one of the child, syringomyelia is one of the children, Chiari is one of the children, and all these are related to atlantoaxial instability. This article I had written in 2013. Many of you have heard about it, many of you have thought about it, and most of you have thrown it in the garbage. You know, it is time for you to think. I'm not saying take it. I'm not saying take it. Think about it. I'm saying think about it. I'm talking from my experience of more than 20 years, and I am giving you a version with this kind of force. Atlantoaxial instability is the cause of Chiari malformation. Atlantoaxial stabilization is the treatment. Now I am talking on the basis of experience of more than 600 cases from all over the world. So this is the tonsillar herniation. See, look at the facet. Don't do any kind of decompression, stabilize. Little bit unstable here, no problem here, no compression here. Do C1, C2, see the magic. See a magic that you have never seen with Chiari malformation. You have never seen. Syringomyelia will reduce, I will not say 100%, but at least 95% of cases to be on the conservative side. Syringomyelia reduces or not reduces is not the issue. Issue is the patient will 100% of times improve in the evening of operation like a magic. You have never seen this before, never. Enjoy this magic. If you wish to really do C1, C2 fixation in Chiari, there is no other treatment in my view. If you do a scan after 4 days or 5 days after surgery, the syringe you will find reduction in several cases. After 2 or 3 months, in 100% of cases, syringe reduction. So this was my article, which you have not read. If it was written by some sophisticated name, you must have definitely read. But this is written by somebody from a corner of India. No need to read all this. But this is a beautiful article, highly cited. This is the most highly cited article on Chiari in the last 10 years. Look at the literature. Chiari malformation observation on 388 cases treated by only atlantoaxial fixation. Chiari malformation is secondary, it is protective, it is potentially adaptive, it is potentially or manifestly reversible. So I had introduced this term, nature's airbag for Chiari, and this is the paper. Another thing I am repeating, every sentence that I am talking is published in high-profile journals, okay? Syringomyelia, I published this article in 1996. Syringomyelia is secondary. It is a consequence of chronic instability, and it is potentially reversible. Idiopathic syringe, I said that if os odontoideum is alone, nothing else. If Chiari is alone, nothing else. If syringomyelia is alone and nothing less, we call it idiopathic syringe. Nobody in the world knows what is the treatment of idiopathic syringe. Have you heard? Have you seen anybody talking about idiopathic syringe? Only one treatment, that put a tube and shunt in this. There is no other treatment. That treatment is a negative treatment. That treatment is based on misunderstanding about the powers of nature, about the powers of divine entity called nature. Short neck, torticollis, musculoskeletal abnormality. This is a paper published in 2009 in Journal of Neurosurgery. When you see short neck and torticollis, don't look here and there. This is C1, C2 problem. Even if there is no radiological manifestation of compression or instability, or you can give a long neck and you can give a beautiful broad smile in the evening of operation. This is just neck, but hands, fingers, legs, you give a new human body. And you can make kings and make them sit on a throne, and you can give this smile that you have never imagined if you do any kind of decompression. Klippel file abnormality, C2-3 fusion, assimilation of atlas are all children of one father, and that father is atlantoaxial instability. If you see assimilation of atlas, nothing else, do C1, C2 fixation. If you see multisegmental Klippel file abnormality, nothing else, do C1, C2. You see, I don't have time to show you hundreds of pictures. If you have only C2-3 fusion, what you will do? Don't do one thing, and that is decompression, because that is negative form of treatment. Here you don't see any compression, but there is Klippel file. You do C1, C2. This is a high profile, this medial person, daughter of a media person who made me quite famous at that time. She was hardly able to breathe, and nobody had suggested any kind of treatment for her. I did C1, C2 fixation. I am not sure if you can see a powerful person here, but she became a normal, beautiful human being. Bifid is secondary, bifid is compensatory, bifid is adaptive, bifid is the child of atlantoaxial. Os odontoideum, I published this series long time ago, is a child of atlantoaxial. It is a protective phenomena. It is natural. Like syringe is a natural self-neural destruction. Os odontoideum is a natural self-odontoid resection in the presence of chronic atlantoaxial instability. And there are various things in this slide which I don't have time to talk about too much. This kind of... Now I ask you one question. All of you are experts. All of you are fantastically, as I said, evolved or evolving or in line to be evolved. What you will do for this case? There is no compression here. There is severe compression here. There is C234 fusion here. What you will do? Whatever you do, but the whole world will do only one thing, and that is multi-segmental anterior decompression. I am saying that is an absolutely negative form of treatment. No compression, but this patient has this kind of fusion. This patient needs C1, C2 fixation, and magic will be the outcome. So when you see clipal file, when you see bifid, when you see little bit syringomyelia, you have to think about atlantoaxial instability. This kind of kyphoscoliosis, many a times, believe me, many a times, there is an entity called idiopathic kyphoscoliosis. You must have heard this. For idiopathic kyphoscoliosis means there is something as wrong as going to happen here and there. Idiopathic kyphoscoliosis many a time. I'm not saying all the time. Don't misunderstand me, okay? And if there is any confusion in my communication, you have papers to bank upon. You go and look at those papers. Many of these kyphoscoliosis are secondary to central atlantoaxial instability. You stabilize and you see this magic of the spine has completely changed very soon after surgery. And I have got hundreds of patients now. I have no hesitation to say, I demolished transoral surgery from the books of spine surgery. I have no hesitation. Somebody can argue here and there. I have no hesitation to say that I am in the process of demolishing foramen magnum decompression from the books of neurosurgery or spine surgery. So this is my chapter number 1. Ashish, where are you? I have another chapter to complete. Maybe after 1 or 2 lectures, I want to complete my another lecture on degeneration of spine. Can I continue? Where is Ashish gone? कहाँ करूँ कि रुकूँ कि क्या करूँ? Chairperson, can I continue or should you want a little bit breathing space, you know, little bit heavy? Okay, now relax. I have given he has given me the permission, enjoy. Just wait. Anterior cervical decompression. Patty, just enjoy. Anterior cervical discectomy, corpectomy. I was the first one in the literature who introduced oblique corpectomy. I was the first one in the literature who introduced tricortical screws. I was the first one in the literature to introduce transdiscal screws. So I was good in anterior surgery and anterior decompression. And I have written several chapters for various books and all. And this is Sweet and Smidek book, this chapter. So this kind of discectomy and this kind of instrumentation were very commonplace in my department. Degenerative craniovertebral junction. Nobody in the world, show me the literature on degeneration of craniovertebral junction, any mention, show me. I am saying craniovertebral junction is the most mobile segment of the body. Craniovertebral degeneration is the most common degeneration, neglected degeneration. And this was my article published in 2010 where I relate instability to degeneration. You see this instability to degeneration in 2010. Now, my dear young friends, carefully look at this slide. And I want, I don't want anybody to look at the phones. I see one young boy looking at the phone, okay? You look here. You're seeing my finger? Please look here. Reduction in the joint space. You see reduction in the joint space? Buckling of this ligament. Osteophyte formation. They are not primary events. They are secondary to vertical or central instability. Osteophyte formation here, osteophyte formation here, osteophyte formation here. Compression, so-called compression, is not a primary phenomenon. It is secondary, it is potentially protective, and it is reversible after stabilization. Retroodontoid pseudotumor. I don't know how many of you have seen this or heard this, but I have to tell you, the whole world was doing transoral surgery, whole world. And many of them, you know, when skull-base surgery progressed, started doing lateral approaches for this. Many papers. For the first time in literature, we said that this is an osteophyte of C1, C2 area. And this article, that this does not need decompression, it needs C1, C2 stabilization. And this was the first article on the subject in 2004. And now you must be very happy to hear many people, there are several other articles now in the world who say, yes, for this entity we do C1, C2 fixation, many articles. Retroodontoid cyst, very easy to remove, very easy, just puncture it. But in the presence of instability, you stabilize, it disappears. This is secondary, this is like a buffer or protection. It disappears after stabilization. So there are all these kind of retroodontoids, and this was my article. I wish that you please read this, where we discussed about C2 body and pannus and all those things, and we said that this is an evidence of instability. Another thing I want to tell you, rheumatoid arthritis. Do you know what rheumatoid arthritis and pannus, how they were treated? How Alan Crockett, my very good, you know, I will say my very good friend or very good senior or very respected in the world of transoral surgery, what he was doing. His one single operation was to remove this pannus. And then somebody introduced, no, we should also add occipitocervical fixation. And Ransford had come in picture and started doing some occipitocervical. It was called Ransford's loop. For the first time we said that this is pannus is secondary to vertical instability. You stabilize, pannus disappears, and it was published in Journal of Neurosurgery Spine, immediate postoperative regression of pannus. And now we have published on several occasions about what happens. So C1, C2 is basilar invagination. Nobody in the world of spine has ever talked about facetal instability in degenerative spine. Have you heard of this? You talk of body, disc degeneration, disc space reduction. Nobody has talked about facetal instability. If the muscles have to become weak, the first thing that will happen is facetal instability. Now I want you to carefully look at the slide. Okay, I don't want anybody looking at the phone, and I am watching, and that one boy in my finger, just piche kaun hai wo? He's talking to whom? This boy. Either you go out or you look here. This is my instruction to you. Either I'm not forcing you to look here or look there. You go out, but don't disturb the other fellow, okay? Please. Because I'm talking of very important, very interesting, and probably a futuristic view on this slide. Look at this slide. Reduction in the disc space. You know, the whole world of spine was saying that disc degeneration, disc water reduction, you'd see any article on degenerative spine, the first sentence will be reduction in the disc space, reduction in the water content is the cause of degeneration. So reduction in the interbody space, bulging of this disc, bulging of this multiple disc, osteophyte formation is not a primary phenomenon. It is secondary, it is naturally adaptive or protective, it is potentially or manifestly reversible after stabilization. More important is they indicate the unstable segment. You stabilize patient remarkably. I call it magic recovery. Question is only one. Which segments are unstable? Radiological, they indicate unstable, but there are other clinical parameters, other intraoperative parameters that indicate. So about 20 years ago, we introduced this intrafacetal spacers. And this concept, you see here, facial distraction spacers for treatment of degenerative spine, rational and an alternative hypothesis of spinal degeneration, 2010. During that time, we did several cases, this kind of buckling of the ligamentum flavum, bulging of this disc, immediate post-op introduction of these multi-space, and you see this. And this article, I'm not just saying like that, published as a cover page of Journal of Neurosurgery, cover page. This is Journal of Neurosurgery spine cover page. And see the title, Facetal Distraction as Treatment for Single and Multi-Level Cervical Spondylotic Radiculopathy and Myelopathy. Radiculopathy and myelopathy. Same concept we talked about lumbar canal stenosis. We introduced this intra-articular spacers, and this is the article published in Journal of Neurosurgery Spine about the treatment without any decompression. So decompression has been the format or the basis of treatment of spinal disease. In 2013, another dynamic concept we introduced. I call it dynamic, you may call it dynamo in the current concept of these kind of wars which are going on. Dynamo. Only fixation even without indirect decompression. When you put facetal spacer, you indirectly decompress. And about a few years ago, 6 years ago, we introduced this paper. Just read the title. Read the title. Muscle weak, and this is in World Neurosurgery, muscle weakness related spinal instability is the cause of cervical spinal degeneration, and spinal stabilization is the treatment. Can you see this? Is there any mention about decompression or any discectomy or any foraminotomy or any kind of nothing? So this is the article. Now look at this slide, multi-level degeneration. You know what the whole world will do, but here only fixation is done, and after 18 months the whole thing has gone. And I have got several patients. You see multi-level ligamentum flavum and things like that. You do fixation. I do Camel's technique, transarticular fixation. I do 5-level fixation in 10 minutes. Simple, safe, strongest facets are the strongest part of the vertebra, and absolutely beautiful. So degenerative cervical myelopathy, we should look in a different perspective, not in the perspective of compression and not in the view of decompression. Instability is the cause and stabilization is the treatment. You will ask me one question. What is the main issue in cervical or lumbar degeneration? This is the question. I am saying to identify which levels are unstable. Is only C2-3 unstable, or C5-6 is unstable, or is atlantoaxial instability is also there? This is the crux of the entire problem. Now you look here, there is 2-level compression. I have done 4 or 5-level fixation here. This is after a few months of surgery. You have to only believe me, dramatic recovery in clinical. But why I have done 5-level or 4-level in 2-level compression? Similarly here there is 3-level compression, and I have done some 5 or 6-level. This is the crux, this is the basis of your understanding of spinal degeneration. And look at the spine. You see this is pre-op and this is post-op. Another issue which has never been discussed in spine. Have you ever heard somebody talking of spinal degeneration and atlantoaxial instability? Have you ever heard? You have not heard. And if you say I have heard, you are lying, because it is never published in the literature. Now you hear what I am saying. Atlantoaxial instability is a very frequent association of multi-segmental spinal degeneration. If you do not include atlantoaxial instability in your thinking process, you are not treating multi-segmental degeneration properly. Now this is the patient, you see multi-segmental coming on a wheel, on a trolley, not on a wheelchair, trolley. In this patient, atlantoaxial stabilization is mandatory, and magic is the clinical result. So this article of mine patients coming with severe myelopathy on a wheelchair, on a trolley, many of these or most of this atlantoaxial instability is always associated, and you have to do C1, C2 fixation in your fixation construct, not in your decompression construct. Lumbar canal stenosis, very common. All of us are doing, and all of us are very happy with what we are doing. The whole world is happy with what they are doing, and they must continue with what makes them happy. I am giving you another concept. I am saying lumbar canal, and this is published in Neurosurgical Focus, lumbar canal stenosis, analyzing the role of stabilization and futility of decompression. See what a power statement. This kind of lumbar canal stenosis, currently the whole world is doing decompression, and that is the gold standard treatment for decompression. I am saying it is a secondary process to when the old man becomes weak in his muscles. He can walk for a few meters, but then his muscles don't take and he gets claudication pain. Muscle weakness is the issue. Multisegmental facetal instability is the result. Lumbar canal stenosis is a radiological manifestation. Stabilization is the treatment. And I do this. Question is, the whole world of spine is focused on removal of osteophytes. Whole world. Some people do laminoplasty and laminectomy to make space for the osteophytes. Is it necessary? I am saying it is not only not necessary, it is counter-effective. And this is my article. Try, if possible, go home and read it. Beautiful, futuristic article. What happens to osteophytes when you do only fixation? You read this and see some of these. You see, these are the osteophytes. I have done only fixation. The osteophytes have disappeared. Kyphosis. You know what is the current treatment for kyphosis? Osteokyphectomy or osteotomies. This is the treatment, or decompression. I am saying kyphosis is an outcome of an unstable spine. Identify the unstable spine segments and stabilize. That is the treatment. Now here, this one, I have done only C1, C2. Here I have included the C1, C2 and subaxial fixation. Why I have done this and why I have not done, this is studied in this article. You will have opportunity. Like I was discussing with Dr. Patkar about if there is a disc herniation, what you do? First treatment. And he said that I like to give 6 weeks of collar and complete bed rest and wait and watch. But the problem is our belts are not strong enough, our collars are not strong enough. As soon as he turns, he has a pain. My concept is clear. Herniation of a disc is a manifestation of an unstable spinal segment. You stabilize by either by collar, for good collar or a good belt, or do segmental stabilization, that disc will disappear. And this ACDF, the whole world is doing ACDF. I was also doing a lot of this ACDF. You identify, I have done 2 level for 1 level. Why the hell I have done 2 level for 1 level? That is the issue. You stabilize, this will disappear. It is like giving a collar and giving bed rest, it disappears. And this article is published in World Neurosurgery, Facetal Fixation Arthrodesis as Treatment of Cervical Radiculopathy. Same is lumbar radiculopathy, like you identify the unstable. Believe me, my dear friends, if I have to talk, I am so passionate about this subject because I have a feeling that what I am saying is the future. And I have several things to talk about, but of course I cannot go on for the whole because Ashish will say, enough of you, my dear friend. Ossification of posterior longitudinal ligament. You ask me one question, which is the most dangerous issue in spine surgery? You ask me one question, you ask any spine surgeon, which kind of thing you will not like to touch? The answer will be OPLL. If somebody of you has done more than 10 OPLL, I am guaranteeing out of your 10, at least 1 patient would have developed quadriplegia. If you are saying no, you are saying lie. If you are saying no, you have not done 10. OPLL is a manifestation of an unstable spine. This was my first article, only stabilization the treatment, and this was my subsequent article some 8 or 9 years ago. Now my experience is more than 150 cases. Somebody tries to argue, no, I don't believe you. No, you're saying nonsense. Go to damn any place you want. OPLL is a manifestation of an unstable spine. Most important issue is identify the unstable segment and stabilize those segments, and that is the treatment. So this kind of OPLL, you know, the world does not want to go so high and so. Another thing I'll tell you, you show me one article, or I will give you one article. The person who has done the maximum anterior cervical surgery in the world, you read this paper, more than 30% major complication after 3-level corpectomy. If you do 3-level corpectomy, he is saying 30% complication. And I have told you, I describe oblique corpectomy for OPLL first time in the literature. But today I am saying, you identify the unstable segments, include atlantoaxial stabilization in your fixation construct. This is OPLL, C1, C2 fixation. Now I have changed my style of C1, C2 fixation in this, which you will have to read what I do now. I don't include C1 in the fixation, only transarticular screws, and I can only tell you, my dear friends, my dear young and evolving and evolved friends, think about it. Take it or throw it. Nobody is forcing you to do, no, I will not. Nobody is saying. But at least my plea is that you think about it. My concept is clear. My concept is definite, that atlantoaxial and subaxial cervical spine fixation can revolutionize the treatment of OPLL. No question about it. Can decompress, like I threw transoral surgery. I'm going to demolish foramen magnum decompression. I am promising you. See after 10 years. Decompression, laminectomy will be in the history books. Can decompressive anterior surgery? Probably in the history books. But this commercial world will not let it go in history. Can decompressive laminectomy and degenerative become historical? My answer is clear. So my concept, my dear young friends, compression is never the issue. Decompression is never the treatment in spine. Thank you very much.
Thank you, Dr. Goel.
I know there will be several questions, but you know, many of you will be a little bit scared to ask. Many of you will not ask because there is a populism in this. Because if you ask, the other fellow will say, what nonsense. There may be politics in this. You know, I have run politics many times in my life. I have been candidate recently for World Federation President. There I used to give political lectures. But now, today, I'm not giving you a political lecture. This is pure and 100% academic. Think about it, okay?
Thank you, Dr. Goel. I think it was a very nice presentation, and everybody is hypnotized by your communication. Thank you very much.
So after this enlightening session, I would like to request the chairpersons to facilitate Dr. Atul Goel sir and Dr. Parthiban sir. Please, sir. So Dr. Parthiban, sir, please. Thank you, respected chairpersons. For the next session, I would like to call upon the stage Dr. S.N. Maderia, sir, and Dr. Rakesh Luhana, sir. Sir, please.
I request Patka sir to speak on unstable reducible odontoid fracture, surgical treatment.
उसको कनेक्ट कर दो. So, you must have now been fascinated by what Professor Goel said. I've always attempted to improve on whatever he does, Literature is written and rewritten only to be thrown in the dustbin and for new literature to come. Dr. Goel himself has thrown his old literature in the dustbin and come out with new literature. So all those patients who are operated by what he said before, they're going to sue him. Because he had proposed foramen magnum decompression for type 2 and transoral for type 1. So many patients underwent that operation because of his article. And now he says, don't do that. So literature is written and rewritten only to be thrown in the dustbin and for new literature to come. Anyway, so I am going to talk about unstable odontoid fractures, the anterior approach, technique, pitfalls and solutions. Again, no disclosures, no monetary considerations from anybody except gratitude. I feel that odontoid fracture is a type of craniovertebral anomaly, and these classifications in the past by D'Alonzo, type 1, type 2, type 3, these are completely incomplete and redundant in the present times because patients don't read textbooks and odontoid fractures can be associated with hangman's fracture, they can be associated with other ligamentous injuries. The type of fracture can be different in various patients. So when you want to treat odontoid fractures, you must analyze many things apart from just D'Alonzo's classification of odontoid fracture. What are the risk factors associated with high degree of neurosurgical failure in treatment of odontoid fracture? Age, osteoporosis, etc., displacement. Everybody knows that type 2 fractures have to be operated. Type 1 and type 3 are not operated. But why are we operating type 2 fractures? We are operating type 2 fractures because eventually those fractures undergo avascular necrosis. We were told our patients develop irreversible instability, therefore type 2 must be operated. Now, whether these statements have any truth, in reality, I don't think that is correct. If you will see that the whole treatment of odontoid fractures has been focused on the cruciate ligament, but the displacement you will see in fractures, always the odontoid remains attached to the anterior arch of the atlas. So actually it is the vertebral component which gets disrupted. It is not the horizontal component, and everybody has been blaming the cruciate ligament. The odontoid fracture always remains with the anterior arch of the atlas. And this concept was something which I proposed in Journal of Neurosurgery a couple of years ago. So type 1 fractures, everybody knows, need not be treated. Type 2 fracture, everybody knows, can be treated with surgery, can be treated conservatively. Still, there is no consensus in the world. Type 3, there is no option but to treat them surgically. These are the unstable, irreducible fractures. They are displaced, they are not getting reduced. These are the ones which there is no question about doing surgery. So this is the new classification which I proposed. And this is type 4, where odontoid fracture is associated with other things like hangman's fractures, with fracture, Jefferson's fractures, with a comminuted odontoid fracture. So when you are studying, you ask yourself, is this type 1, is this type 2, is this type 3, is this type 4? Type 3 and type 4, no question. And Journal of Neurosurgery I have published. Unstable odontoid fractures are those which on weight bearing result in spinal cord compression because of atlantoaxial dislocation or the displaced fracture fragment. Now this definition has been quoted by almost every subsequent paper, but what is the meaning of an unstable odontoid fracture? If you will go to the literature, most irreducible odontoid fractures were being treated by irreducible AD underwent transoral odontoid decompression because they were not able to reduce those fractures. Again, from India, direct posterior reduction. This treatment came in British Journal of Neurosurgery in 2015. So you will understand why these people were treating these fractures and focusing, because they knew that this is what is to happen eventually. So there is a consensus in treatment of odontoid fractures that you must do an anterior odontoid screw, but there has been no randomized controlled trial. And if you will see the literature, over a period of time, you will see most of the people have been talking about odontoid screws. I was the first to publish in 2013 from Japan on anterior extrapharyngeal approach for fixation of the atlantoaxial joints bilaterally from one side. You can fix both the joints from one side anteriorly. And that paper carried this. The unilateral approach to fix plates on both sides was described by me in 2013, which was not described anywhere in literature before. Then subsequently I published in other papers, other journals. See the outcomes of patients who underwent, when you review the work through which about odontoid fracture, lot remains to be still desired from in treatment of odontoid fractures. Odontoid is not a standard bone. Over a period of time, the odontoid also changes. There's when you see a odontoid in a 60-year-old person and odontoid in a young person, they are different. If odontoid gets fractured in a young person, believe you me, it is a very high impact trauma. Whereas odontoid fracture in an elderly person is a different kind of injury. That is a very soft bone and just a small fall and then the patient will get a fracture. So treatment of odontoid fractures in young and in the old are completely different. Odontoid fracture is a not weight-bearing bone. So when there is a non-weight-bearing bone, the treatment is not external plate. You have to see the difference. Humerus can be needs a plate and screw, whereas a femur can be treated by passing intramedullary because it is a weight-bearing bone. Odontoid is not a weight-bearing bone, and therefore odontoid screw is a wrong construct for odontoid fractures. And this, of course, there are many other shortcomings of odontoid screws. I will not waste time. It has to go perfectly across the fracture. It has to be perpendicular. It should cross the distal cortex. There should be adequate amount of bone in front of the too many requirements. If you don't pass the screw correctly, this is what will happen. And you will see literature is studied with examples. Most of the neurosurgeons don't cross the distal cortex. They feel they have gone through the odontoid fracture. That is not correct. If you want to use screw for treatment, you have to cross the distal cortex. So there are many kind of literature studied with this, and of course my friend Atul described the technique of posterior fixation, and then Harms tried to push his name inside. But all said and done, posterior surgery has its own limitations. Way back I had shown that in odontoid fractures, the treatment of any fracture is what? Realignment and fixation in compression mode. That is a basic treatment from Adams' textbook of orthopedics in second MBBS. So this was the treatment, where I did the anterior plate compressing the fracture component. This is an unstable fracture, and you can see over a period of time how the fracture has healed. So new concept, direct open reduction compression of fracture with VSP plating under compression and bilateral anterior transarterial. So you treat the fracture and treat the instability in the same operation. There is no need to turn. Now there is an anteriorly oblique fracture. People used to do a screw, then turn the patient and do another operation from behind. See, these are examples, and you can see over a period of time the fracture is healed because this treatment follows the principles of orthopedics, that the fracture has to be realigned, fixed in compression mode. So these are examples. You can see this. And along with it, the joint has to fuse. So any fracture can be manipulated if you know how to manipulate the joints. And the easiest way to manipulate the joints is from the front. There is no muscle dissection required. It is an anterior cervical fusion. You have done so many and you just go up a little bit. The problem has been that we inherited spinal surgery from orthopedic surgeons and kept on following what they are doing. They were doing, Smith, Robinson, Cloward were orthopedic surgeons. They did anterior cervical spinal surgery, we followed them. The posterior C1, C2 surgery was done by Galli, Alexander, the orthopedic surgeons. And they said that C1, C2 should be fixed from behind. Everybody started following them. Follow the Pied Piper. When you are doing posterior C1, C2 surgery, you are disrupting the entire muscle complex. When you are operating from the front, you just divide a little bit of the longus colli. So these are Geon made. This is a VSP plate where you put the screw. As you tighten the screw, there is a compression in the fracture. So these were made by Geon for me, and you can see this is a displaced fracture. You can realign it. And this is how it is fixed in compression mode. And plus the advantage was you can reposition the fracture and pull it into position. So this was the concept, the VSP concept, new treatment for unstable odontoid fractures. Anterior oblique fracture, you cannot treat with odontoid screw. So you fix it to the plane. As you tighten this, it goes into compression mode. The VSP concept for treatment of odontoid fractures. So you tighten and then you go very close to the edge. And when you tighten, this is the principle of orthopedics called variable screw placement. Now this kind of displaced impacted fracture, there was no treatment except going on odontoid, removing the odontoid or accepting the deformity and fixing in the deformed position. So here you can pass a tap, get it back into position and put a VSP plate and then continue with fixation of the atlantoaxial joints by passing anterior transarticular screws. This is there in all my, if you go to General Neurosurgery, focus on all, I have published many times about how to do this operation of anterior screws. So these are some examples. You can see a displaced fracture. This is so simple, you know. This does not require any complex instrumentation, no navigation. There is no talk about vertebral artery. There is no talk about venous plexus bleeding. After you expose, you cut the I'm repositioning the fracture by simple pressure. Fracture which is not reducing with traction, the moment you cut the longus colli muscle, it comes back into position. You can even put a tap and use it to manipulate the fracture. So once you have tapped and you put the plates and screws on either side, you can put in the midline plate. This is a VSP plate I put, and now I'll pass transarticular screws on both sides. So you see, this is like an anterior cervical fusion. People study the CT angiogram and the MR angiogram and where is the high riding vertebral artery and where is the vertebral artery and how much bleeding is going to take place. Nothing. This is nonsense. If anybody tells you operation is difficult, that person still has to progress or the science has to progress. You know, the instrument sets for C1, C2 they come with 2-3 dabbas and there is so many instruments. There's one instrument to open the box and one to close the box also. This does not require any instruments. You must put adequate amount of bone in the joints and see on table you can check for whether you have done a correct operation or no. Unlike the prone position, in the supine position, the natural person's position is like that. It doesn't look like this. So you can check on table what is happening and whether you have done a good operation. See this kind of patient. Realign it, fix it with transarticular screws. This is another patient. You can realign. The end point must be that the fracture should have healed. You must have a fracture, the odontoid which has reformed. That should be the treatment. This is another example. This was the construct which was described by me, anterior plate and bilateral transarticular screws, treating the fracture and the instability in the same operation. Another case, and another case, and you can see the fusion across the joints. Joint fusion in the unstable odontoid fracture is part of the treatment. You should not fall short on that. Now this is the case of lock. This picture, you see this is a locked facet. This is, you can read, no traction is going to reduce this. You go inside, cut the longus colli muscle, tap the distal fragment, bring it into alignment and pass the bilateral anterior transarticular screws. So this is what was done for the patient. The facet has been realigned and the fracture goes on to fusion. Another case, you can see the hangman's fracture associated with this. Unclassified odontoid. That is odontoid fracture along with hangman's fracture. And this has been done. On one side I put a plate, on one side a screw, and I have treated the hangman's fracture by anterior fixation of the joint. And you can see this all through a small linear incision without, the moment you go, it's like you are onto the anterior surface of the spine, no cutting of muscles, working through muscle planes. It's not working anyway. This is another type, Jefferson's fracture along with odontoid fracture. So I've fixed the odontoid fracture and the Jefferson's fracture with the anterior plate. So anyway, the point I want to make is that the end point should be the fracture treatment. So these are old slides. So direct compression treatment and reduction with fixation has got published at various places. Then complications. If anybody says that he doesn't have complications, he is lying or he has not operated enough or is hiding. Great surgeons are made with bigger complications and not getting sued. If you get sued, you're finished. But if you escape being sued, then you become a very prominent person. So best is learn from your complications, learn from the complications of others. So these are the kind of complications I've had where the screw has gone into the spinal canal. There is no navigation still for anterior spinal C1, C2. There is no navigation gadget. So your navigation has to come from your brain. You cannot, nobody has made the machine for putting anterior transarticular screws under navigation. So you see this kind of certain anatomical problems when the facet, there is no adequate amount of ledge of the C2 to pass the screw. So you end up in these kind of things. On this patient I had passed and distracted the odontoid, one screw had come out. Now here I had over distracted. I had not waited for the drill to go into the lateral muscle of C1 and that ended up in the patient getting up with a cock robin deformity and I had to reposition it. So this is to happen because my screwdriver is to wobble. So then these people made a special screwdriver for me where the screw can be locked into the screwdriver. When you do C1, C2 screw, sometimes the screw wobbles, then the nurse will put some bone wax and it's all rubbish. So this is a screwdriver which Jayon has made for me. You can ask for it. I have absolutely no financial interactions with the company. They just make what I want and they sell and they make their money. So then I went on back to the drawing board and I found that there was adequate bone in the lateral mass of the atlas in the body. This is why am I wasting time passing anterior screws. So this new plate, Patkar plate was made for me. Again, this was Jayon who helped me. The average angle was 45 because it's a square block of bone. The angle is 45 degrees from behind front. You start at the anterior inferior edge of the atlas and it is on laterally it is 35 degrees. So this implant was made for me by Jayon. After trying various kinds of implants, and you can see this plate which has been made by Jayon. This is even certified for European use and some people have purchased it, I don't know. So you can see these examples of this, pre-op, post-op. The lower screw has to be bicortical. When you want to do a good fixation, use a bicortical screw. Don't remember this basic principle of orthopedics. We must learn from orthopedic surgeons. So this is another example you can see. Hangman's fracture along with odontoid fracture treated with the anterior plate and screws. Another example. And again the anterior surgery gives you the advantage of going and drilling the end plates very well. You can put the micro drill inside without any fear. When you're doing from behind, there is vertebral artery on one side, the spinal cord on one side. So it destroys and demystifies atlantoaxial fixation. If you start doing anterior C1, C2 surgery, your fear of anterior surgery will go away, it will disappear. So this was the concept which I mark with a micro drill I make where I want to make the entries. And the cervical screw is always just above the end plate. I make the entry points for a few millimeters and then with the tap I keep it ready so that few threads so that a screw will engage. And then the plate is brought onto the place and it is, So this, after I've debrided the joints, I put bone grafts, I make the drill holes after having marked them with a marker pen, a few twists with the tap, like I said. Don't over tap. Always tap very, very minimally, which has, helped me. In the previously, I used to, tap completely and then end up with a looser implant. The first screw that you pass, the first attempt, that is the best attempt. After that, it is all rubbish, And this is the plate. Very simple, like an anterior cervical fusion. So biomechanical, where is the force nucleus of that vertebra? Where is the line of weight transmission? What is the quality of bone, and whether the technique can be done by the last fellow sitting in the last row? That should be the focus. The weight transmission is from the lateral mass, from the condyle to the lateral mass to the facet. So your fixation must involve these things. And the closer the implant is to the bone, more rigid is the fixation. All these concepts were published in Journal of Neurosurgery. Fracture realignment fusion is the correct point. Again, this technique of plate was published for basilar invagination. I had published this technique in Journal of Orthopedics. You can go to Journal of Neurosurgery. You can find the videos. I've been traveling around the world trying to spread my technique. This was in Indonesia, with Nepal, Bangladesh. Of course, there are many people who have started doing this. This was in Aberdeen. I had been to do a workshop, and they gave me some certificate of presentation by the Society of British Neurosurgeons. They were impressed with my work. And those youngsters, you can read the entire work in Ramamurthy Tandon's textbook of neurosurgery. There's a big chapter. So friends, the task is not so much as to see what no one else has seen, but to think what nobody has not thought about what everybody has seen. That is the purpose of neurosurgery. Thank you, my dear friends.
Excellent talk, Professor Patkar. So we move on to a next talk by Dr. Umesh Srikanta on minimally invasive thoracic corpectomy. Umesh.
Well, good afternoon, respected chairperson, senior colleague, dear friends. Well, it's very difficult to follow two charismatic speakers, and I'll try to do my best. So my topic is MIS thoracic corpectomy, and so this is a surgical video talk. It is not. I'm not going to talk about the indications. I'm not going to talk about the the case details. Not going to show too many examples. So ultimately, basically, when we were doing MIS or open thoracic corpectomy, it's fraught with several challenges. You have to get a lateral entry point in order to do that extracavitary approach. You have to resect the rib and then go all the way to that lateral to medial angle, and that requires quite a significant amount of muscle dissection, and it is extensive muscle dissection will be required, higher blood loss. There is a, and you open up wide on the at the level of the skin, and then when you go into the level of the pedicle and the lateral part of the vertebral body, your vision is still restricted, and you're just, sorry? Okay. Sorry. So that is why when we move on to a minimally invasive corpectomy, so it's basically a muscle sparing approach. You minimize the blood loss, minimize post-operative pain, lesser morbidity post-operatively, and so these are the advantages that we get with MIS corpectomy. So how do we do it? So this is a quite old technique and an old video. So this is done with 2D fluoro navigation. Of course, nowadays it can be done much more easily, much more confidently with much more confidently with the help of a navigation and other stuff. So basically, when we have to understand how to approach an MIS thoracic corpectomy, so we need to understand that this is just an extension of an MIS T-lift. So if you see in MIS T-lift, what we do, you just remove one facet and approach the disc. Whereas in for a corpectomy, you need to remove the two adjacent facets so that you get an unrestricted access to transpedicular route through the vertebral body, and with the same angle you can actually resect the vertebral body. So this is the basic concept. The second point is the difference between lumbar and thoracic. In lumbar, you have a chance to retract the dura and the neural elements so that your angle can be in the same angle as that, or that you use for putting in a pedicle screw. Whereas for a thoracic, you need to go much more lateral. You can't retract the spinal cord. So that's why you need to go much more lateral, and then the incision will be much further away from the midline as compared to a lumbar area. Now, the second thing is to consider the anatomy. So, in order to go that much lateral, your transverse process and your rib are in the way. And that is why the first docking is almost vertical down. You are not trying to look into the canal or towards the vertebral body. You try to look all the way down and resect that transverse process as well as the rib, so that you get a access to the lateral part of the vertebral body. You dock in the tube much more deeper down, and then you will be able to visualize the lateral part of the vertebral body and resect and do a corpectomy in that way. So this is basically the first dilatation, the first docking on the transverse process, and then you expand. You use an expandable retractor for a corpectomy. So in these cases, so this is the video, and as you can see there, we are able to visualize that is the transverse process. You identify the superior inferior edge of the transverse process, dissect it out, and just make a vertical cut on the junction of the transverse process and the lateral part of the facet, and that kind of disengages the transverse process. And once that is done, so you can have access to the rib joint. So this is the vertical cut that has been made. You can use an osteotome, you can use a drill to make this cut. It's also important to consider that these ligaments, that is the superior costotransverse as well as the lateral costotransverse ligaments, are quite strong in this area, and it is necessary to disengage them before you can remove the transverse process, and it can be also used as a graft if it is not involved in the pathology. So that is the posterior surface of the rib, and once that is done, you can dissect the rib all the way to the lateral border of the vertebral body. You identify the superior and inferior, dissect the rib from the underlying pleura, that is the lateral part of the pleura, and then you can actually make a cut at least 5 centimeters away from the rib head. So that is why you get enough, so that you get enough space to dock in your tube deeper down on the lateral part of the vertebral body. And here again, it is difficult to use a rib cutter that we normally do in open cases, because the space available is very small. So you can actually use a drill, or a osteotome is slightly more difficult because this is very mobile. So the drill is what I feel is the best instrument, or you can use an upcut. And if any part of the rib head is actually left behind in the deeper portion, that again can be disengaged from the lateral border of the vertebral body and can be removed. So after this, you just pack the pleura laterally, and then your tube is ready to go in deeper, and then change the angulation to more medial angulation, so that you are visualizing the lateral border of the vertebral body as well as the lateral border of the pedicle. Now, before we go anterior, especially when a ventral dural decompression is required, it is always better to visualize the superior and inferior facets that I was mentioning about. And also, once we resect that, you will have a transpedicular access to the pathogenic vertebral body. And this is what we are doing here. So you have angulated the tube more medially, you have gone in slightly more deeper than what you had initially docked in, and then you visualize or identify the superior facet. That is the superior facet, and you can do a facetectomy just like you do it in a lumbar case, lumbar MIS T-lift. So you remove the inferior articular process, use a drill to remove the inferior articular process, and once that is done, then you can remove that inferior articular process, and then you will visualize the articular surface and the superior articular process. Now, the entire superior articular process in the thoracic spine, unlike in the lumbar spine, is above the level of the pedicle, and that also can be resected, or that also can be taken out in toto, unlike in the lumbar spine, where you actually try to preserve the part of the superior articular process that is overhanging on the pedicle. So this is something that is done, and once you can remove the superior articular process, you will be visualizing the lateral border of the dura, the exiting nerve root at that particular point. You can remove the bone pieces also a little bit above in order to go all the way towards the superior aspect of the pedicle. Now that same thing again is done for the lower vertebral, lower facet. Now once you dissect or once you remove the lower facet as well, the pathogenic vertebral body becomes completely isolated. You have removed the superior facet and inferior facet, and as you can see, this is the pedicle. The moment you are touching the pedicle also, this is moving because the vertebral body is already unstable. So after that, you identify, isolate the pedicle, identify the medial border of the pedicle, the lateral border of the dura, the lower exiting nerve root, and then you can actually dissect, or you can actually resect the pedicle step by step, either using drill or using bone punches that you can use even in MIS techniques. And then once that is done, you can either, in most of the times, especially in corpectomies, it is always necessary, becomes necessary to sacrifice at least one nerve root in order to get anterior access so that your cage placement becomes easier. Otherwise, the presence of this nerve root can put undue traction on the nerve root, which can get transferred to the spinal cord when you are trying to insert a cage anteriorly. So once that is done, so you can actually identify the upper disc, the lower disc, and go all the way into the vertebral body. And you can see the angle of approach here, where we started vertically down and then angulating medially all the way to reach the contralateral part of the vertebral body as well. Now once this is resected, we should always be careful. So this is the appropriate size cage that will be selected. But we realize that in many cases we are finding difficulty, and that is because we have not removed the lateral vertebral wall. And in many cases it is important to remove that lateral part of the vertebral, posterior part of the vertebral wall, that is laterally, as shown in this diagram, so that our cage insertion becomes easier. You have more space laterally, and your pressure that you are transmitting towards the spinal cord is significantly reduced. And that is what is being done here. And once that lateral space is created, the cage usually goes in. The other problem sometimes is because it's very narrow, your cage is not going to go in directly in a longitudinal axis like we used to do in an open surgery. So it's always becomes necessary sometimes to put the cage vertically down and then turn the cage inside the vertebral body, inside the cavity that we have created. And that is why it is important to create a much larger cavity, do a much wider corpectomy than what is actually necessary to insert the cage. And this can actually be checked. The position of the cage can be checked with AP as well as a lateral fluoroscopic image, as you can see there. And once that is done, then you can do your percutaneous pedicle screw fixation. In difficult cases, in some cases where the instability seems to be very severe, you can always use anchoring pedicle screws on the contralateral side before trying to do the corpectomy on the ipsilateral side. So this is the post-operative X-ray and MRI. So we now have a series of more than 20 cases, and in some cases we have also tried to just put in these expandable cages which have come in nowadays. As you can see there, it is very easy to go in. It is almost like doing a TLIF. You just create that space that is required in the vertebral body. These cages can expand up to 18 millimeters, and that gives a good enough, especially if the body is already collapsed, if the space is very narrow, you can actually get away without putting a big mesh cage in these cases. And these cages are much more easier to insert than the earlier expandable mesh cage that I was showing to you earlier. Thank you so much for your attention.
Thank you, Umesh, for that excellent, crisp presentation. Due to time constraint, we move on to a next talk by Dr. Nidhi Patel. That's the next level of endoscopy, that is multi-level canal stenosis tackling with a monoportal endoscopy. If someone has one question by the time the laptop is being set.
Dr. Umesh, hello. My question to you was, this is actually a kind of PVR, posterior vertebral column reconstruction, the same philosophy. I have always found that when you are trying to put it, it's better to remove at least 2 ribs. With 1 rib removal, it becomes very difficult. At least 2 ribs, then you can push the pleura and go extrapleural, and that bone which you removed later on. Obviously, once the pleura is pushed aside, that can. The second argument is that I do not accept anything is as good as a mesh cage, because in expandable cages, ultimately the bone starts floating inside once the cage is expanded. A mesh cage of the right size gives better results than expandable cage. The moment you expand the cage, all the bone graft is not under impaction. It starts
I
floating inside
completely
the
agree,
cage.
sir. We have moved away from mesh cages and means expandable cages, especially cervical. Even anterior cervical, many people regularly use expandable cages, but
It's eyewash.
I think yes, it's
just temporary,
and
temporary satisfaction.
even if we are filling the bone completely inside, the amount of diameter of the bone that we are filling
very
inside
narrow.
is very narrow. It doesn't give a good enough surface area for fusion.
So
I completely accept that. But these are thoracic cases, and we know in thoracic the fusion happens, quite much more easily. And we have not removed the contralateral facet.
The contralateral facet is intact.
And so that also probably helps in maintaining that stability that is required.
Yeah, because it's just nothing else but a PVR. It's just that the other side has not been done. But definitely removing 2 ribs makes life very simple. Your struggle is finished.
Yeah, sure, I would agree. Thank you.
With the tube diameter, it would become different. Yeah. Yes, Nidhi.
Good afternoon, and thank you, Dr. Ashish Tandon sir, and organizers of this conference for inviting me. And pardon, Goel sir, because though it is a technical evolution, but concepts are really old. So I will just show what we are able to do with the endoscopy. So as we know, with the increasing aging population, we will get lots and lots of these patients, and many of them are actually having more than one level issues, and we know the severity by radiological grading that mild, moderate, severe to extremely severe, and it's not so uncommon. So yes, topic of today's presentation is about decompression and various ways by open MISS and endoscope. So we'll just take case by case. So just showing the first case, that 63-year-old lady with chronic symptoms, with when the symptoms become constant, only then they usually come to see the doctors. And this is how MRI showed at L4-5 schizas grade D and L5S1 also compression. So in a very fatty obese patient, when it becomes with open surgery, definitely the dissection and all is very large. Compared to that, endoscope provides a very just 1 centimeter cut, and with that you can do the decompression. So here is the case. So today morning we have seen that Rakesh sir's presentation, how we do interlaminar decompression. So here I have just finished that, widen my bony window on ipsilateral side from the left side, and just afterwards I am reducing the bulk of ligament flavum, and this is on the ipsilateral side, inferior lamina, and inferior lamina upper edge. I am dissecting, I am trying to detach the ligament flavum from that edge, and you can use the drill or you can use the chisel, and just reduce the bulk of ligament flavum by removing the superficial parts. So it becomes easy when you want to do contralateral work. Usually, initially I was fond of this butterfly technique. I used to remove the ligament flavum in the one bulk. Nowadays I have moved away from that, but yes, the idea is to preserve the ligament till you do all the bone work, so that your epidural space is not, means your neural structures don't get a lot of irrigation pressure, and also the blood does not disturb your field of vision. So, and as and when you get the blood, especially in the epidural space, please coagulate there and then, so you can move on. Otherwise later on you will be just struggling to tackle that clearing the field. So now I have this ipsilateral side detachment is just getting over. This is the move to the cranial side. On the ipsilateral side, the slash portion, the ligament which is going under the pars. After detachment with the curette, you can just cut it with the Carrison. And then we just go to contralateral side after drilling good base of spinous process and drilling, and then you just dissect it with the curette or dissector, and you can use the diamond burr drill. There is thick bulk of ligament, so you don't have to worry about dural injury, and go till laterally as far as you can, so that you can reach the facet easily, and then you detach it, and in the last few you may have to take the Carrison bites, and once you have detached it from all around, all the corners, the most difficult portion is the contralateral lower quadrant, that is quadrant number 4 here, and there you can there you have to see, and afterwards also in chronic cases there will be lot of adhesions, so please cut them with the sharp instruments like Carrisons or cutter before pulling them off, otherwise your whole hard work you will be struggling with another dural tear. So once you are sure that it is not adhered to any of the adhesions, you can just pull it and it will come out in single piece. It's not necessary that you do only in this way, but yes, this is actually little faster, but you should not be struggling and wasting a lot of time. And once that is done, you go back in and just see whether anywhere you need to still do additional decompression. So this is one way to do it, and even you will have the severe cases like this one where you have almost no canal, L3-4 and L4-5. You can see both even laminas are almost touching. When you just rotate your 5 mm burr, it takes bone from both the upper and lower lamina, and even those cases can also be done easily. Once you have identified the interlaminar space, and once you have widened your bony window, then it becomes just easy. Here I am just removing them in 2 halves. After ipsilateral half, then just going to contralateral side, you can see that one small degenerated material just stuck over the traversing root. These are actually some cases where you have to spend little time and just release all these adhesions so that the root becomes mobile and becomes free. So it was not very thick and adherent, so then I could pull it. So this ipsilateral side was root was free. Then just go the contralateral side, and there also you can do the work and make sure both the traversing roots become free. Then only then only there is a point of doing the endoscopic way. Here this is called jumping technique. Like from the single incision, you do one level work and then just come out and make another facial entry through the same skin incision. It is not that difficult actually, and you can easily dock and carry on your work. So there are patients, as we see that there is a lot of stigma in the society. So many patients suffer for a long time unless they become just bed bound, they don't turn up for the treatment. Like this particular patient, 84-year-old lady, was not willing for surgery since she has been advised surgery since 2020, and just she came last year, and you can see 4-5 level, 3-4, 2-3, it was all very tight bad stenosis. Even those cases can be done very easily. This is the 4-5 level on the ipsilateral side, traversing root. You can see the congestion, you can see the clarity of vision in the endoscopy system, the contralateral side. There also you can see it's free, 3-4 level. Till the lateral recess, margin, and contralateral side, traversing root going down below the pedicle into the lateral recess, and 2-3 level. At higher levels, usually the traversing root doesn't lie so up in the canal. So, but yes, sometimes the blood and all will just not be able to give the final good quality picture for the conferences, but it's okay. Just you can see you have done good and enough work, that is enough. This is the post-op MRI. Immediately we can see that decompression has been done and barely any footprint in the muscles. This was done through just 3 tiny skins in 84-year-old lady. So, and patients with congenital bony canal stenosis, they do come early. Like this was the lady of 36-year-old only. She was afraid of surgery because multiple surgeons have suggested her long fixation, and she has been taking steroids. She developed steroid-induced diabetes. She was became almost 100 plus, and since last 3 months, she was almost weekly, twice to thrice. She was taking diclofenac injection, and then finally she turned up for the surgery. So you can see that severe canal stenosis 4, 5, 3, 4, 1, 2, 2, 3. L5 was sacralized. So I was also a bit hesitant how to go about it because I knew that there may be iatrogenic instability chances. So I suggested that we'll go for the 3, 4, 4, 5 level first and see how she improves, and we'll take call based on that. So she agreed. Initially she improved, but after 1 week she returned that okay, I am still having some symptoms. Then we just checked one MRI on 3, 4, and 4, 5. So that looked fine, and then we did the L1, L2 level decompression as well. And L2, L3 is 2, 3 I have not just taken. So this is the end of picture. So you can see the previous 2 incisions have already healed, and this was the recent case, and this was the final X-ray after 4 level bony decompression and ligament lateral recess decompression. So recently, just 2 months back, I had done even 5 level decompression. This was also a patient who had developed bilateral foot drop for 1 month and did not want to undergo open surgery. And neurologist strongly suggested that she has to undergo surgery. So finally they came, and yes, I did this surgery also in 2 stages because endoscopy, my operating time is at least 1.5 hours for at least one level. So I initially planned 2 levels, lower 3 levels and first sitting, and then upper 2 level in the second sitting. Here also that same way you can use this jumping technique through separate facial incision, and patient has by 2 months follow-up now, and she has almost been able to stand up, and power in the ankle has become 2 to 3 with last follow-up. So yes, this we can tackle anything. Endoscopy is just tool. It's all about mastering the handling of the instruments. This is another case waiting for afraid of surgery for a long time, and here 3, 4, 4 and 4, 5. Here on left side there was facet cyst and there was an disc, but symptoms were more on the right side. So we went for from right side surgery, and you can see with ipsilateral interlaminar approach, contralateral side, we can remove even the opposite side foraminal, extraforaminal area disc as well. And this was the final decompression. And you can, it's not only about that. With endoscopy, we are not doing any fixation. It's like our indications have come down, but you can do any fusion as we do with open surgery, like this particular case, 4-5 level disc large cranially migrated disc herniation with instability. This is at the end of decompression from the right side. At L4-5, this is the traversing route. Because we are going to do discectomy, we have remove the facet as well, and the disc bulge which we would be taking out. And this is the end of end plate preparation. We are standing on the right side, so this is the L4, 3 o'clock is the cranial, this is the L4 end plate, lower end plate, and this is the L5 upper end plate. So this is the disc space. We have removed the disc till anterior annulus, nice petechial bleeding under direct visualization. So that's that much disc preparation we can do, and we get a lot of bone graft. And I use the same skin incision for putting the cage. So it's like, yes, you can call it stitchless fusion. So you can do even multiple level decompression, like this case, severely stenotic with instability, you can do it. I did 2-level fusion, so here just are the steps, and this is the end plate preparations, and this is how we put the cage through the same. This was rather use a separate incision was used, and after putting the cage, the final inspection. Here there was some G graft also was put because bone were porotic and did not get good quality graft for 2 levels. So I had in addition nearly used G bone also. So yes, most important aspect is the discussing complications, and yes, I had dural tears. I had 8 dural tears actually, of which 5 happened only in last year. In initial part I had actually less and in last year, but because I think there were case related. One was the revision case which had severe bed adhesions, and that one actually I had to convert it to tubular approach for the dural repair. And rest I had just used the Duragen inlay after root reduction, and 2 smaller roots rootlets without herniation I had just skipped them and no issue. 3 infections also I had, all of them had implant. And neurological deficit, yes, one patient developed contralateral side weakness, that was actually I feel maybe Ronger related pressure, and one on the ipsilateral side with the case with the implant, most likely I feel it could be cage related, some traction would have gone. And the patient which had dural tear which I had converted to open, I earlier struggled for the reducing the rootlet. Patient developed urinary retention post-op, but fortunately after 2 months that recovered. So, but recovery wise I can say definitely patients are very comfortable post-operative. Their recovery will be just like any open decompression. So from my side, learning point for beginners, yes, you have to plan each and every details from the scans. You have to learn the bleeding control mastery for bone harvesting technique if you are going for fusion, and also other complications like instrument failure, etc. And so it's safe, effective. It's easy to start because your anatomical familiarity, but definitely it takes time to master. And if I have to conclude endoscopic after 3 years of experience, I can say it's definitely one of the best technological evaluation in the field of minimal invasive spine surgery because of great view, great anatomical detail, and excellent post-op recovery. And so it is not only limited to only transforaminal discectomy, how it started, but you can do practically anything what you can do with open surgery, like stenosis, decompression, interbody fusion. You can go to lumbar and thoracic and cervical, and even of late IDEMs also some of the advanced surgeons have started. Thank you.
Thank you. Nice presentation, Nidhi.
Thank you, sir.
Thank you, Farid. Now, Dr. Achal Gupta on posterior endoscopic cervical foraminotomy.
By the time he set his laptop, my question is how much maximum irrigation fluid you have used?
At a time in earlier when I had longer duration of surgery, I had at least gone 15 or 16 bottles in a single stage. That would have gone for 7.5 to 8 hours.
Any fluid related complication
I
in your
had
practice?
so far nothing. Only case which had developed deficit where I had dural opening and where I had struggled actually to reduce with irrigation one. But otherwise I don't think irrigation has really caused any cranial issues or any body temperature issues. No.
Okay, thank you.
Yes, sir, that half sleeve we use. That video I showed actually, but I had just rushed it. Half sleeve I use.
Yes, Dr. Ashish. Yeah.
So I have a comment, and that comment is for a lot of you who are interested. So Nidhi came to us few years back, and like all youngsters or any person who's taking up anything new, be it me or anybody, kept on struggling initially. But now it's been about 4 odd years, and we have seen him evolve from like scratch to normal spine to endoscopic spine. So sort of it should give a lot of energy to all of you to, take up MIS. It's not that, there is a learning curve to it, but then you can overcome and, you can excel.
Thank you, sir.
Thank you, Dr. Ashish sir, for inviting me. Respected chairpersons, seniors, and dear friends and colleagues. So today I will be speaking on the posterior endoscopic decompression for foraminal stenosis in the cervical spine. So if we see this is the corridor that we utilize. This is a lateral disc herniation, and this is a foramen through which we remove the disc and decompress the exiting nerve root. So what are the current surgical treatment modalities available for that cervical disc prolapse? One is anterior cervical discectomy with or without fusion, which is the commonly done by neurosurgeons, in which we do the total discectomy, put the graft, put the instruments, and ultimately we do the fusion. So we remove the disc, we remove the motion also. So next is anterior cervical disc replacement surgery. This is a motion preserving surgery in which we do the total discectomy and put an implant. So it has a cost and implant related complications also. So we remove the disc, but yes, we preserve the motion for the time being. So next is the posterior laminoforaminectomy that I will be speaking on. In this, we do the limited discectomy, which is compressing the nerve root, and we don't put any graft or the implant, and finally we preserve the disc and we preserve the motion. So what are the case scenarios or the indications of this approach? First is there is a soft disc, new herniation, and there is radiculopathy symptoms, and patient is not responding to the medical management. Then we can plan to for the posterior cervical full endoscopic laminoforaminectomy and discectomy. Another scenario is if there is a calcified disc and patient is having radiculopathy, or the patient is having foraminal stenosis because of the spur or the endpoint osteophyte, and patient is having one side radiculopathy, then no need to do discectomy, only the posterior cervical laminoforaminectomy is enough to relieve the symptoms of the patient. So regarding the position, typically this operation is being done in the prone position, head fixed to the pins preferably, or you can do in the horseshoe, using the horseshoe. Neck should be in slight flexion position, or can be in the neutral position. Eye and all the pressure points should be well padded, and abdomen should be free. So regarding in the AP view, the two lines should be marked. One is the midline, then second is the mid-facetal line, mid-pedicular line, and then we turn to the C-arm in the lateral view, and then put the spinal needle to the level of our interest. So where we are docking exactly at the V point, where the upper lamina covers the lower lamina and it makes a V. So this is a point where we dock our endoscope and we start doing our work. Our target is to make a V to U so that we get the space into the foramen to enter and decompress the exiting nerve root. So once we do this, we put dilate the fascia, put our dilator, put our working sleeve, and start with the surgery. So this is my first case, patient complaint of the right side C5, right C6 complaint was there, and C5, C6 lateral disc herniation was there. This is the same case. We put our scope inside after careful nail placement. So after clearing the soft tissue, we identify the upper lamina and start drilling it slowly. Make a V to U, and slowly using the hooks, we remove the disc fragments which are herniated, and slowly using our hooks, we remove further fragments. And we have to be careful. We should not retract the exiting nerve root much. And this is how it is decompressed. And this is a small suture that is there, and patient recovers immediately after the surgery. So this is the second case. He was operated earlier at C5-C6 level ACDF, and patient has come to me with the ASD with the symptoms at C5 level and also some paresthesias at C6 nerve root. So first we went to the C5-6 level, and we just did posterior cervical foraminectomy. We can see this inflamed nerve root C6, and after that we jumped to the C4-C5 level. So now this is decompressed, and now we jump to the C4, C5 level after clearing the soft tissue, and we start drilling the upper lamina and make a V to U so that we can see the foramen in the cervical spine. So now you can see the ligamentum flavum down. This is a white ligamentum flavum down. This is protective to us. We can drill the upper lamina, lower lamina, and we can make to V2U, and slowly using the number 2 punch, remove the flavum, see the exiting nerve root. And everything is being done in water irrigation medium, and it is gravity assisted. It should not be more than 40, and we remove the disc, and definitely patient improves and patient is happy, recovered from his symptoms. So this is the post-op CT scan. We can appreciate at C5, C6 level. So this is a C4, C5 level. There is the calcified disc. We just did the cervical laminoformatomy. No discectomy was done. And this was the C5, C6 level, which was having the foraminal stenosis. Again, we did just this much of the decompression, and at 2 levels, and patient recovered. So this is another patient which showed at fresh disc at C3, C4 level, and patient was having right C4 palsy, and we asked the patient for the surgery, but she wanted to wait. We gave the steroids, but after 20 days she didn't improve and consented for the surgery. So this is his MRI. Yes. So after CM fluoroscopy guidance, we put our scopes, clear the soft tissue, make a V2U. You always use the diamond drill so that we can carefully drill our upper lamina foramen and the lower one, and create the space, remove the ligamentum flavum after doing the complete bony work, and then see the exiting nerve root. See, it is quite inflamed. And after using the hook slowly, without much retraction of the cord, so we remove our disc fragments which are compressing the exiting nerve root. So here comes the first fragment, and then this. So as we are moving the fragment, fresh blood is coming out, and don't increase the water irrigation pressure. Just wait, have patience. It automatically will, this irrigation will help in the good control of the bleeding, and this is quite decompressed, and definitely patient improved. So this patient had a C4 palsy, and after 1 month of physiotherapy, after decompression, she improved, and this is her post-op MRI, which shows complete decompression of the exiting nerve root. So till now, I have operated 10 cases. All the patient improved. The most common level was C5, C6, and patient improved in mean VAS and the neck disability index scoring. So what are the advantages of full endoscopic posterior cervical laminar foraminectomy? First is, this is a motion preserving surgery, and there is no major risk to any vital organs like esophageal, laryngeal nerve, any such kind of vascular injury. Patient very short hospital in stay, can be discharged very second day of the surgery, and recovery is very fast, better quality of the life is there. There is no muscle damage, collateral damage almost nil. And my conclusion is, this is a safe and efficient, minimally invasive procedure for radiculopathy. The proper case selection is the key. We should do only the lateral disc herniation with the unilateral radiculopathy symptoms. Cervical laminar foraminectomy is more than enough. Long-term follow-up is required. Thank you.
Yeah, thank you. Thank you for finishing time. We can cover up some.
Yes,
yeah.
sir.
Ankit?
Yes, sir. Yes. So first we start, the first thing is, docking is really very important. We dock at part of the pedicle. There is one. Then first where we land is the upper lamina. Once we start drilling the upper lamina, we'll see the lower lamina. So automatically this V is being made U. That is one. Number two, once we start drilling more upper lamina and the lower lamina, we'll see the flavum down. So these are the ways where we can understand how much we have to drill the foramen. Yes, sir. So till the attachment to the ligament of flavum, superiorly we see till that point I do, and then after that using number 1 or number 2 punch slowly remove the ligament of flavum to see the exiting nerve root. The idea is we should see the exiting nerve root properly, superiorly and inferiorly both. Yes, sir. Yes, sir.
The pedicle, the lower pedicle. So these two landmarks you can see for your drilling, extension of your drilling.
Sir.
Because that will lead to you, I mean, that will allow you to go cranial and caudal to the root and handle it.
Thank you, sir. Thank you.
Thank you. So after the conclusion of this fruitful session, I would request the chairpersons to please facilitate our speakers. Dr. Umesh Shrikant, sir, please. Thank you, sir. I would like to call upon the next speaker, Dr. Nidhi Kumar Patel. Sir, can you please come on the stage? Thank you, sir. And for our third speaker, Dr. Achal Gupta. Sir, can you please come? Thank you to all the speakers and chairpersons. Now I would like to call our chairpersons for the penultimate session for today, Professor Manmohan Singh sir and Dr. Harsh Saxena. Sir, please.
Good evening, everybody. So we are moving forward for the next session. So our first speaker is Professor Deepak Agarwal. He'll be speaking on DRES for intractable pain.
So good evening again. I'll be talking about intractable pain. We have been talking about actually pain only the whole day because pain is the primary symptom. Patients come with any problem of the back, be it lower back pain and cervical pain. And one thing I've realized, you know, Dr. Atul Goyal has been my mentor teacher and I've been following him. And I have seen these patients who come to your OPD, most of them, I would say 80 to 90% are actually having a BMI which is above normal. They are obese. And if you tell them that you please decrease your weight, they say, sir, pain itna hai, hum to chal bhi nahi pa rahe. So they have an excuse for not even trying to even decrease their weight. So I tell them that, look, if you can't even do for yourself the decrease in your weight, then nobody can help you, because whatever we are doing is just a prophylactic, not a palliative thing. And nowadays I've started prescribing them, you know, Ozempic and Wegovy or whatever you want. So I said, if you are not ready to help yourself, spend 20,000 a month. Now the price has come down. But I feel that once the weight decreases, the pressure on the facets also decreases. I think that is a philosophy which is always expanding. And we always overlook, but pain is the most terrible thing. I think for pain, people can do anything. And the one pain I'm going to talk about today is the neuropathic pain because of post-brachial plexus injuries. India is the capital of this kind of pain simply because we have one of the largest two-wheeler populations in the world. And these are the patients At one time at AIMS, we used to get more than 500 patients a year of neuropathic pain. Not all of them will require treatment with surgery, but yes, 500 patients with intractable neuropathic pain. Now with the opening of the plastic surgery department, a lot of them are going there, but the treatment remains very elusive. So what I'll be talking about is microdryotomy using the technique I told about in the morning, micro scissors. And this is a beautiful technique, you know, for alleviating this pain. We have patients who had this pain for decades and wanting to have obviously the whole upper limb cut off, but that will not relieve the pain because the pain is here in the brain. It's a kind of a cortical remapping which occurs. So what DRES actually is, you see these posterior columns, this is posterior, this is anterior, this is the spinal cord, and this is the lateral corticospinal tracts. We have to enter in the zone between the posterior column and the lateral corticospinal tracts. And it's a very elegant technique. This is what I talked about. It was taught to us by Dr. Tiara. He came to us in 2014, so it's been almost 12 years. Sorry about that. So I will just take you through a operative video. So you can see this is a classical pan BPI. What we do is a hemilambectomy. So this is cranial, this is caudal, and we remove only half the lamina on one side. One thing to remember is that the dorsal roots or the root entry zone is much more medial than you can ever think. It's almost on the midline. And it is catastrophe if you go too lateral, because there you will find a lot of venous plexus, and I have seen patients actually die of blood loss because you have gone laterally. So after you go open up the dura as we normally do, and now it's turned around, you can see cranial is on the lower end of the screen. This is caudal, and this is the dorsal root zone, which is seen very clearly. You see a lot of neovascularization out there. You see normal root. This is three roots, and then you just open up with your scissors the pia, which is there between the dorsal column and the lateral corticospinal tracts. And this is a normal sulcus, like you go intersulcal in the brain. It is exactly the same procedure. You go intersulcal, and there is pia actually covering both the tracts. So you can actually see the color change of both the tracts. Unless you do this surgery, you will not realize that how cleanly you can do it and how different tracts can appear inside the spinal cord. Before that, you're oblivious to the whole thing. So look at this. So I'm opening up, and here I'm opening up. You can see the vertical vessels again. Oh, sorry. You can see the vertical vessels. This is the beauty. When you open up, you can see the vertical vessels here, which are going under the pia on either side of the dorsal column. This is the dorsal column here. This is the lateral corticospinal tract. Sorry. And you can see the vertical vessels. These are the small vessels which are going so beautifully. It is like a cadaveric dissection, or like one of those anatomical videos. You can see all these vessels, and you keep dissecting. You're not damaging anything because the pia is there on either side. And you continue doing that, and you continue opening up, and you see the vessels. You continue do it from C3 right down to C7, and I just use the micro scissors. The only reason I use the bipolar is to coagulate the neovascularization which is there, which is overlying it. Otherwise, I never use the bipolar. And at the end of the procedure, you see how beautifully this thing has opened up, like a open book. The two columns have opened up like this, and you can actually see it like an open book. And whole thing from top to bottom, beautifully visible. It is a delight to watch and do the surgery. And when you see this, it looks extremely simple. But the devil is in the details, as previous speakers have. And what I do is, I also mark my scissors. That is another, just a small thing. I mark my scissors, if you see here, 2 millimeters I mark with the permanent marker on the scissor itself. So I know how deep I'm going with the scissors. And it's usually around 2 to 3 millimeters. If you see the diameter of the spinal cord at the cervical region, it is hardly 8 millimeters. So you have a 8 millimeter spinal cord, and you have already, so that means half is 4 millimeters, and you already gone 2 to 3. The spinal canal must be hardly a couple of millimeters away. So we are all, so whatever you read in the books has no meaning, because nobody can see the Rex zones, lamina 5, lamina, nothing you can see. But you know where you're going. You have the sulcus, or what we call the intersulcal dissection, will itself lead to around 1 to 1.5 millimeters. Just another 0.5 millimeters you have to destroy the gray matter, which is supposedly there, because you don't see it with the microscope or the gray eye, and you open it up with the suction. So this is, I don't use any other instrument. So you can see beautifully the whole thing has opened up, then you just close up, and instantaneous result. Patient wakes up and his pain is gone. But what happens is, because the first patient we did, and we asked the patient, how's your pain? He says, it's the same. It has not gone at all. I'm feeling the same pain. So we were very disappointed. And next day we went to him, then we asked him, okay, how is it now? He said it had gone then only, but it took me this much time to understand that the pain has disappeared, because it's been there for decades. So he said, I could not fathom that the pain can disappear. So today morning I'm realizing that it has actually gone. And that patient, the first patient, we have now followed up a follow-up of more than 10 years. And he's still doing, he's a police constable who tried to attempt suicide 3 times because of the pain. So we have done a significant number of 76 cases. We have a follow-up also of the majority of them. It's not all roses, we have an excellent outcome in around 70%, which is very good. And this is long-term outcome, more than 5 years. And but there will be a subset of patients who will have a poor outcome. It could be immediately they don't have, which is a very small, but most of them with the poor outcome will happen, let's say after 3 months, 6 months, 1 year, they will have recurrence of pain. We have another study to show you, but what I want to say is that although this procedure looks simple, it has this learning curve. You have to remember the small steps. Initially, you can have weakness, which is transient, sensory problems, imbalance problems, because the spinocerebellar tracts overlie the corticospinal tracts. So you should never retract the corticospinal side, you should always retract the sensory. So it takes time. But after you've done around 10 procedures, 10, 15 procedures, then this is the complication rate, then your complication rate comes down. But it took me, I'm a slow learner, whatever you might say, it took me 4-5 years to actually get my complication down to a 0 or something like that. So it is a very inexpensive procedure. Anybody who has a micro scissor and a bipolar can do this procedure, a neurosurgeon I mean. So it can be done anywhere. It's not dependent on tier 2, tier 3, tier 4, tier 5. And it is a beautiful procedure for spasticity also. You imagine all your severe traumatic brain injury patient with spastic hands and lower limbs and upper limbs. Beautiful procedure. You do a cervical, the spasticity nursing care can improve dramatically. No need to give any drug. So that's the beauty, just the same procedure. And for lower limb also I do the same dress at the conus. That's a technically more demanding procedure, but I have done it. It is again a beautiful procedure, the complete spasticity. We have patients in which I have done cervical and lumbar dress, and these are patients, with CVJ anomalies, who are spastic, who are quadriplegic, who are stuck with you for years. You do this procedure and the relatives will care, now everything is fine, the legs and hands are fine, but they have spasticity only on the chest and the abdomen. You can't do anything for that. So the advantage of this procedure are many, and I can tell you, for those patients who have a bad prognosis, who have recurrence of pain, we have gone in and it looks like a virgin spinal cord. Just look, the textbook I showed you, looks like that you just operated in the morning. There is no inflammation, no nothing. It's amazing how it happens in the spinal cord that there is nothing happens. It's just like an open textbook. So you go in and you further deepen, go a little higher up and lower, again they will be pain free. And this time maybe for a longer time. So I would say, I would urge all of you to please think about it. It's zero cost, all gain for you also and for the patient also. Beautifully made for India, I would say. Thank you so much.
Yes.
Deepak, that is, recently I encountered one patient who had cut his hand and came with very severe pain, and the result was fantastic. Now I want to ask you one question which is very relevant. Now when you are opening the cord, you are saying, with a very big experience, 76 is a huge experience. Are you worried about, some limb weakness or developing myelopathy and things like that? Because that may be the realest concern in these.
Yes, sir. That's a concern and very good question, sir. Two things about this. For pain procedures, when I'm doing for brachial plexus pain, upper limb is already gone in all these patients. And if you see the fibers, the superficial fibers of the upper limb, the deeper fibers of the leg are actually deeper inside. So chances of damage are negligible. But this is a very important concern when you're doing it for spasticity, because these patients have normal power and the roots are also intact. So you have to be careful. But if you do not touch the corticospinal tract too much, it should not happen.
So I think, Deepak, you remember, I think we were together when Dr. Taira did. Yes. So Dr. Taira is not even just opening, he's actually coagulating. So what he does that in the same sulcus, he's not just opening, he just open with this bipolar and he keeps on coagulating till down. So that coagulation is also at a very minimal level, so that it is that heat is not dissipated. The plan is just to take care of that rootlets, that the root entry zone. So just remain in that plane, you will not damage the patient.
But I don't
Okay. Yes. So our next speaker is Dr. Ankit Gupta, and he'll be speaking on transforamen endoscopic outside in and outside out perspective.
Good evening everyone, and once again I would like to thank Dr. Ashish for having me here. So I am talking on the transforaminal surgery, the outside in and outside out perspective. So actually it is time to go beyond the Camden's triangle, and that is my perspective. So what is perspective? Perspective is the labyrinth of the layers, the precisely crafted layers of our experience, situation, goals and knowledge. And that makes us to think what is wrong and what is right. So it is time to go beyond the Camden's triangle. We have to see beyond the Camden's triangle for these transforaminal surgery. Actually, they are foraminal or paraforaminal surgery, both of them. So because of this perspective, there can be many solutions to one problem, and there has been many approaches being described in the literature. So just skipping. So this is what traditionally we started with, the pioneered by Young and Gore, the inside out technique, where we used to initially start from the disc and then we come out and do our job to decompress the traversing route. But you know, the degeneration is not restricted to disc only. There are a lot of changes into the foramen, paraforaminal areas, the disc height reduces, there is changes in the facet also, and that's why patient can have the pain generator anywhere. And usually in our clinical practice, most of the patient present in the later phase. That is why the foraminal technique or the foraminoplastic technique has to be learned. So why in last 10 years the interlaminar technique has become so popular? Because in transforaminal, the traditional transforaminal surgery, there is restriction of the mobility. We have only two dimension restriction, the axial rotation or in and out movement. Whereas if you use the foraminoplasty techniques, it gives one more dimension to our movement, that is the to and fro movement. So even in our practice, we see that there are difficulties in certain cases while we are operating transforaminally, like in high migrated disc herniations, highly migrated multiple fragments, whenever there is reduced disc fragment, or there is foraminal stenosis, chronic fibrotic disc. They are very difficult to remove by the traditional transforaminal techniques, osteophyte or calcified disc herniations, and whenever there is low-lying root. So we have to be careful in these cases. So beyond Kramben's angle, what I mean about that we use the foraminal boundaries and we broaden these foraminal boundaries and move our area of work from cranial to the caudal area. So that gives us the better accessibility to the chronic changes. So in outside in, what we do is the basic difference is where we land on. So in outside in, we land it outside the disc, and then we work inside the disc. So this is an example of 75-year-old male who had very severe pain, not able to walk or even sit for a moment. And although he didn't have any neurogenic claudication, but you can see here that he has foraminal and extraforaminal disc herniation at the level of L4, L5. So this patient was operated with the outside-in technique. So you can see in this video, these are the foraminal ligaments nicely seen, and ventral to that is the disc surface. So this is the landing area where we can start. So after cutting this annulus, because this is having an extraforaminal component also, the large disc comes immediately in your view. So that's how the disc fragment is being removed first. There were multiple large fragments, and so this is, till now I am outside the disc, I have not gone inside the disc. So we just keep on coagulating the thing. These articulating instruments help you to mobilize your fragment which is lying ventral to the exiting root for the complete decompression of the exiting root. So I'll just move it a little bit. So some more fragments, and then so in this technique what I am doing, I am starting from outside the foramen, then walking in the foramen. So now I am moving and walking towards the foramen. The superior articular process and the junction of the pedicle is being drilled, and that makes me to move slightly inside. And you know, because I am outside, the cannula is not fixed, I can move anywhere. So this is the foraminal component, and now I am removing the fragments from the disc. So these loose fragment has to be removed from the disc, because these are the cause the recurrences. And almost the literature suggests that the recurrence chances are higher in the outside in technique, probably because we leave those loose fragments. Now I have moved inside. Now I am medial to the foramen, and this is typically transforaminal view. We can just cut down these annulus area, and now you will see that there is a hump. That is the hard hump of the annulus. That is the chronic changes. So after the foraminoplastic technique only you can remove this, otherwise it is very difficult to remove these hard annulus. So now I cut these annulus with these punches, the forward punches. Sometimes even you have to drill the osteophyte which are overhanging. So in this case I had to drill. At this point of time, if you have a bendable burr, then it is very good. Otherwise you can do if you are capable enough. So this is drilled, and then you can see the traversing root and the medial to traversing root is quite decompressed here. So then I am moving outside. Then I move. This is the axilla of the exiting root, and here you have a very nice view of both upper end and lower end plate, and a very nice panoramic view of the extraforaminal area, and this is how my the hook is going below the exiting route for the decompression, and that is the exiting route. So in outside out, what happens is again the your starting point is outside, and then you are working only outside the disc and come out. So that is called as outside out technique. So again, I will go with the example. So this is an 38-year-old female with right leg pain having a dorsiflexion of grade 3 weakness. Again, you have a L3, L4 disc herniation with a reduced disc height, and this disc herniation is highly migrated, down migrated fragment lying parallel, just medial to the pedicle. So this is the video. I start from here. My location, landing point is this, the junction of superior articular process and the pedicle, and then this is drilled to expose the traversing route first. So a part of the pedicle, around 2 to 3 mm part of the pedicle, and superior articular process, just to make space to put your instrument inside, we have to make first. So here you can see after drilling, the exiting route is now being seen, glimpse of the exiting route is there. Now below that is our fragment. So just cut the annulus. There is a lot of inflammation in this case because you all know that these, the down migrated fragments or highly down migrated fragments, about 70 to 80% of these fragments are multiple fragments, and they cause a lot of intense inflammation. And that is the reason while removing these, there is bleeding also. So one has to prepare for that. So here also you can see I am removing the multiple fragments. These bendable hooks or the spatulas help you to mobilize those fragments from medial part of the pedicle. So this is the another fragment out. One more fragment is we can see here. There is little bleeding at the lower foramen, so it needs little bit of use of RF. Now I am moving a little cranially to remove the disc fragment at the disc level. Still I am not gone inside the disc, I am outside the disc. This is the annulus and PLL adhesions. You can see quite edematous and adhered. And always see what you are cutting, because in these cases there can be adhesions, and you can bring the part of dura with you in your annulus cutter. So keep on watching what you are cutting. So that's how it is removed. I don't remove PLL in all my cases, but when there are multiple fragments or extruded fragments, migrated fragments, I do cut, because sometimes there are fragments lying dorsal to the PLL and you may leave one of them. So that's how the the traversing route is decompressed here at the disc level, and this is the foraminal level of traversing route completely decompressed. So that's the post-op MRI. But does it really matter where you start? Necessarily not. It doesn't matter where you start. Our ultimate aim is clinical outcome, and clinical outcome depends on how you look at the pain generator. That's why my message to you is it is key. The key is favorable clinical outcome and identification of pain generator. And in chronic patients, it is not only one pain generator. The pain generator shifts from the actual inflammation to the area of the stenosis. And it is not fair to compare the techniques, but choose an appropriate one. And always a freedom of mobility provides better access to the chronic changes. Thank you.
Thank you, Dr. Gupta. The next speaker is Dr. Umesh Shrikant. He will be speaking on minimal invasive spine tumor resection, redefining the techniques and indications.
Well, good evening again. Respected chairpersons, senior colleagues, dear friends. Yeah, so I'm going to be talking about what all is possible as far as minimal access surgery for spinal tumors is concerned. And let me start with a disclaimer. The disclaimer is that the traditional approach that we use, that is the conventional or an open surgery, is very good in achieving the primary objective. The primary objective being the complete tumor resection. But in the process, we almost forgot what it is causing to the paraspinal muscles, and this is one of our case which came back to us almost 6 years after a single level laminectomy for an IDM removal, and you can see the amount of muscle atrophy and the muscle damage that this patient has. And that is where minimal access surgery is coming into the picture, and we all know the basic concepts of minimal access spine surgery, where we try to minimize the injury to the paraspinal muscles and try to achieve the same objective as we are able to achieve in a conventional or an open surgery. Now our journey started almost 13-14 years ago with this kind of small single segment tumors, which are quite easily resectable. You just dock in a 22 millimeter tube, you do a wide decompression, identify the tumor, identify the nerve root going into the tumor, try to preserve the nerve root if it is only few fibers that are involved. Otherwise, you can just do a complete, transect the entire nerve root that is going into the tumor. Either remove the tumor in toto, or you just internally decompress and remove the tumor as it is required, and you can even close the dura intermittently or even sometimes continuously, and that is all that will be there. So more importantly, this, apart from the complete tumor excision, the amount of muscle damage is significantly less. The same thing applies for thoracic tumors, where single segment small tumors like this can be easily removed with just a simple hemilaminotomy using a transmuscular approach and preserving the paraspinal muscles. For meningiomas, we believe that lateral approach with an MIS approach is much better than the traditional midline approach, because these tumors tend to be more anterior or anterolateral rather than posterior. And even in these cases, depending upon the attachments, our surgical strategy has to change. For meningiomas which have dorsal and dorsolateral attachments, usually any kind of a inward movement has to be, or inward pressure has to be avoided, and of course the pressure has to be always towards the outer aspect. Whereas the tumors which are more anterior and anterolateral, we need to create a space more laterally, because otherwise if we exert any inward or even a pulling pressure, the spinal cord can get compressed against the contralateral intact lamina, and that can lead to a further injury. And that is why the tumors have to be pulled more laterally and then removed, and this is one of the examples. I'll just forward it to certain points. The dura is being opened in the midline. As you can see there, you identify the arachnoid plane, identify the attachment of the meningioma, then do an internal decompression, start with an internal decompression, try to identify the superior and inferior poles of the tumor, and then once that is being done, so you try to gradually dissect the tumor from its interface with the spinal cord as well. So this is the internal decompression that is being done, the attachment that is being traced, and you can remove that. So usually what we do in these particular cases is, spinal dura can be easily separated into an outer and inner layer, just like in the cranial. So usually these meningiomas have attachment only to the inner layer, and the outer layer can be preserved. So you can actually remove the inner layer of the dura along with the tumor and leave the outer layer intact, as we are going to show in the later part. So that is the tumor being removed, and that attachment is still there. And so that is the thing that I was mentioning. You can just separate the attachment, leaving the outer dura intact, and that is going to actually prevent us from having a large dural defect which requires a significant amount of reconstruction. So that is the attached portion of the dura being completely removed. So once that is done, again dural sutures are, dural approximation can be achieved, and that is the end result. Even tumors at CV junction, C2 neurofibromas can be resected. Even large tumors like this can be removed. You basically dock on the C2 lamina and then angulate the tube superiorly to visualize the gap between the C1, C2 interlaminar space, and then you resect the posterior atlantoaxial membrane, identify the tumor capsule, do internal decompression, again identified sequential intratumoral decompression as well as peritumoral dissection in order to remove the entire tumor, identify the nerve root that is going inside, and entire tumor can actually be resected in this. And usually if we see for these tumors, if we do a conventional approach, you have to resect them, you have to remove the attachment of the muscles a little bit from the occiput as well as from the C2 spinous process. And this is the postoperative MRI. If you can see, appreciate, the muscles are all pretty intact. We have not removed any of the muscles from their attachment. Large tumors like this in the paraspinal area, again can be resected. I couldn't resist putting Trump. He is the man of the hour these days. So, so you can actually dock in your tube in the lateral paraspinal area and, in the intertransverse space. And then you can, again, with the same principles of sequential intratumoral dissection, decompression as well as peritumoral dissection, you can actually see that is the nerve root that is going into the tumor. And once you coagulate and resect that, the entire tumor can actually be pretty much easily removed. So that, but as I was mentioning earlier, the primary objective is not just tumor excision, and if you can appreciate here, the only difference you can make out is just a thinned out psoas muscle on the side where the tumor was removed, and the paraspinal muscles are all pretty intact in these cases. Now this is one of the cases where a large intrathoracic tumor, patient was actually scheduled for a thoracotomy and removal of these tumors, which is pretty commonly done for these approaches. And this also can actually be taken care with minimal access techniques. So all you have to do, as I was earlier telling with my corpectomy talk, all you have to do is remove a small portion of the transverse process and the rib, and you can actually visualize and put your tube all the way inside the thoracic cavity, and then you can actually angulate the tube in order to identify all the margins of the tumor and resect that. This is a case that we actually did it with under navigation guidance, and post-operative, as you can see, the only defect that we can see is the rib defect which we have excised. Again, we can appreciate the intactness of the paraspinal muscles and complete tumor excision in these cases. But it is not just about the size. You are not just talking about big tumors only. There are sometimes small tumors which pose a significant challenge. So this is one such case where it is straddling the thoracolumbar junction, straddling the facet joint, and you can actually you cannot remove these tumors without removing the facet joint, and ultimately, because it's a thoracolumbar junction, you need to have a unilateral stabilization. So what we have devised, and we have published this as well, is a two-incision approach, a paramedian incision and a paramedian approach for an intraspinal tumor resection, as well as an extraforaminal approach to remove the extraforaminal portion of the tumor. Again, this is a short video. This is the intraspinal paramedian approach. So you can just go in, remove the decompress the tumor. You just cut the tumor and you decompress all the way up to the foraminal level. You just don't go under the facet and try to remove the tumor. Now once that is done, you dock in, you come out, you dock in your tube from the extraforaminal area, again an intertransverse approach, identify the tumor over there, and then you can just pull out the tumor that has been left behind at the foraminal area, and that just comes out. As you can see there, that is the tumor portion that was left behind from when we did the paraspinal approach, and that particularly comes out, and an entire complete tumor excision can be achieved. More importantly, again, as I was mentioning, that is not the complete tumor excision. The only defect that you can make out post-operatively is the small hemilaminotomy defect, and you see the facet joint is intact as well as the paraspinal muscles are pretty much intact. So this is again something. So in cervical, you don't have to actually do that, because the cervical facets, as we know, are quite wide apart. They are more flattened anteroposteriorly. So what you can do in these dumbbell kind of tumors is you can put in your tube in the paramedian approach and then actually angulate your tube laterally and visualize under the facet and go all the way into the extraforaminal area without actually removing the facet. So this is again a small surgical video. This is the intraspinal portion where we are removing the the tumor that is inside the spinal canal. You open up the dura along the nerve sleeve, identify the root that is there, identify the vascular pedicle that is going in, coagulate, cut that, and then you gradually dissect. Basically, we are not trying to put any pressure inside, whereas trying to pull the tumor out into the cavity or into the area that we have created laterally. So now that is the intraspinal portion of the tumor that is being removed. After that, you angulate the tube. So this is, we are working under the facet joints. You have angulated the tube laterally. You are working under the facet joint and gradual tumor excision. And as you can see there, you can dissect the tumor off from the vertebral artery. And at the end of complete tumor resection, you can visualize the vertebral artery, the disc, and the dura is here. So this is where we initially started with the intraspinal approach. Again, complete tumor excision can be achieved. What with tumors which have more extraforaminal extension? Again, in these cases, you can use something of a double incision technique like this, and you can put two tubes, one paramedian, one extraforaminal simultaneously at the same time and start working on both of them together. So with tumors which have much larger extraforaminal extension like this, you can, I'm sorry, this is the old one. So with this, what you can do is you can, put in an incision that is one paramedian, and the second incision just at the posterior border of the sternocleidomastoid, that is around 7 centimeters lateral to that what we have calculated on the preoperative imaging. And again, in these kind of cases, this is the paramedian approach. So you are doing the intraspinal portion of the tumor, you are opening the root, the dura again on the, along the nerve root sleeve, identifying the tumor, internally decompressing it, and then gradually removing the tumor out into the space that you have created without causing any inward pressure on the spinal cord. Once that is removed, you will come laterally, again the same thing, you remove the tumor from the extraforaminal area as much as possible, because the vertebral artery and that part of the tumor cannot be accessed from your extraforaminal approach. So you have to do this from the intraspinal approach itself. And once that is done, you do your dural reconstruction and then use in your dural grafts or something. Once that is done, you can come laterally, extraforaminal approach along the posterior border of the sternocleidomastoid, dock in your tubular retractors. The first thing that you are going to identify is the lateral border of the facet joint and the tumor that you have left behind after you have decompressed the intraspinal portion. And once that is done, you can actually do your subsequent, tumor dissection in the extraforaminal area to achieve a complete tumor excision. In some cases like this, thoracic tumors where the facet is completely involved, again you can do the same thing, with a single approach, single incision with a 22 millimeter tube. You remove the tumor, you resect the facet joint. The tumor is, because you have sacrificed the facet joint, complete tumor excision can be easily achieved. Tumors can be dissected from its lateral interface with the pleura as well. Once the complete tumor excision is achieved, you can actually put in two pedicle screws through the same tube and achieve a unilateral stabilization because you have removed the facet. So this is our data from last year. I think we have added a few more cases after that. And as you can see, even tumors that are quite large in size, almost more than 12 tumors we have operated which are more than 4.5 centimeters in size. We had transient partial neurological deficit in 3 patients, and fortunately all of them recovered over a period of time. So to summarize, minimal access resection is feasible for most extramedullary tumors. Surgical planning, as I have mentioned in individual cases, should be based on tumor extensions, relationship to the spinal cord, as well as that regional anatomy. It's quite safe and effective, and it also offers the proven benefits of minimal access spine surgery in addition to achieving the primary objective, that is complete tumor excision. Thank you so much.
Thank you, sir. Our next speaker is Dr. Lohan. Dr. Rakesh Lohana will be speaking on monoportal endoscopic posterior cervical pneumothorax. आपका इसके बाद है ना?
Good evening, everyone. So the talk has been covered very well by Dr. Achal Gupta. It would be a revision, and open and MIS was covered by Dr. Parthiban. So I'll be talking on posterior cervical monoportal endoscopic discectomy. So basically it's a posterior cervical surgery doing laminoforaminotomy and discectomy using this monoportal endoscopy. Basic concept, it's a targeted fragmentectomy, disc preservation, motion preservation surgery with no need of expensive implant. It's ultra minimally invasive, so minimal approach-related morbidity, minimal tissue trauma, less post-op analgesic requirement, and shorter hospital stay. Selection criteria is very, very important. It's important to revise this. Short, severe radicular pain, not responding to conservative measures for 4 to 6 weeks, focal neurological deficit, and it's reserved for foraminal and posterolateral disc herniation with radiculopathy. Clinico-radiological correlation is must, as brachial plexite is very common here. So ideal candidate is like this: severe radicular pain. On MRI, you would see classic foraminal soft disc herniation. There is no cord compression and large foraminal disc herniation. These are classic indication to begin with. Contraindications are associated myelopathy, central disc herniation, pre-existing instability, significant neck pain. In those cases, fusion is better. Presence of kyphotic deformity, again, fusion is better. So this is first case, C6-7 radiculopathy with disc herniation, not responding to conservative measures. So there was acute soft disc, left C6-7. So we decided to go ahead with the surgery. So as Dr. Achal said, your vertical incision should be at the medial pedicular line at the level of V point. So you marked with a needle, and then 1 centimeter incision is placed. It's a single dilator system, dilator sheath, and you confirm it under CM, and then you get your scope in. So once you put your scope, this is what you would see. So soft tissue dissection is achieved using hemostatic radiofrequency or plasma. And you basically identify, this is V point, this is rostral lamina, this is caudal lamina, this is lateral mass. So maximal you can resect is medial third or medial half of the lateral mass. So you start drilling with a inferior aspect of the superior lamina. The disc is more towards inferior lamina. So minimal superior laminectomy, more of inferior laminectomy. So once your medial part of lamina is done, you take out medial facet using punches, and basically you expose root and the junction with the thecal sac. So that's a root beneath it. And usually there will be two rootlets, sensory and motor, and with a blunt hook you can tease out the fragment. So don't retract, try to retrieve the fragment. And then you take the fragment out using disc forceps. Don't be satisfied with single fragment and search for few more fragments. You will usually find few more fragments. And then you confirm adequacy of decompression with a monopolar hook. And post-operatively, that's incision, complete relief of pain, triceps weakness recovered over 6 weeks. And post-operative CT scan, you can see very minimal foot mark with a excision of the disc. On CT, you can see very minimal bone window excision. Second case, a C5-6 disc herniation with radiculopathy, not responding to conservative measures. As I mentioned, classical foraminal disc is the classical indication. Patient is on prone position with this kind of bolster and horseshoe. So docking is same, medial pedicular line under C-arm, and you confirm in AP and lateral. And that's how you identify this is V point, superior lamina, inferior lamina, and the medial facet. After removing adequate soft tissue and bone clearance, you use blunt hook beneath the root, and usually it is inferior to the root. So you retract the root superiorly, and there will be the disc. You have to check adequacy of decompression at the end point. The root is free. And that's post-operative MRI showing excision of the fragment with minimal footprint. This is the third case, young doctor with a C6-7 disc herniation, and there was here osteophyte as well. So same endoscopic posterior cervical discectomy. What I want to show you here is one can take out osteophytes as well. So you dissect beneath the root, make adequate window, This is soft disc coming out. And I could see some osteophytes as well. So that osteophyte can be taken out with the annulus cutter. So you retract the root with the back side of the annulus cutter and take out the annulus. And you confirm decompression there. So basically identification of weak point is important. This is the fragment removal, and this beautiful view at the end is important. This is how we close. Post-operative protocol, ambulation on the same day, next day discharge, no collar is needed. There are complications, post-op paresthesia, neurological deficit, CSF leak, recurrent disc herniation is a possibility. If you resect too much of lateral mass, post-operative instability is possible. Advantage is unmatched visualization. Smaller incision, minimal soft tissue damage, minimal intraoperative bleeding, shorter hospital stay, less post-operative pain, faster return to work, and basically it's a motion-preserving surgery. Points to remember, yes, there is a learning curve, begin after getting sufficient exposure of the lumbar cases. Case selection has to be proper. Sheath position should be as close to lamina as possible, otherwise you will have to end up taking a lot of muscles. And don't start fenestration till you identify proper anatomy and a V point. And there may be epidural bleed at times, so don't get panic. Just keep patience and use hemostasis with RF. You should be able to go through it and avoid cord retraction at all cost. Complication of myelopathy, post-operative myelopathy is possible. Yeah, thank you.
Thank you, Dr. Rakesh. So our next speaker is Dr. S.N. Madharia. He will be speaking on complications of endoscopic spine surgery.
Should I take it out? I thank the organizer and chairperson and the Goyal sir, who is my mentor, teacher. We were working in the lab for 8 hours, 10 hours, whole night in 90s. And my skill in spine surgery and brain surgery I dedicated to him. I'm just talking, almost everything has been taught regarding complications, just summarization, nothing more than that. I started endoscopic surgery in 2006 with this Tendu technique. Then gradually foraminoscopic, then intralaminar. Just to review the incidence and type of the complications, as we all know, complication is always with the surgeons. It is initially little more, with more experience, more exposure, more learning, we reduces the complications significantly. So most of my slides are almost more than 10-year-olds. So just compared to the technique, unilateral, naturally unilateral approach, less compared to the bilateral or biportal. Just brief in the management and reduction in the Indian practice. And just brief on my cases. Overall complication rate, all endoscopic is around just 2.13. Reoperation rate is not available. Unilateral, biportal endoscopics, little more. Biportal it is almost more than that. Endoscopic open surgeries, open having the higher rates compared to the endoscopic. Common complication we all know is the dural tear. Initially we are afraid of. In 90s we don't have glues and even good patches, nothing was available. So that time we are always more worried about the dural tear. With the advent of that time we have so many sutures material, patches, dural glues, so it becomes much easy to handle it. Similarly, the hematomas, initial incidences were very high. We don't have the good bipolars. Now, with this, it has come down significantly. Nowadays, one more thing, it is not written is the infection. Infection is the most dreaded complication in any kind of the spine surgery, I always says. So preparation is most important in the patient selection and the preparation of the patient preoperatively important. So dural tear is almost 2.2 to 4%. Most frequent in UBSS, stenotic cases. Just epidural hematoma in biportal is little more. Incomplete decompression in initial stages, particularly in biportal cases, and that it depends on the case selections. Nerve injury is also little more in initial days, and transient dysesthesia in most of the cases with the severe compression. So risk factor is lumbar canal stenosis, more dural tear versus the disc herniation. Bilateral decompression, as I already told, this is more the bony resection, chances of hematoma is more. But because of the good plasmas, bipolar, we can reduce it significantly. Even nowadays we can use bone CUSA, and that significantly reduces the neural injuries. Learning curve, it always experience and always have relation with the complication rate. Rare complications, these are noted particularly in 2-tier cities. Almost 1 or 2 cases I am managing in a month, that including subarachnoid hemorrhage, pseudomeningocele, pneumocephalus, seizure. Just now I had case of the meningitis, stroke also coming after the surgeries. Nowadays, number of the neurosurgeons this time in their experience and the teaching standard, I also think has significant meaning, because whenever there is a call, neurosurgery is going with the instrument, drills and mic and endoscope, and just doing the surgery and coming out with, they doesn't have follow-up to the patient, and patient is landing in the trouble. Where they are operating, what was the post-op care, nobody is bothered about that. This is my experience in my cities. I always said it is difficult to get the carpenter rather than getting the neurosurgeon. You will get neurosurgeon within half an hour. Good carpenter will take almost more than 4 days to get it. This is the condition. They are keeping the instrument, drill, endoscope, going there, wherever they are operating, and then leaving the patient, don't know. And that is another reason why we are getting more number of the complications. In my cities, already two colleges, MCH course are going on. Hardly any there is cadaveric dissection or training, just coming out in static practice. In we were almost 30 years back, we have to go to a micro lab, learn from legend, we have to endure the time. This was the, we have to go to postmortem. I think in my days I have done more than 100 postmortem. This I am talking about the 90s. But now scenario has changed. So we have to be careful while we are the teacher or DNB teachers, how to train the people. Because ultimately they are experimenting on our own, one of the relatives may become in culprit for them. So management is most important in the teaching. We have to be, most of our age group surgeons are the teachers, so always worried about the teaching part. Complication, autogenous muscle, this is in case of the dural tear. Autogenous muscle fat graft is best with the fibrin glue rather than using the artificial one. But these are the new material available to us. But if there is root prolapse, then it is always indicated to reposit it and repair the dural tear. Whether you are doing with the tube or by open method, immaterial, but we have to reposit the root. Otherwise, patient has severe radiculopathy. Postoperative epidural hematoma is common in biportal endoscopic, more in revision surgery. So, good quality bipolar is very important in these cases to maintain it. Gelatin, thrombin, matrix sealant are commonly used to prevent the postoperative hematoma in cases. In transforaminal surgery, exact site of the landing is important. And with this, we can complete the surgery very nicely and avoid the complications. Retroperitoneal hematoma, if segmental artery branch is damaged, particularly for endoscopic surgery, then you may require to open and control it. It is very torrential bleeding in that cases. To prevent, insert the needle to the relatively safe avascular area, and that is always required some cadaveric courses. As Dr. Dandon is told, it is very important, and he is managing that one every year. This is a nice sufficient hemostasis with the radiofrequency electrocautery before leaving or completing the surgery. Post-operative anesthesia is very common, particularly if you are using large size of the endoscope, rotating route more. I'm more common with the inferior migrated disc. Foraminoplasty to widen the safe zone, that is important. Appropriate landing, appropriate angulation according to herniation site. Incomplete decompression entirely depends on the type of the instrument, surgery, and experience of the surgeon. So, precise planning, proper surgical maneuvering, placement of the cannula, these are the important to prevent. I am going fast little. This is how to land. We can have a little larger bevel shape cannula for the large disc, proper placement and removal, epidural pressure. This is important in endoscopic. In some cases, high pressure pump are used for better visualization. In that cases, chances of increased epidural pressure and volume hopper load is also noted. In my experience, initial days, only 3 cases dural tear, infection 4 cases, instrument package in 1 cases, just free. Sorry. If you are not using more commonly this kind of the cautery where this was broken up, it is required me to go with the tube and remove it. This is one case I want to say it. For a endoscopic surgery, where there was calcified disc compressing with boil bladder involvement. This is almost 8-year-old video. Decompression was done adequately. Only few calcified parts are attached with the anterior dura. Then suddenly there was, everything was going nicely, completely dural tear. And once there is dural tear, it becomes very difficult. We have to reposit the root, seal it. I was able to reposit it only because of the adequate decompression. Otherwise, one of the my fellow has shown this is post-op patient. So in Indian scenario, I always emphasize on the level of the teaching and cadaveric dissections. So dural tear is the most common in 2 to 4%, but overall say management prompt recognition is the key point, and future is more randomized control trial studies is needed for that. Thank you. Thank you.
I know you are tired. I know it is the end of the day. I know you don't want to listen too much. And I also know that you know that once I start, I will not stop. But believe me, I will try to do my best. Okay? Again, I come with my slide. Charlie, you are seeing this slide? You have to come for this, okay? So this is the ACNS meeting which I am organizing in Mumbai, and I invite you all. So I give you a concept that brain tumors are confined. So whatever is beautiful is protected. You see this palace, inside what is there any palace, or is some queen is there, or some king is there, whatever, but this wall is protects. See the huge wall, what is happening inside, nobody knows. As long as this wall is protected, inside people are protected. So this is the Great Wall of China. So what is happening on the other side, now of course the matters are different, but this is a huge wall with protection, with guns and all those things in these places. What is happening outside and what is happening inside, nobody knows. Line of actual control between India and China. Line of control between India and Pakistan. What is happening in Pakistan is happening in Pakistan. But if you try to cross the line of control, then you are in trouble. So don't try to cross the line of control. So this is Taj Mahal, and if you have seen it properly, there is a big line of control. And there used to sit some police officers and security, and nobody used to transgress this line of control. So it can be barbed wires like this, or it can be natural protectors. So this is the screen or parda. As long as your parda is on, no matter what is happening to your face, is there any dimple or any pimple or any ugliness, the parda has to be preserved. So what is the human curtain or human sacred wall? That is the dura. You know, dura matter, dura mother. During the COVID time, there was lung infection, this infection, that infection, but no meningitis. Have you heard of meningitis during COVID times? Because of this firm membranes which did not allow any bacteria to enter. So there is no hole in this dura. The dura, as the arteries enter, they take the dura with it. As the nerve exits, they take dura. So there is no hole in the dura. And these membranes, partitions and all those things. So when we operate and we create a rift in the dura, we have to use a vascularized pedicle flap. And there are temporalis muscle and various flaps. And we have to reconstruct the skull-base divide. There are several articles of mine. And this subgaleal fascia, this layer we introduced, this term we introduced first time. And there are various flaps, vascularized flaps, that we described. This is muscle fascia flap, this is this is split cranial, pericranial flap, this is long subgaleal fascia flap, this is multilayer flap, and several flaps. And this is reconstruction of the using the mucosal flap, outer layer dura flap. So membranes have to be respected, and membranes are the mother. That is why we call them dura mother, paya mother. So this word dura mother is from Arabic word, Arabic. Alum al-dimag means meninges are the mother of brain in Arabic. So when I used this word first time, I used this sentence about 35 years ago. And you know Sam El-Mefti, Charlie, was sitting in the audience and he came and hugged me. He said, no Arabic fellow has ever found out this word. So this was the word from Arabic legacy. So dura is durable, and there is no, there are several beautiful articles that you would like to read, maternalizing the meninges. So I will quickly, briefly summarize how you can reduce your exposures in skull-base surgery. This is in 1996, this is the cover page of my book. And if you realize my exposures, you see carotid artery exposed, gastrin ganglion exposed, facial nerve mobilized, carotid mobilized. So these is my cover page. So I was heavily in exposures during that time. But of course, over the years, my exposures have become less after we have understood the anatomy, understood the entire processes of mother and mother dura. And from 30 or 35 years, there are several articles of mine in the literature, this is 1998, as to how the dura and the tumor and carotid artery and the tumor, this relationship matters. Like here, if you see carotid is encased and squeezed. Here it is encased but not squeezed. Here it is displaced. How it matters during surgery. So this is a beautiful article which was published in 1998. More important and most important in skull-base surgery is to have experience in operating. More you operate, and fortunately for me, I have worked in heavy, public institutions all my life, and this gave me an opportunity early. This is 33 years ago I did this case. Can you imagine carotid, PCOM, carotid, and see my craniotomy and basal cuts and all those things. So it gave me huge opportunity to do several of these very complex cases, which I continue. This is my passion, as you know, and as you have realized. So extradural approach to intracavernous sinus tumors. You see, we know vincodolens described for vascular lesion, anterior clinoid aneurysm, cavernous aneurysm, vincodolens. But this was the first article in PubMed and internet which described tumors. This tumor, can you guess what tumor is this? This is the most vascular tumor of the body. It is the most benign tumor. This is cavernous hemangioma of cavernous sinus. In 1991, I published this article. This was the first article in the literature which showed preoperative and postoperative resection. Never before a picture was shown in the literature. Now this tumor is benign and completely within the walls of mother dura. Completely. No matter how big it becomes, it remains within the confines or arms of mother dura, towards the intercavernous sinus, towards the Meckel's cave, towards the orbit, encases the carotid artery within the mother dura's hands. So we described in 2000 extradural approach to these tumors. Now many people are doing this, but this was we described for the first time, and there's no question this is the most beautiful approach for these very complex, dangerous tumors. Sometimes I like to say that we revolutionized pituitary tumor surgery. Now you will ask me what you have done so to revolutionize. So that is briefly I will try to show you. And I have no, even if it looks quite, aggressive and all, but there is no question we have revolutionized it. So pituitary tumors can grow to various sizes and huge sizes. अरे भाई साहब हो गया क्या टाइम हो गया मन So this is a little bit difficult situation, but okay, let me just quickly show you. The dura of the diaphragm cell is elevated on the dome of the tumor. This was never described. Earlier the description was there is a hole in the dura. Jules Hardy described there is a hole in the diaphragm cell and this part of the tumor, this dumbbell tumor, is subarachnoid in location. So we described that the diaphragm cell goes up. Diaphragm cell goes up and this gives an opportunity to remove this tumor. Even if there is a nubbin, the diaphragm remains intact. There is a nubbin here, the dura remains intact. If you have this information, you can use it endoscope. If you don't have this information, you use any approach, you cannot remove it. Cavernous sinus invasion grade 2, the lateral dural wall remains intact, diaphragm remains intact, diaphragm, dura. Now another beautiful thing you will see is elevation of dural roof of cavernous sinus, elevation of diaphragm, elevation of dural roof of cavernous sinus. So this tumor is intradural. You see this, and very rarely the tumor goes beyond the diaphragm and encases this. So this is my classification: grade 1, grade 2 when it goes in cavernous sinus, grade 3 when the dural roof is elevated, grade 4 is when the arteries of circle of Willis are encased. And I have no hesitation to say this anatomical understanding was never there in the literature. And if you have this, whether you use endoscope or whether you use whatever scope, there is no scope for any scope. There is scope for only understanding that there is diaphragm, you remove it, the diaphragm will fall down. So these tumors, learn the art of breaking the tumor, learn the art of demolishing the tumor. In 15 minutes you should remove this tumor. If you take 2 hours, then you don't know pituitary tumor surgery. This is uterus, it will push the baby down. Uterus is the strongest muscle of the body. Do you know that uterus is stronger than your bicep muscle? And no horse or donkey has ever been done by caesarean section. Only human donkeys are removed by caesarean. So this uterus is strong and uterus pushes the baby down. This is, even if it goes this way, even if there is a breech delivery, you can get this tumor to deliver. You see this tumor, I removed it 25 years ago by the understanding that the diaphragm is intact and you can remove this tumor like that. This tumor I removed 27 years ago. Just anterior wall, break the tumor, break the tumor, break the tumor, the diaphragm will fall into picture. This is post-operative. Cavernous sinus, how to remove. Roof of cavernous sinus, how to remove. These are different issues and dangerous issues. How to remove this tumor, whether to remove this tumor, and what are the issues in this tumor, grade 4, are another chapter of neurosurgery. So this is pituitary tumor. Trigeminal, should I go one more or what do you think? Okay, let me quickly, Ashish, you give me permission to show a few slides at least. This article is the most highly cited article in trigeminal neurinoma, most highly. You will ask me why. This was the first article which said that tumors arise in the Meckel's cave. Second thing is the first article which described that these tumors are intradural. Third thing, this was the first article which said that you can improve the trigeminal function after this tumor resection. Can you believe this? 1995, I did this tumor without a craniotomy. So minimization, the issue which Ashish was discussing is how to minimize your approach. Understand these tumors, understand the dura of this tumor. I removed this tumor in 1995 without a craniotomy, just widening. I removed in 1994, 28 years ago, this tumor without a craniotomy, just widening the foramen ovale. Without craniotomy, I removed this tumor. Of course, for these tumors, we describe various other approaches and how to remove and what to do. Even when the tumor has extracranial extension, it is intradural. Even when the tumor recurs, it is within the dura. Third nerve tumor are dangerous skull-based tumors. They remain within the dura. They arise in the oculomotor cistern here. And when they grow, they are covered by dura. It is not capsule, this is dura. If you have this information and do not remove the capsule, you can save the third nerve. 7 nerve are interdural. These tumors are height of skull base tumor surgery. You can take 10 hours or 15 hours to operate, but these tumors do not need more than half an hour to operate. If you know that this is arising from the geniculate ganglion, this is facial nerve neurinoma, make a small cut, work within the dura, and you can do a very quick job. Facial nerve tumor are within the dura. Interdural. Lower cranial nerve. You see, nobody has really understood lower cranial nerve tumors. Have you heard about interdural strategy? If you know this interdural, if you know that the whole thing is within the dura, have a lateral exposure, open the dura and work within the dura. This article of mine was the first article in the literature where we said that the lower cranial nerve function can be improved after operation. Never discussed before. So I think somebody was talking about C2 neurinoma, but unfortunately Umesh was talking, or whoever was talking, but unfortunately you did not read my article. You know, of course you use technique, you use technology, but philosophy is so important. This article of mine, you see this in 2008, I described C2 neurinomas can be like this. Within the dura, and this is intradural. On the basis of 60 cases I described in 2008. In 2018, I changed my concept that even this part is interdural in location. And you just make an incision on the lateral wall and without a laminectomy. So I did this case without any bone work. And I showed one, I was operating from KEM hospital, and the thing was relayed live in London in a skull base course. And I did this operation in exactly 15 minutes without any bone work. So understand the dura, limit your exposure and make a quick fire time. So this is C2 neurinoma, exactly similar. This is the largest ganglion of the spine. Gastric ganglion is the largest ganglion of the cranium. So they are very, very similar. Chordomas, nobody has really understood chordomas. Chordomas arise from bone. They displace the soft tissue. Carotid is displaced anteriorly. Gastric ganglion and cavernous sinus is displaced superiorly. Do you know where the sixth nerve goes with chordomas? Nobody has talked about this. The sixth nerve divorces from the carotid artery and comes with his brothers and sisters and goes over the dome of the... So the sixth nerve, this distance becomes larger in clival chordomas. So this is another beautiful article. On the basis of this, we minimized the approach and described middle fossa subgastric ganglion approach for these. Recently, we have described supracerebellar approach for clival chordomas. You see, you can come from the nose, you can come from lateral, but if you come from here, the sixth nerve is on the dome. Sixth nerve you can identify early. You can come from this direction and attack this tumor and remove this tumor beautifully. Like this tumor, you see, this is supracerebellar approach. Nasopharyngeal angiofibromas are not only extracranial, extradural, but also extracranial, and you can have a beautiful plane of dissection for these tumors. I described this transcranial approach in 1994, but now I do only extended middle fossa, extended maxillary approach to remove this tumor. Cavernous meningioma is another chapter. I don't want to take too much of your time, but believe me, meningiomas arises from meninges. Meninges are the mother, tumor of the mother, and it requires motherly affection. So thank you very much.
So the last speaker of the day, Dr. Rakhi Gupta, and she'll be speaking on cervicogenic headache and cervical interventions.
Respected chairpersons and fellow neurosurgeon colleagues. My topic was cervicogenic headache and occipital neuralgia and cervical interventions, but because that was covered yesterday, interventions, that is why I have chosen occipital neuralgia as a topic. And thank you, Dr. Ashish, for the invitation. Okay, so I'll be dealing with 4 cases of my OPD, they were diagnosed and how they were treated. So first is a 29-year-old female, chronic one-sided neck pain radiating to the occipital and ocular area, lasting few hours, variable intensity, aching in character, started after lifting heavy weight on the head for the past 2 years. Occasional dizziness, swaying kind of a sensation lasting for a few minutes every day. No nausea, vomiting, phono or photophobia. There was tenderness on deep palpation of the left upper facets, no tenderness at occipital nerves, mild restriction and extension of the neck. Multiple consultations done, no long-term relief. Other joint examination was normal. MRI showed mild degenerative changes. X-ray showed loss of cervical lordosis. Provisional diagnosis of a cervicogenic headache of facetogenic etiology was made after extension injury. Intervention which was planned was diagnostic USG-guided torn third occipital nerve, which was a supply to the C2, C3 joint, and C3 median and C4 median branch block was done, USG guided, and patient reported 70% pain relief. Now radiofrequency ablation of the same nerves are planned. This patient came just 3 days back, so USG guided approach was done, and now RF is planned. Another was a 40-year-old male complaining of chronic left-sided neck pain radiating to head after a road traffic accident. The presentation was almost the same. The diagnostic block and RFA was done. The patient reported 80% pain relief. So these are patients of cervicogenic headache, which is caused by a disorder of the cervical spine and its bony component disc or soft tissue elements, usually but not invariably accompanied by neck pain, usually female predominance in the middle age. So the magnitude of the problem is substantial. 15 to 20% of the chronic headaches are these headaches. 70% are misdiagnosed, and so leading to ineffective treatment approaches. 40% treatment delays. Average month before correct diagnosis is 15 to 23 months. So the IHD criteria for cervicogenic headache is any disorder or lesion within the cervical spine or soft tissue of the neck known to be causing headache. And effect of causation has to be there, where headache has developed after the neck cervical disorder and improves with the resolution of the cervical disorder. Cervical range of motion could be reduced and headache will be made worse by provocative maneuvers. And it is abolished by a diagnostic block of the cervical structure. Pathophysiology of this encompasses the upper 3 cervical nerves, 1, 2, 3, which whatever nociceptive structure is being innervated by these nerves, a dysfunction of that can lead to cervicogenic headache. Along with that, there is a presence of trigeminocervical nucleus at the upper cervical spinal cord, where the afferents of the trigeminal nerve and the cervical 1, 2, 3 nerves are convergent. They converge. So that leads to the radiation of neck pains to the trigeminal territory and vice versa. Along with that, like any chronic pain, there is central sensitization, which amplifies the pain signals, expanding the receptive fields. The reasons could be many, and these are mostly it is a whiplash injury, facet joint dysfunction, disc disease, AO or AA disease, joint dysfunction, and mostly now myofascial trigger points in cervical muscles. So the most common differential diagnosis of a cervicogenic headache is migraine and tension type, especially migraine without aura. And the characters of cervicogenic have been already told. Migraine is a usually pulsating, throbbing, can be bilateral. You're located at the temples, frontal, occipital. May be associated with nausea, photo, and phonophobia. Tension headache is a pressure band-like pericranial muscle tenderness, bilateral circumferential, with stress-related triggers or muscle tension. For algorithmic approach, once you are suspecting cervicogenic headache and have excluded the red flags, and there is no pressure pain on the occipital nerves, then, and there is pressure pain on the cervical facets, then selective diagnostic block of the nerve supplying those facets needs to be done. If there is more than 50% pain relief, you should go for a radiofrequency ablation of the median branch. If there is no relief, then consider pulse radiofrequency of the cervical DRG of the C2. Clinical evaluation is almost the same as presented in the case history. A special mention about the third occipital headache. This third occipital C2, C3 facet joint is the most common cause of cervicogenic headache. And that is why the nerve supplying it is the third occipital nerve. That is why the name has been given third occipital headache. It is a transition zone between the upper cervical joints, which are anterior to the intervertebral foramen, and the lower facet joints. And that is why it is the most likely joint where whiplash related disorders can occur. So a mention about the cruvi-hilionar plexus. It is the connection among the C1 to 3 sensory branches, and the connection of the upper back muscles are also supplied by variable C1 to 3 branches of these. C2-3 facet joint is also innervated variably. Maximal cases, only the third occipital nerve is there, but a twig from the C3 medial branch or a twig from the greater occipital nerve can also supply the C2, C3 facet joints. These neural interconnections can affect the therapeutic results of cervical, muscular, and facet denervation procedures. Third is a case of a 65-year-old female, chronic bilateral occipital pain occasionally radiating to forehead for the past 2 years, comes in episodes, sharp burning character, increased by lying down on brushing hair, no nausea, vomiting, photophobia, phonophobia. Mild relief whenever neuropathic pain medicines were prescribed by physicians. The VAS was 5 to 8. On palpation, discomfort overlying the gone nerve at occipital present, greater occipital nerve, concordant with the pain. In investigations, brain and cervical MRIs were normal. Ultrasound-guided diagnostic gone nerve block was done at suboccipital compartment, where there is most likelihood of the gone nerve to be entrapped between the muscles. Patient reported 100% relief. Posture correction was advised, and patient was discharged. At the same time, some amount of steroid was also given. If the patient comes back, the radiofrequency ablation of the greater occipital nerve was planned, but the patient is not still back after 8 months. According to IHS criteria, occipital neuralgia involves paroxysmal shooting or stabbing pain in the dermatomes of the gone or the lawn, mostly gone 90% and lawn 10%. It is originating in the suboccipital region, spreads to the vertex, upper neck and back of head, and can also go to behind the eyes. Etiology can be varied: whiplash, vascular compression, sol, and myofascial entrapment. History is the same as the patient presentation. Pain can also be perceived in the retroorbital area. Vision impairment, ocular pain, dizziness, nausea, congested nose can also be present because of overlap of the sympathetic nerves also in this area. Okay, tingling can be evoked by light pressure or percussion on the nerve. Tinel sign can be positive. As soon as the patient lies down on the pillow and there is hyperextension and rotation of the neck, the pain can be reproduced. So this is the second one, is the occipital pattern, where the neck pain goes till the retroorbital area. And the fourth one is the cervicogenic pattern, where the neck pain along with the shoulder pain can occur mostly, and subtle radiation to the occipital and forehead area can be there. Algorithm is, again, you do a positive test block, then consider pulse radiofrequency of the occipital nerve if long-term pain relief is not found. Otherwise, if some short-term relief is found and pulse RF is also not working, occipital nerve stimulation can be tried. Regarding anatomy of the gone and the lawn, gone is apart from the dorsal ramus of C2, lawn is apart from dorsal ramus of C2 and sometimes C3. They come in the suboccipital compartment overlying the occipital's oblique capitis muscle, and go superficially beyond the superior nuchal line at the level of the external occipital protuberance. That is the area where percutaneously, without any guidance, we can block the nerve at the area of the external occipital protuberance. But usually, for therapeutic purposes, we need to block it at the suboccipital compartment. That is done USG guided in this manner, where you identify in the A diagram, we identify the occipital protuberance and the atlas, and then we go down with the ultrasound probe. We see the bifid spinous process of C2. Then we tilt the probe and locate the mastoid process, and then we can see the obliquus capitis muscle and the semispinalis capitis. The occipital, the greater occipital nerve is located where the yellow arrow is there. And caution has to be there. Under vision only, these blocks have to be done because the vascular structures like vertebral artery are nearby. The last case is an 85-year-old male. This diagram is not of this patient. This is just an internet picture. He had a history of cervical fusion from occiput to C3 to C4, probably due to upper vertebral collapse, which was told to me. by the relatives. Complaint of severe sharp shooting in the post-auricular area, neck area. Limitation of neck movements definitely was there because of the fusion. On neuropathic medicine, side effects a lot. He had a history of fall even, and a severe relenting pain. Successful greater occipital nerve procedure was done elsewhere, but no relief in lawn. As you can see, there is no space that the ultrasound will be able to, the waves will be able to go because of the instrumentation. Tinel sign was positive for lawn distribution. So the planning was procedure for hydrodissection of the lawn done at the neck level, followed by RFA. So the sternocleidomastoid and trapezius, in between them, the lawn emerges from the posterior margin of the sternocleidomastoid. And that was the area which was targeted for this person, because peripherally even you can ablate a nerve. So the main differential diagnosis in this topic were occipital neuralgia and a cervicogenic headache. Neuralgia is a neuropathic pain, and cervicogenic headache is a nociceptic manifestation of upper 3 cervical nerves. Occipital neuralgia is sudden shock-like pain, scalp hypersensitivity, eye involvement with tearing, and trigger points. Cervicogenic headache, dull persisting pain, restricted cervical range of motion, worsened with neck posture, associated neck muscle tension. Cervicogenic and occipital neuralgia often underdiagnosed and untreated due to considerable overlap from the primary headaches like migraine and tension type, and due to stringent diagnostic criteria like diagnostic blocks. Usually unilateral, more common in females, associated with reduction of range of motion of the neck. Clinical examination, diagnostic interventions help to arrive at a diagnosis. These are my references. Thank you. Thank you, sir.
And with that, we conclude our this day's session, and we'll meet at the dinner.
I would like to call the chairpersons to facilitate our speakers. So kindly come on stage. I would like to call Dr. Rakhi Gupta. Ma'am, please come on the stage for the facilitation. Thank you. Now I would like to call Dr. Ankit Gupta. Sir, kindly come on the stage. Thank you, sir. And at last, I would like to call Dr. S.N. Maderia, sir. Sir, please come on the stage for facilitation. Thank you, chairpersons, and thank you all the faculties and delegates. Just to inform all, the dinner is at rooftop at 8 o'clock, and tomorrow's session is at second floor. Thank you. Sir, tomorrow's session will be on the second floor of the same hotel. Second floor, not here. Thank you. Kindly, can everybody please gather for a group photo?